all a warm welcome to second day of International Conference on SRS and SBRT. I hope you all are eager for another day of enlightening discussions and insights. I kindly request the moderators to welcome the speakers for the upcoming session.
Thank you. Good morning, everybody. It's a pleasure to be here. Alma mater for me.
I kindly request the moderators to welcome the speakers for the upcoming session.
This is going to be a very interesting session, a very common problem, everybody. And it's a pleasure to be here. That has intrigued both neurosurgeons and
I
radiation
kindly request the
oncologists
moderators
for a long
to
time.
welcome the speakers
May I
for
call
the
upon the
upcoming
first
session.
speaker,
is going to be a very
Professor Sridhar from Chennai, who will be speaking, who will be giving us an overview on vestibular schwannomas.
both neurosurgeons and
I
radiation
kindly request the moderators to welcome the speakers
May I
for
call
the
upon the
upcoming
first
session.
speaker,
is going to be a very
Professor
Good
Sridhar
morning,
from
everybody. Greetings from Chennai and from the Neurological Society of India. This works. So, vestibular schwannomas have been called variously. They've been called acoustic schwannomas, acoustic neuromas, and then currently being called vestibular schwannomas. They arise from the Schwann cells over the vestibulocochlear nerve and form a major proportion of the tumors which lie in the CP angle. So this is basically the anatomy of the CP angle. You have the pons, the cerebellum, and then the middle cerebellar peduncle, which connects them, and then you have three neurovascular bundles which get associated with the vestibular schwannomas. Oh, it's not seen in that. It's okay. So, which is what we are concerned with the middle one, which is the vestibulocochlear nerve related to the ICA. Now, what is important to understand, especially surgically, is the anatomy of the facial and the vestibulocochlear nerves. Both, does this work? Ah, yes. No, it's not working. In position in the internal artery meatus, and the complex actually twists around as it reaches the brain stem. And this is a very important anatomical fact that one has to understand when one is dealing with vestibular schwannomas, especially surgically. There is a substantial geographical variation in the incidence of these tumors. It seems to be lowest amongst the Black and Hispanic populations and highest amongst the Caucasian populations. Somebody is moving that mouse for me. No, leave it. But these differences may be due to genetic and environmental factors, and VESA has different diagnostic practices. But what is important is that we need to have improved screening protocols, especially when there is an asymmetric hearing loss, and we need to have better advanced imaging with improved MRI to have an early diagnosis. The pathogenesis of these tumors is due to an inactivation of the NF2 tumor suppressor gene, but we also have epigenetic mechanisms and mutational events which happen. There are many other genes which are also thought to be involved in these tumors. It was formerly thought that these tumors arise only from the glial Schwann cell transition zone, which is known as the Obersteiner-Reidlich zone. But now we know that it can arise from anywhere along the 8th nerve, most commonly coming from the vestibular part of the nerve, but 20% of the cases can arise from the cochlear part of the nerve as well. Just a word about NF2. It has a birth incidence of 1 in 25 to 33,000 with a diagnostic prevalence of about 1 in 60 to 70,000. It is very important that we must consider NF2 when an individual presents with a unilateral vestibular or other tumors less than 25 or 30 years of age. That part of the slide has got, I think because of the difference in operational systems. But basically the criteria for diagnosis of NF2 are these criteria, and by this we must understand that we have to look out for NF2 because they are a completely different ball game when compared to solitary VS. An example, a 50-year-old man, right temporal headache, CT-MR showed these two dural-based lesions on the right side, also had an incidentally picked up cervical intramedullary lesion. And then the high-resolution MR picked up an intrameatal tumor, and therefore this fits in to diagnosis of NF2. And therefore the treatment of this tumor involving the vestibulocochlear nerve would have to be different from an isolated VS. These also form a part of the phacomatosis group, and therefore we have to realize that we have to look for other tumors in other organs. The clinical picture of VS is most often a unilateral sensory neural hearing loss or an asymmetric hearing loss. You may have also tinnitus at the initial stages of presentation. Vestibular symptoms and imbalance also is seen in a variable number of patients. Very often the hearing loss is not recognized by the patient because the patient is still able to hear from the other ear, and it's only that the imbalance gets them, and then when you ask them which ear, is there a preferential hearing or use of the mobile phone on one ear, that's when they realize that the speech discrimination is lost in the other ear. So this is something which we need to really look for. You still see patients with raised intracranial pressure, and that is something which is important to understand. This is the, when there is a patient with a sudden onset giddiness or hearing loss, you would have to do a PTA, and this is the sort of high frequency hearing loss that you would see on the audiogram, and then when you do the MRI, you would see a tumor, which is the vestibular schwannoma. Imaging wise, we used to use the CT as a screening tool, but the MRI, plain and contrast, is the gold standard for both preoperative workup as well as the follow-up imaging. The CT scan may miss small lesions, as in this tumor where it was not seen, but the advanced MRI picked it up. When you're going especially for surgery as part of the management, you would need to do advanced imaging to look at the facial and trigeminal nerves to know where they lie. In very small lesions, perhaps you could track the vestibulocochlear nerve as well. The Coase classification is a classification which gives you the size of the tumor, especially in relation to the brain stem, and this helps in understanding where the tumor lies and how far into the CP angle and brain stem. We now know that more than half of all VS grow at an average of 2 to 4 millimeter per year, but we must understand about 10% actually can regress on their own. And this is something which we must understand when we are planning management of a particular case. And of course, extrameatal tumors were more likely to grow than intrameatal. Pathologically, they are similar to schwannomas elsewhere in the body. You have the Antony type A and Antony type B types of pathology and Verroque bodies. Immunohistochemically, they diffusely positive are S100 and SOX10, and you have variants like the cellular and melanotic schwannomas. the molecular analysis actually does not play a role either in diagnosis or treatment, so there's not much emphasis placed on that nowadays. Historically, in 1777 in Netherlands, there was a postmortem report of a vestibular schwannoma. In 1895, in Edinburgh, it was the first to remove a VS, though there is also a report that Charles Ballance was the one who did it first. Harvey Cushing developed the retromastoid, and he played a large role in reducing the mortality following surgery for vestibular schwannomas. But historically, if you look at the management of vestibular schwannomas, in the early 1900s, there was a high mortality, and then in 1930s, Cushing brought about the bilateral posterior fossa decompression and subtotal excision, which reduced mortality. Dandy played a large role in improving surgical techniques. 1961, House introduced the operating microscope and then reintroduced the translab approach. Lars Lexell in 1968 invented the gamma knife, and in 69, first SRS for vestibular schwannomas, and in 1979 came the cranial nerve monitoring. And this was the progression of how management of vestibular schwannomas took place. And now if you look at it from starting off with resection of a tumor with high mortality, we are now at a stage where we want to do early diagnosis, hearing, and functional preservation, and have other treatment modalities to help us do that. There being a shift in thought of the goals of VS management from total resection to functional preservation, especially when you cannot remove the tumor safely with respect to cranial nerve preservation. So the managements available are surgery, SRS and SRT, and of course observation. So looking at observation, when do you observe tumors when you diagnose or see on imaging vestibular schwannoma? So you look at that when it is an incidental asymptomatic VS. Of course, the evidence is class 3, but it is important if you are observing a VS, there must be compliance on follow-up. And follow-up and serial imaging is very, very important, as about 50% of these tumors are expected to grow. Now, there were studies which have compared observation versus other managements, and of course, all the reports have shown that observation turned out to be a better modality of management. In Coos grade 4 tumors, surgery is the way to go forwards. Surgery may be also considered for swallowed tumors if there is cystic degeneration, or if cure is the primary goal of treatment. Of course, evidence is class 4, and surgery-related mortality nowadays is less than 1%. But the probability of hearing preservation with normal hearing with surgery is about 50 to 75% immediately after surgery, after 2 to 5 years, and then comes down later. And we are able to give good serviceable hearing after microsurgery if the tumor is of less than 1 centimeter, presence of a distal internal auditory meatus CSF, or if there is good pre-op hearing. I'm sure Dr. Rajshekhar will be speaking about surgery in this. Neuromonitoring as part of the surgical armamentarium is very, very important, especially in large tumors when you want to save facial function. Now, the goal of surgery and recurrence, so we need to do a total or at least a near total resection, because the more tumor you leave behind, the more are the chances of relapse or recurrence of the tumor, and therefore, we have to remove as much of the tumor as possible, saving the facial nerve. So when you leave tumor behind, it's now becoming increasingly popular to be followed by SRS, and with this combined approach, results have been shown to be very, very superior. Now, what do you do when the tumor recurs? You can either have resurgery or you can have SRS, but it has been seen that radiosurgery is preferentially thought to be better. Coming to radiosurgery, though we have only prospective studies without randomization, that SRS is superior to microsurgery for tumors, for patients with less than 3 centimeter tumors, for preservation of facial and hearing outcomes. And we have that functional hearing preservation is similar to the rate of facial palsy and trigeminal nerve dysfunction when you compare SRS and SRT. Malignant transformation, also there is very little data, and some studies have shown absolutely no radiation-induced tumors. Of course, the question of pseudoprogression of these tumors can happen of up to 3 years, and that is not a predictor of failure. So the EA-NO recommendations are like this. So it goes from observation till surgery, depending on the size of the tumor and on hearing preservation. Follow-up. Follow-up is extremely important when we deal with vestibular schwannomas with the current management of either observation or surgery or radiosurgery, because these tumors can recur after any of these or can grow. So it is very important. The protocol that I follow would be a 6 to 12 monthly MRI and a 6 monthly PTA, especially when the hearing is preserved. A couple of examples: a Coos grade 4, near total resection, 2-year follow-up. There's a thin sliver of tumor there. A giant VS, near total excision. You can see a small bit of tumor which is coming from the meatus till the brain stem. 4-year follow-up. And this is the type of surgery that you would need to do to have a normal facial function. This is a small tumor, a Coos type 2, recent onset hearing loss. So the patient wanted immediate relief and cure. So we were able to remove the tumor completely right from inside the meatus. You can see that there is a cap of CSF in the fundus of the canal. So we thought that would be a good thing for surgery, and hearing is improved 2 weeks post-surgery. Now this was a giant VS which we operated. We left a small bit behind, and 3 years post there was growth of residual lesion, and therefore now the patient has gone for radiosurgery. So this is the type of follow-up that you need to do and refer patients. So the take home from me is that VS are a challenge, whichever modality of treatment that you do. The key is early diagnosis, and management needs to be individualized to the patient variables, tumor variables, expertise of the treating team, and the available resources. Management has moved from GTR with morbidity to NTR with facial and, if possible, hearing preservation. Radiosurgery for small or recurrent and residual tumors, and occasionally doing nothing is the best thing you can do for the patient. At the end of the day, quality of life is most important. Thank you very much.
Thank you, Dr. Sridhar. Since all the talks are on the same subject, we will have a discussion at the end of all the 4 talks.
Our next talk is also on surgery of vestibular schwannomas. Consultant neurosurgeon from Vellore, India, Professor Vedantam Rajeshkar. Thank you very much.
Good morning. I think my task has been made easier by Dr. Sridhar, because he's covered quite a bit of what I plan to say. So when we talk about the principles of management of any neoplasm, there are 2 factors that we take into consideration. One is its biology, which in the case of a vestibular schwannoma is the fact that it's a benign tumor, and also the natural history. That is the difficult part with vestibular schwannomas, because the natural history is very variable. It varies from patient to patient. So you need to understand that when we advise a particular line of management. The second major factor that we take into consideration is what the patient comes to you with. And sometimes the patient comes to you with no symptoms. Basically, it's an incidental finding. Again, you need to think about that before you intervene, because you need to decide, or you need to realize that you can't make an asymptomatic patient better. You can only make that person worse. So keep that in mind when you are thinking about the management of vestibular schwannomas. And of course, I think the other aims of management are quite similar to the aims of management of any a brain mass. So let me begin with the types of vestibular schwannomas one could encounter. So we start off with these small intracanalular tumors. They are sometimes very difficult to recognize unless you do a heavily T2 weighted MR imaging, as you see on the left, and with a gadolinium T1 weighted thin slice axial imaging. So these two patients had incidental intracanalular vestibular schwannomas. Actually not both, one was incidental, the other one presented with tinnitus. Both are on follow-up because their hearing is pretty well preserved, so we decided we won't do anything for these patients. Then we come to these slightly larger tumors which have come out of the canal into the cerebellopontine angle cistern, and invariably these patients will have hearing loss with or without any one of the other symptoms that I have listed there. It's important to recognize again that some of these small tumors, as you can see on the panel on the right, can present with features of normal pressure hydrocephalus. That is hydrocephalus which is not associated with raised intracranial pressure. They won't have headache, they don't have vomiting, but what they do have is a gait imbalance, bladder dysfunction, a urinary urgency or incontinence, and the lesion that's responsible for this hydrocephalus is that small tumor that you can see there. It's just a 2 to 2.5 centimeter tumor. So this is how small tumors present. But when you're talking about surgery, then you're talking about tumors like this. Okay? There is no way you can avoid surgery in these patients. All these patients require surgery. And you can see the range from 4 centimeters. By the way, anything more than 4 centimeters outside the canal is considered a giant vestibular schwannoma. So all giant vestibular schwannomas, and anything more than 3 centimeters, I think requires surgery of some form or the other. And these patients, of course, present with significant symptoms, including hearing loss, but they usually have one or more of the other symptoms. And I'm sorry to say we still do see patients who come to us with blindness. It's a sad fact of life working in our country. So let us start with the relevance of surgery for intracanalular and small tumors. I think there is enough evidence now to suggest that we as surgeons should take a back seat when it comes to the management of intracanalular and small tumors. There is evidence to suggest that either observation for intracanalular tumors or radiosurgery provides a better quality of life outcome than surgery. So there is this recent meta-analysis which has again shown, they didn't look at the quality of life in this meta-analysis, but they showed that although tumor control rates and hearing preservation is equal with surgery and radiosurgery, the facial nerve dysfunction was definitely worse in the microsurgery group, 10% versus 2%. So I think the deal is done. Okay, for intracanalular and small tumors, radiosurgery or observation is the way to go, and surgery should be avoided as far as possible. At least that's what I believe. So with the background of that evidence, there is this algorithm that was suggested about 10 years ago, and I think it still holds true. For small tumors which are not growing with no progressive symptoms, they may have just mild hearing loss, mild tinnitus. Watchful observation is the best. Again, quality of life in patients who are undergoing observation is better than any intervention, including radiation. The tumors which are growing or the patient has progressive symptoms with a small tumor up to 25 millimeters in size, I think stereotactic radiosurgery should be considered. For anything more than 25 millimeters, and of course for a large tumor like 3.5 or 4 centimeters, a combined approach, which Dr. Sridhar also talked about, is what is recommended at present. So let us see how different groups of surgeons apply these algorithms to their practice. So on top is a large series of 502 patients from Hanover in Germany. It comes from the group of Majid Sami. He is no longer an author in this, but he is a pioneering neurosurgeon who pioneered excellent outcomes in following surgery for vestibular schwannomas. But if you see that obviously they are biased towards surgery. They are operating on everything and anything. Okay, any vestibular schwannoma is fair game for them. But if you break down the numbers, and this is their own classification by the way on the side, up to T3B is less than 3 centimeters. It's reaching the brainstem. I think they should have actually offered radiosurgery to these patients. This is possible that they did offer and the patients chose surgery, but I doubt that. So 60% of their patients would be suitable for radiosurgery or observation, whereas 20% were large, or 40% were large or giant tumors which should have undergone surgery. But look at our practice. In our series of patients, out of 318 patients, we had close to 60% of patients with tumors more than 4 centimeters where we cannot avoid surgery. We have to operate on those 60% of patients. So why is it that our patients come with these large tumors? And that is something that bothered us. So we did these two studies 15 years apart. So the first study was published in 2008 when, forget mobile phones, even a telephone was a luxury for most Indians. And we thought that was the problem. But our careful analysis and questioning of these patients found that actually we were responsible. We means the doctors. Because if you read carefully, the delay between the initial medical consultation and final diagnosis, not the symptoms, delay between onset of symptoms and seeking consultation is a patient-related problem. This is their fault. But see, this delay after initial medical consultation and final diagnosis was of the order of 3 years on average, 3 years. And that's how long it took us, the medical community, to diagnose a vestibular schwannoma in these patients. And so when we broke down the causes as to doctor related to versus patient related, 80% of the problem was due to us. We were responsible for delaying the diagnosis in 80% of these patients. In some patients you can see 204 months it took for a diagnosis of vestibular schwannoma to be made, because they were diagnosed with presbyacusis and demyelination or whatever it is. So 15 years later, we wondered, okay, now we have mobile phones. Everybody almost has a mobile phone in India. Has it made a difference to the presentation of vestibular schwannomas? So what do we find? That in 60 patients, 97% of whom had mobile phones, there was some improvement. Okay, first they did go to the ENT surgeon for hearing loss. We did diagnose a few more medium-sized tumors, but unfortunately the vast majority of our patients are still presenting to us with severe hearing loss and large tumors. So the situation is not going to change as far as surgery for vestibular schwannomas is concerned, at least in our country. So coming to the surgery of large and giant tumors, I just want to share with you that this is one of the most complex and challenging surgeries for a neurosurgeon. We have to operate in a place which is, as Dr. Sridhar pointed out, has got so many eloquent structures: the brainstem, the cranial nerves, the blood vessels, both arteries and veins. And even with the operating microscope, the ultrasonic aspirator, the monitoring, the imaging before surgery, intraoperative neurophysiological monitoring, but it still is a demanding surgery and it takes several hours for a giant vestibular schwannoma. Typically it takes 6-8 hours surgery. and the outcome can still be dicey. So this surgery is not to be taken lightly, both by the patient and by the surgeon, once the tumor becomes so large. So these are some examples of early postoperative scans after removal of these giant tumors, and these are some long-term follow-ups after several years after removing these medium-sized and giant tumors. But it's always not like this. We have problems. So I thought I'll put up the series by Dr. Majid Sami, that is Hanover 1, which he published in 1997. It's a landmark paper. It's considered the gold standard for microsurgery of vestibular schwannomas as far as the outcomes are concerned. And the second paper again from the same group, but about 20 years later, without Dr. Majid Sami there. And finally, our series of only giant tumors. So that's the difference. Their tumors were much smaller, most often smaller. They did have a few giant tumors. So you see, we still have mortality. In giant tumors, our mortality rate was close to 2%. Even in Majid Sami's hands, mortality rate of 1.1%. To the patient who dies, the patient dies. 100% mortality for that particular patient. So there is mortality to be considered. You have problems like postoperative tumor bed hematoma. CSF leak is a major problem. 1/10 of patients will have CSF leak. And facial paresis. Now we come to functional outcomes. Even in Majid Sami's hands, 20% of patients will have a less than optimal facial function after surgery. And in giant tumors, we had a facial dysfunction of close to 30%. And 9th and 10th cranial nerves. This is necessitates sometimes tracheostomy, sometimes feeding jejunostomy or a gastrostomy. That was of the order of 18%. Most often it's temporary. I agree, we can close the tracheostomy and pull out the Trials tube, but it is a problem. And even in the best hands, close to 5.5 to 6% will have this dysfunction. So we need to think about these consequences of surgery when we go and attack these tumors. Dr. Sridhar mentioned the utility of intraoperative facial nerve monitoring and how it improves outcomes. It does, we have no doubt. Even without a randomized controlled trial, I will not operate on a vestibular schwannoma without intraoperative facial nerve monitoring. We have been doing it for 25 years and we'll continue to do that. Evidence be damned, because we are convinced that it improves outcomes. Okay, so the problem is that the larger the tumor, the worse is the facial nerve outcome when you try to remove these tumors completely. That is very evident from the data here. Grade 1 outcomes in our series, in my colleague series, Dr. Ari Chako's series, when the tumor becomes more than 4 or when the tumor is more than 4 centimeters, a grade 1 facial function is only seen in a quarter of the patients. Whereas when it is less than 3 centimeters, 85% almost have a normal function. And this is not only our data. You look at the data below from the Hanover group. For small tumors, good facial function in 50%, but for large tumors, it's only 30%. So we know that when you try to attempt to remove these tumors completely, a large percentage of these patients with large tumors will have facial dysfunction. Now, there is another aspect. These tumors should be excised in centers and by surgeons who are experienced. Again, data is very, very clear on that. As you can see, with increasing experience or increasing caseload, your complications come down. So somebody operates on just one vestibular schwannoma a year, I hope nobody does that, their outcomes will be poorer than somebody who's operating on more than 10 vestibular schwannomas a year. And for a center to achieve optimal results, the number suggested is 30, 35 per year. This is a very interesting aspect that a lot of us surgeons do not recognize. What we report as outcomes are different from what the patient feels are important outcomes. We talk about mortality, cranial nerve morbidity, facial nerve function, hearing function, whether it be surgery or radiosurgery. This is how we talk You know, this is these are the outcome parameters. But look at what the patient wants. Besides facial nerve function, they're talking about headache. How many of us report headache after radiosurgery for vestibular schwannomas? Nobody. How many of us report headaches after surgery for vestibular schwannomas? Nobody. We just show hydrocephalus is gone, tumor is gone, headache should go. No, the patient still has headache. Problem, big problem. It interferes with their life. Dizziness, nobody asks. Psychosocial disability, no. And look at the last table there that I have provided. This is taken from a paper where they compared the facial dysfunction on the House and Brackman grade reported by the surgeon versus what the patient self-reported. Grade 1 and 2, which we call excellent outcome, surgeon said 65% of these patients had that outcome. Whereas when you ask the patients, only 30% said we had that outcome. And this is the problem. There is a disconnect. We underestimate the patient's handicap. We don't look at things like psychosocial disability and things like that. And do again remember, patients with vestibular schwannomas have worse quality of life after than before any intervention, whatever intervention we think of, except observation. Now, when it comes to large tumors, the story is a little different. Because most of the studies on quality of life are on small tumors, less than 3 centimeters. You look up literature from the West, it's all about less than 3 centimeters. And they are based on retrospective studies. Means you take the patients after their treatment and you ask them, how are you, you administer the SF36 or whatever, and then compare it with the normal population. Okay? And you invariably find that their quality of life is worse than the normal population. But what was their quality of life before the surgery for the large tumors? Small tumors, maybe that was close to the normative population. But for the large tumors, you need to know what the quality of life was before surgery. Remember, most of these patients are severely disabled. So we need to have a pre-op and a post-op assessment. And to our knowledge, very few studies have done that for large tumors. So we set out to look at the quality of life in 100 patients with large and giant vestibular schwannomas, did a SF36 before and at 1 year after surgery, and in addition we administered the Glasgow benefit inventory. And we found that on the Glasgow benefit inventory, 87% of patients had improved after a surgery, but 12% had deteriorated. So they were worse off than they were before surgery. As far as SF36 is concerned, 60% of patients showed an improvement in one or more domains. So we are not doing that well. Okay, 40% of patients have remained the same or maybe worse off in their quality of life than before our intervention. But we have to operate to save lives. And we will improve the quality of life in at least 60% of patients. So we need to counsel our patients that surgery is not going to improve your quality of life. It's to save your life with these giant tumors. If you do not operate, you will not survive. So that kind of counseling is very crucial. So keeping that in mind, of course, now we have moved on to this so-called hybrid surgery or combined surgery. These are 3 examples of such patients. We take out this tumor as much as possible, leave a small residue, and we gave upfront radiosurgery to this patient. That's another debatable point. Do we need to do radiosurgery for that small residue? What will happen to it? Will it grow, not grow? No answers. At what is the threshold for treating with radiosurgery after excision of a giant vestibular schwannoma? No answers. Okay? But just giving you some examples, we rely a lot on the ability of the patient to comply with follow-up. Okay, so 5 years post SRS, the tumor has shrunk a little bit. But look at the second patient. The patient said, I'll come for regular follow-up. 9 years later, no SRS, tumor has not grown. It's remained the same. Again, the natural history or what we are seeing as tumor on the MRI may not be tumor, maybe some scar tissue, I don't know. And the third patient, very small residue, but 3 years post-op, it's grown. So we had to administer radiosurgery at that point in time. So we were again wondering what happens to our patients when we do this hybrid surgery. Because remember, Hybrid surgery does not end with the surgery. Surgery is 50% of your treatment or management. The other 50% is either careful observation or radiosurgery. So how many of our patients complied with that? In 55 patients, we found that 40% or so had not complied with our management plan. You will lose 40% of patients before the treatment is complete. This is in our country. So this is a big problem. And that's what worries me, that if we continue on this path of combined surgery, we are sending out several patients back home who think that treatment is complete in spite of a lot of counseling. This is a real danger. Remember, they'll come back and they will have problems. So besides giant tumors, we do operate on other tumors. We have to. Patients who have failed radiosurgery. These are the two examples. The example on top, this is not pseudo-progression. This patient was observed for 2 or 3 years after radiosurgery and the tumor kept growing. And the patient in the bottom panel had radiosurgery and then this tumor grew after 10 years. He's just been operated. 10 years later, that small tumor which was under control after radiosurgery has become a large, and he was symptomatic. So we had to operate. And finally, we do have to operate on patients who, even though they have a small tumor, they come with hydrocephalus, like I told you. So we put in a shunt, like the patient on top, and then did radiosurgery. And you can see the central necrosis following radiosurgery. And the patient below, in the lower panel, we just excised the tumor because the patient said, I want the tumor out. And then the hydrocephalus has gone down, as you can see in the lower panel on the follow-up. A sobering study from Mayo Clinic for surgeons. This is data on long-term follow-up, many, many years later. And you see that number that I've circled there. This is after gross total resection of a vestibular schwannoma. It's a sporadic vestibular schwannoma. 56% of patients were still progression-free, survival. But 44% had progression 20 years after gross total resection. That is the type of follow-up which is required for benign tumors. And this is an example of one of our patients. We operated in 2015 for a giant tumor. We thought we had taken it out completely. Asked the patient, of course, to come for follow-up. She comes back 5 years later and look at the size of that tumor. This required both a middle fossa approach and a posterior fossa approach. So I would like to conclude by saying that surgery is required in a large proportion of patients with vestibular schwannomas in our country. But we need to counsel our patients about what can really be achieved with surgery, especially with relation to their quality of life. And this is my belief. I think vestibular schwannomas should be operated in high volume centers with experienced surgeons, and ideally it should be managed where you have both options. For a small tumor, you go to a surgeon who only has surgery to offer, it's likely that you will get surgery. If you go to a center where they have both, there is no bias. There is no reason to push for one or the other because the patient still stays under your care. So you don't need to send that patient out anywhere. So you will likely give the patient a true unbiased opinion. Thank you for your attention.
Hello.
Thank you, sir. Excellently elucidated the various factors influencing the management, decision making of surgical management. May I call upon the next speaker, Dr. Mikhail Chernov. He will be talking about radiosurgery of sporadic vestibular schwannoma.
Good morning. Radiosurgery of sporadic vestibular schwannomas is so well established that it's really difficult to find some new things for this report, so therefore I will just highlight some issues which are well known for any radiosurgeon. Another thing that maybe not neurosurgeons are familiar with these things, so just some overview of the basic principles. If you look on the general trend in management of vestibular schwannomas, by this time around 50% of patients undergoing surgery. This American data, and other quarter undergoing either radiation treatment, any way of radiation treatment, including radiosurgery or observation. Our personal experience in Tokyo Women's Medical University was highlighted in several papers which were published several years ago, and Dr. Hayashi, who is director of our Gamma Knife Center, the first author in the majority of these papers. So yesterday I mentioned that we implied the concept, so-called concept of robotic microradiosurgery, and I highlighted how it is applied for cases of cavernous sinus tumors. So absolutely the same principles we use for management of vestibular schwannomas. So we use T2 heavy MRI images with gadolinium enhancement for delineation of the tumor, as shown here. On the top there is these images without gadolinium enhancement, and the bottom with gadolinium enhancement. So we always use fusion of MRI and CT images, not only for simultaneous visualization of both soft tissues and bone structures, but also it allows for us calculation of the dose to the cochlea, which is important for hearing preservation. We use highly conformal and selective treatment planning, and we're trying to put this high hotspot or high dose isodose area on the intracisternal part of the tumor. We're trying not to extend it, not to extend this high dose area intracanalically, but we believe that this high dose area, at least according to our data, it corresponds to the shrinkage of the tumor. We call this before as homogeneity index when we try to calculate the area of the lesion covered by 80% is a dose to 50% is a dose, and we try in this area inside the tumor of 80% is a dose would be at least 50%, even higher. So it was shown in meningiomas. Then we tried to also to evaluate the same principle in schwannomas, and it somewhat correlates with the more recent studies by Konstantin Tulyaska, who demonstrated that biologically effective dose may be associated with the shrinkage of the tumor after radiosurgery. If you're speaking about response, also we should mention that starting from 2017, it has become clear that cystic vestibular schwannomas probably respond better to radiosurgery than solid ones. Actually, the last paper on this matter was published this year in Journal of Clinical Neuroscience, and it came from India. Initially, it was demonstrated by two American groups independently from each other, from the group of Taipei and from Switzerland. And even there was attempts to suggest that ADC, apparent diffusion coefficient, may predict response of cystic schwannomas to radiosurgery. So in general, we should consider these tumors more suitable for radiosurgery, maybe in the even conditions than solid ones. These are our results. It's a little bit old series, but it's our largest and the most systematic analysis of our cases, 126 cases with at least 2 years of follow-up after treatment. We use, as many of you use, low-dose radiosurgery with a range of dose from 11 to 12 gray. So at 3 years follow-up, we observed tumor shrinkage in 73% of cases, stabilization in 23% of cases, and enlargement in 4% of cases. No one enlarged tumor required any additional treatment, so the oncological response was 100%. In more than 50% of cases, we observed more than 50% shrinkage rate, which means that it was clinically significant. And very rare complications is trigeminal nerve dysfunction. No one patient had trigeminal nerve dysfunction after radiosurgery. Just 3% of patients had transient facial nerve palsy, On the other hand, we observed improvement of the motor function of the seventh nerve in 30 patients, if this deterioration was observed before radiosurgery. But what we definitely saw, as many of you, is transient enlargement of the lesion within several months after radiosurgery. In our series, the incidence of this side effect was 25%, and also, of course, deterioration of hearing on the long-term follow-up. This very classical imaging of the case with temporary tumor enlargement after radiosurgery, when several months later, usually from 6 to 12 months, we observe a disappearance of the contrast enhancement within the tumor. According to Pittsburgh classification, they call it as a black hole, and then the tumor enlarged, and so then it shrunk again. So if the patient is asymptomatic on this stage, it's possible just to initiate steroid treatment or even just to observe the patient. And 90% of this patient don't need any additional treatment and surgery. And while, of course, occasionally neurosurgeons don't understand this still and trying to operate patients on this stage. It's not necessary at all. Hearing deterioration is definitely a problem. In our series, we observed first features of deterioration even 6 months after radiosurgery. And then with longer follow-up, it's steadily declining. And the only one question whether this plateau after 5 years exists or not, because maybe it's still deterioration of hearing. According to various publications in the literature, at 10 years after surgery, from 23 to 45% of patients still preserve their serviceable hearing if they had it before treatment. But we can look on this from the opposite point of view. We can convince the patient that at 10 years after radiosurgery, you have 25% chances to have preservation of hearing, and this is definitely much better than after surgery. There are multiple factors which are associated with hearing preservation after radiosurgery. It's younger age, it's good preservation of hearing before. Specifically, even subjective hearing losses, as demonstrated by Pittsburgh group, is associated with worse long-term results of hearing preservation. And this should be considered when we advise patients to just for observation, because if during observation period the hearing will deteriorate, then it will be much more difficult to preserve serviceable hearing. Of course, with different parameters of treatment, smaller size of the tumor, lower dose. In our series, we tried to evaluate several factors, but we didn't find actually anyone which statistically, which had a significant association with hearing preservation, and we believe that the approach is actually multifactorial. Specifically, I wish to put your attention to the cochlear dose. We know that maximal dose of the cochlea may be around 3 to 4%, which is associated with better preservation of hearing if the dose is below this limit. But, and we are trying to do it in our own practice also. But on the other hand, in several series, this dose of the cochlea was included in the multivariate analysis along with other factors, and actually in the multivariate analysis, dose of the cochlea wasn't significantly associated with hearing preservation of the long-term follow-up. Another thing that in several other CPA, cerebellopontine angle tumors, as meningiomas or facial lymphomas, we are given even much larger doses to the cochlea, and still the rate of hearing preservation is sufficiently high. So it means that a dose to the cochlea is important, but this, once again, not only one important factor. So if we cannot keep low dose to the cochlea, we still have to treat tumor according to the general standards to avoid its recurrence. There's a very interesting study from Pittsburgh which suggested so-called Pittsburgh hearing prediction score, which is based on 3 factors as patient age, Gardner-Robertson grade before radiosurgery, and tumor size. And they defined 4 groups of tumors with statistically significant difference in hearing preservation rates on the long-term follow-up. The only one thing, I like the study very much. Unfortunately, this, to the best of my knowledge, this prediction score was never validated externally by other groups. So if some of you are doing research, I think it's a very good, very good objective for research study validation of this score. So among other reported complications, these high rates of neuropathy, of course, they came from the old series. Now the rate of neuropathy is less than 2%. In many series, it is nearly zero, as well as peritumoral edema or radiation-induced necrosis. Hydrocephalus occasionally is a problem, but it can be managed with shunt. Hemorrhage into the tumor, according to the recent multi-center study, is encountered in 0.26% of cases overall. Occasionally there's aneurysm formation, stroke. So actually the rate of these complications is very, very low. So the question is how to treat large tumors. If you look on the series, so initially, in the initial series, treatment was possible, but the tumor control was a little bit lower than with regular size tumors, is less than 3 centimeter in diameter. And also the rate of hydrocephalus need for additional treatment was higher. But if you look on the more recent series, for example, the series of Agina published in 2021, the results are actually comparable with those which we observe in treatment of small and medium-sized tumors. There is only theoretical explanation why there is some improvement with time of results for treatment of large tumors. In my opinion, there are two main factors. First is that there is better selection of patients for this treatment because CUS grade 4 vestibular schwannomas is very large in highly heterogeneous groups. We should put attention to other factors, not only to the CUS grade when we're considering radiosurgery for tumors. And also another thing that probably in the more recent time there is more frequent application of multi-session radiosurgery with 3 or 5 sessions, maybe it also implying results. So the results, once again, the results of radiosurgery for large tumors in the more recent series which are published in the last, let's say, 3 years are much better than before. Still, in our practice, we prefer other approach for these tumors. We use combined management, as was already mentioned, with pre-planned subtotal or partial resection. And there is different series which demonstrates effectiveness of such approach. And with subsequent radiosurgery for residual tumor, specifically I wish to underline this series, which is this black line in the middle. This some sort of a case control study from Taipei, from a very active center, Veterans Hospital, by Dr. Pan. They had 2 groups of tumors, of patients, of course, 2 groups of patients. In one patient, it was pre-planned subtotal resections. In other patients, it was subtotal resection based on the intraoperative situation. So they found that if this was pre-planned subtotal resection, even the hearing preservation rate was 100%. So if it was decision was done by surgeon during surgery that he or she couldn't remove the tumor completely, the results, functional results were worse. So it means that probably such treatment should be planned in advance. And the question is just the majority of neurosurgeons are asking at which stage they should stop. We don't have enough data about this. Recent series, it's a small series, but a very experienced group by Michael Schulde from New York. They said that according to their data, the cutoff for preservation of facial nerve function after surgery is 3 cubic centimeter. So they try now to leave this 3 cubic centimeter volume, which is fully suitable for radiosurgery, and they demonstrated very good functional results. Actually, again, for the surgeons, this study also was cited in the previous preservation, this Mayo Clinic data. Even total resection of the tumor is definitely not panacea against tumor recurrence, and this is a Kaplan-Meier curve. Very experienced group, more than 300 cases of gross total resection, and we can see steadily a decrease of recurrence-free survival. And in the lower line, this is subtotal resection group, just 18 cases, but we can see that progression-free survival even worse. The very important question about timing of radiosurgery. This review was published last year, and it retrospective study and a very good literature review. So the authors demonstrated that actually timing is not so important. You can do either radiosurgery within 6 months, which is called as early radiosurgery after subtotal resection, or you can wait and you can give it later. So from the functional point of view, from the point of view of functional results or from the point of view of tumor control, the results are similar. So delayed SRS after close observation of the residual tumor following subtotal resection is a safe alternative to upfront radiosurgery regarding tumor volume control and control nerve preservation in selected patients. But here we should put attention to another thing, which we up to this time don't discuss so often in any neurosurgical or radiosurgical meetings, the so-called social aspects of neurosurgical practice, which is very important, because one story when we have a deal in Japan, when we have patients around our hospital which are regularly coming to the outpatient clinic, we can do regular follow-up. It's not a problem to have delayed radiosurgery. Another situation is in India or in Russia when you're treating patients in St. Petersburg, they're going back to Sakhalin Island. So maybe it's better to complete treatment in the first stage, and if results are the same. So also another question, maybe I'm a little bit out of time, I will try to speak a little bit faster, about comparison of radiosurgery and fractionated stereotactic radiotherapy. There are no randomized studies on this. This very strict, meta-analysis with very strict criteria, and so the authors of this meta-analysis put only 2 series with fractionated stereotactic radiotherapy. It is marked by cross on these lines, on these graphs, and radiosurgery, and they found no difference in tumor control or hearing preservation with these 2 modalities. And this is one of the largest study on this topic, retrospective study from 3 German centers, very active centers. They did Linac-based treatment, but also they found no difference in functional results or in tumor control between 2 modalities. So therefore, at this moment, neither ASRS guidelines nor CNS guidelines recommend fractionation for treatment of vestibular schwannomas because of the lack of evidence of the advantages. Once again, this is which I mentioned in the previous slides, this corresponds to the fractionated stereotactic radiotherapy. Probably the situation with multi-session radiosurgery with 3 or 5 fractions is different, and probably for some large vestibular schwannomas it may be a reasonable treatment modality. So if you see late enlargement of vestibular schwannomas after SRS, it's really a difficult situation to make a clear diagnosis. Is it pseudo-progression or is it real progression? There was suggestion to use diffusion-weighted imaging or methionine PET for differentiation of these situations. It's actually still we don't have sufficient data, because even on the late progression of the tumor, we can observe later stabilization. So in our practice, even if you see progression of the tumor on the long-term follow-up after radiosurgery, initially we're trying to follow the patient. We are looking on the symptoms. If the patient is symptomatically and neurologically stable, so we are trying just to observe him, and occasionally we see the further stabilization of tumor or even regression. So if the tumor is progressing and there is appearance of new symptoms, definitely it's necessary to perform secondary treatment. It can be either radiosurgery, but repeat radiosurgery for vestibular schwannomas associated with somewhat greater risk of cranial neuropathy. So probably microsurgical management is preferable. In such cases, the majority of neurosurgeons prefer subtotal tumor resection instead of total resection. And I think this is the optimal treatment way to perform subtotal resection to confirm that it's still benign tumor, there is no malignant progression, and then for residual tumor to give the second radiosurgery. So in this conclusion, nearly similar to conclusion which I gave yesterday after talk on radiosurgery of cavernous sinus tumors, that contemporary radiosurgery provides effective and safe management for vestibular schwannomas, resulting in high rate of mass shrinkage and low rate of complications, and allows for optimal functional results. And thank you very much for your attention.
Thank you very much, Dr. Chernov, with your comprehensive observation of this topic. And now I would like to invite Professor McCutcheon from MD Anderson Cancer Center to give the last talk in this session.
Okay. Let me try to... So, let's see. Yes, good. So yes, I'm going to address the specific issue of stereotactic radiosurgery for the subset of vestibular schwannomas that are associated with neurofibromatosis type 2. Are we up higher? Okay, good. Thank you. So, let's see now. Is this thing going to work? Yes. So one of the big differences is that in that syndrome, which is a genetic syndrome caused by mutation on chromosome 22, there's not just vestibular schwannomas, but a lot of other manifestations, tumors that include meningiomas and also ependymomas in the spinal cord in particular, and then, of course, occasional schwannomas as well. And so when you deal with this, you can't just look at them as vestibular schwannomas. You have to kind of look at the whole picture. But the vestibular schwannomas are the focus of this talk. Typically, they are bilateral, although they don't have to be bilateral. Oh, sorry, what's going on here? Okay, right. Here you see fairly classic types of bilateral presentation, such as we would see in our clinic, where we follow a fair number of people with NF2. However, out of the general population of patients with vestibular schwannomas, only 5% or less have that syndrome. So it is a distinctly unusual thing. It clusters in centers of excellence or academic centers, so we have a disproportionate number. They can cause a significant degree of brainstem compression and often come to us with quite large lesions. You can see on that right picture the meningiomas on the convexity. There may even be one in the ventricle there. So the diagnosis of NF2 requires that it meet various clinical criteria. This is the traditional set where if you have bilateral vestibular schwannomas, you don't need added features for diagnosis. If you have a unilateral vestibular schwannoma, you need also to have either a first-degree relative with NF2, thus proving the genetic component, or any two of the other lesions mentioned, meningioma, schwannoma, etc. Over time, the diagnostic criteria have actually evolved. The Manchester criteria, which are in the second column from the left, are often the ones that are quoted in papers that you read about this, but there have been consensus conferences that have tried to fine-tune this, including one last year, where, if you read through that, you'll see that they're including the genomic data. So if somebody has had sequencing done for mutations, they will take that into account, which makes sense because in the modern era, we do have often those kind of data available. It's been mentioned about Coos grade. I won't dwell on that. What we do want to say is that mutations within the NF2 gene have a variable clinical effect. There's a bunch of different possibilities for what kind of mutation you might get: truncating, splice site, large or small deletions, etc. And so there's a clinical heterogeneity of tumor behavior, tumor presentation, and some people have the bilateral, some have the unilateral, some have bilaterals that grow on one side, some the other side, some both. So it's a very diverse group within this small patient population. So genotype does drive phenotype in this condition. If you look there in the graphs that we see, we have on the upper one stratification by the nature of the genomic change, and some of them, as you can see, have much more chance to appear over time, and survival is shown on the right. The same thing applies. There's one group that has a poorer survival for sure. A greater proportion of those who have de novo constitutional variants get meningiomas and ependymomas, which is sort of interesting, but none of this is very well understood. These are sort of recent observations. So the goals in treating vestibular schwannoma in NF2, of course you want tumor control, but you want it in order to maintain nerve function. And so that includes function of the facial nerve, the maintenance of serviceable hearing in at least one ear, which is a significant issue for quality of life. And then if there are preoperative symptoms, which there can be, headache, as has been mentioned, dizziness, tinnitus, you want these symptoms hopefully to improve. You want to avoid getting facial spasms, which are a thing that can happen after treatment occasionally for vestibular schwannomas. And of course, you don't want to resect a patient who is mistakenly identified as having a tumor but actually has pseudoprogression. So usually what's done is you treat the larger and or the faster growing tumor and the one in the ear with less hearing, the more deaf ear, or the one that's losing hearing the fastest. Radiosurgery tends to be indicated only on the hearing side, and only if the hearing of that ear is declining or if the tumor is growing. Now that doesn't include the category that relates to, adjuvant radiosurgery after a resection has been done of a giant schwannoma. Certainly, yes, we do agree with that. But I'll come to that a little bit towards the end of my talk. So there's the EANO guidelines, which have been mentioned in at least one of the previous talks. And the problem is when you look deeply into their tables for their recommendations regarding NF2, you can see they say you can have surgery and or radiosurgery and or bevacizumab and or stereotactic radiotherapy, the fractionated variety. And so, that doesn't really help. So, yes, that is the array of types of treatment that can be used, but it doesn't really get us, details on which patient is good for which. This is the algorithm put together in Marseille by the group led by Jean Régis, who's a very well-known radiosurgery sort of specialist and has actually presented at a number of these meetings in the past. And so in Régis' scheme, this being the algorithm specifically relating to NF2, you have bilateral vestibular schwannomas, so you go through this series of columns where the first one is it's weirdly sort of labeled in his paper, but it's the number of ears that have hearing, either 0, 1, or 2, the Kuss grade, 1 through 4, the number of clinical or radiologically, what he calls evolutive, which means growing tumors, and then you come up with a decision through this tree, and then you wait a year, and you may have additional things to do depending on the situation. I won't go into all of the fine points of the details, but this does exist out there. It was published in 2018, and actually has some sort of sense to it. Essentially, it shows a role for both radiosurgery and surgery, and the conservative watch and wait strategy as well. He doesn't really get into medical therapy with bevacizumab, which is a thing unto itself. In that same paper, they looked at what happens with the tumors as they go year by year, what's happening before Gamma Knife has been given to tumor volume, and what happens to tumor volume after Gamma Knife is given. And so you see that there's a significant amount of growth going on in that left column that's prior to the treatment being given. And then after the treatment's given, things shift way down, and so there's still some that fail the treatment, but the majority of them stabilize. They're carried within that sort of green-looking rectangle there. But there are several patients there who did not respond perfectly. So it's not the final answer for everybody. He also looked at the time of last serviceable hearing after gamma knife in a total of 70 ears. I think it's interesting they look at ears. It's hard for me as a neurosurgeon to think of ears as what I'm looking at, but that makes sense. And so as you look at this graph, you can see that functional hearing, as we've heard, is not preserved in many patients over time. So at 5 years post gamma knife, again, these are NF2 people, 47%, and at 10 years, 34%. There seems to be a plateau going on there, but who knows, as we heard previously this morning, you know, you got to 20 years and you've still got things going on with deterioration. So giving gamma knife does not automatically make you retain hearing. The list of complications, as you can see, there are some, but they're not heavily in these. Yeah, let's see. I'm going to skip that. Yeah. So if you look at single session gamma knife versus what they call fractionated gamma knife versus no treatment, you can look at these sort of from left to right is the single session gamma knife, the no treatment on the right. And you can see no treatment leads to lots of growth of tumor, whereas treatment with either the single session or the fractionated does have a pretty good chance of keeping things stable or shrinking them, but with little bumps in the road of pseudoprogression, as you see when it has that initial up bump that comes down again. So if you look here, this is tumor volume after radiosurgery in a total of 41 tumors that were looked at. The marginal dose typically given was between 12 and 13 gray, and the tumor control over time goes, so you've got 24 of them out of 41 have tumor control at 12 months. At 2 years, it's 21. Then at 36, it actually goes up a little bit. It's interesting. And then by 120 months, it's down to 9. So you've got this kind of degrading of the tumor control over time. And when they look at pseudoprogression, which happened in roughly about 25 to 30% of them, the peak volume increase was about 30%. The time to peak volume for pseudoprogression was an average of 17 months. So, you know, you have to be aware of the pseudoprogression. It's very important. So here's the pattern of growth in this study before radiosurgery was given. You can see how there was a lot of, this is a log scale, but there was a lot of, you know, varieties of levels of growth, but in general, most of them were growing. And then after radiosurgery, you get a kind of an example of here where you've got some that were treated but then eventually failed and started to grow again. You've got some that showed pseudoprogression, and you've got some that just responded gradually and nicely. There's one on the right that showed hearing loss during pseudoprogression, but the hearing loss got better as the pseudoprogression faded. So, tumor control and maintenance of hearing after gamma knife. Here's now 85 patients with 133 tumors, and you can see here again it makes the point the time to loss of tumor control extends over many, many months. 10 years is on the right-hand side of that left panel, and at that point you're down to somewhere around 55% or so. And the time to loss of serviceable hearing, it can take a long time as well. Tumor control and freedom from additional treatment. You've got tumor control on the left here in this recently published series just from earlier this year. Tumor control degrades gradually, again, over a long period of time, and freedom from additional treatment. They seem to manage for 10 years, not needing more, but then as you get past that time, more and more they need additional treatment, whether that be surgery or another radiosurgery session. Interestingly here, they found that the risk of malignant transformation, which we often hear about with NF2, they found no malignant transformation in this reasonably large number of patients with a large number of tumors, and that's over a median follow-up of 6 years almost, but with follow-ups that extend out in many well past that. So, you know, the time to malignant transformation requires, like for a true assessment, a long follow-up. Was this 5.9 years long enough? Perhaps, maybe not. They also saw no radiation-induced tumors, another thing that people worry about in people with NF2 or indeed any genetic syndrome. So in the maintenance of functional hearing after radiosurgery in the NF2 situation, just as in the sporadic, the cochlea is radiosensitive. We do try to keep the dose also at 4 gray or less. And there have been sort of variable degrees of hearing preservation among the different published studies. One of them by Krut, which is a very actually good paper, was 59% at 5 years. A relatively contemporaneous one by Lloyd et al. Was 41% with a tumor control rate of 81. So that it's interesting, you think about it, if the tumor is controlled and not growing, why is the hearing deteriorating? Well, it may be because of the nature of NF2 itself, that the nerve, you know, is composed of cells that are just vulnerable over time. But it may also be because of the effects of the actual gamma knife treatment on that nerve. If you increase the marginal dose, your tumor control improves, but you get worse rates of hearing loss. And of course, patients with larger tumors start with worse hearing at their baseline before therapy is given. So the next are a series of slides that are on sort of more of the same. Effective tumor size on hearing preservation, as you can see, it goes down. The one that go down the most are the ones at the bottom with the dark line. That is the ones with the biggest tumors. That's logical. This is an algorithm that has suggested for patients with NF2 and hearing in only one ear. And so you've got, in this particular algorithm, surgery as some of the conclusions. Some of them are cochlear implants. Some of them are auditory brainstem implants, but nobody says anything here about radiosurgery, which is interesting. We think that's a kind of an omission on their part. This is the paper by Krut et al. That I said was a good study. What they really did was matched patients who had NF2 with another cohort who had non-NF2 and similar-sized tumors, and looked at what happened in order to see, was there a difference between the NF2s and the non-NF2s. And so what they show here is that for the NF2 people, when they're stratified by tumor subtype, the more aggressive subtype, which is called the Wishart phenotype, and the less aggressive one, yes, those phenotypes actually work as they're supposed to. Some are going to deteriorate more than others. By tumor size, yes, this is after gamma knife. The bigger ones don't do as well as the smaller ones. When you look at tumor size together with the subtype of aggressiveness, that still all falls out as it should. This is all logical. And then the loss of serviceable hearing over time, as it goes down quite a lot, as we have seen. But what they saw was no significant difference between NF2 patients and those in their comparative group who did not have NF2 for either tumor control, hearing preservation, or complications. So they're basically saying that the two groups do equally well or equally badly, depending on your perspective on the matter. I'm going to skip that. The progression was actually 0% in NF2, whereas 4.5% in the sporadic group progressed in this separate study. So you get different results from different authors, which are interesting. So I want to conclude here with just a little brief bit of the giant tumors. This is an algorithm for them that includes surgery, bevacizumab, but here too it doesn't really get into the issue of what's the role of radiosurgery. So there's as many algorithms as you can look for in the literature. They're all going to be a little bit different. The treatment of large tumors with bevacizumab does actually have a reasonable chance of working, but as you can see here, in some it doesn't shrink them, in others it doesn't stop them from growing. And it is associated with improvement of hearing, but it is dependent on continuing to take the drug as soon as the drug is sort of a static drug. As long as you take it, it works, and as soon as you stop, it starts to degrade again. So in large vestibular schwannomas, does the NF2 status affect the results from doing what has now become popular, including with my own practice, of subtotal resection with radiosurgery to the remaining fragment? And the answer is no, not really. It works as well for the NF2 people as it does for those who don't have NF2. That's what those two lines show in that graph. Now, this is the final part of the talk. I have 2 or 3 slides on this, which I think is an interesting thing to consider. People with NF2, like, why do we have trouble after surgery? So I've talked about radiosurgery, but I want to just mention, after surgery there is more chance to not get all the tumor out, more chance that you're going to hurt hearing, more chance for complication. They're harder cases to operate on. So this study is from the NIH in the United States, and what they did is they looked at different regional samples of tumor that were saved from multilobulated tumors, and they looked for the genetic hits on the NF2 locus and found that there are, in fact, multiple different somatic second hits, which implies that these tumors are polyclonal, not monoclonal. So if a tumor is polyclonal, it means that it may be formed from a separate number of different smaller tumors that coalesce over time. And in fact, if you look really closely at MRIs on patients with NF2, which they did, they found that to be seen in a number of their examples. And so, as some of the clones might arise from tumors from either the cochlear nerve or the facial nerve, not just the vestibular nerve, that's perhaps why the risk of injury to those nerves is higher in this group. So basically, functional preservation, hearing, facial movement, and tumor control are actually less after surgery in NF2 patients than in those with sporadic tumors. Tumor recurrence long-term approaches up to 50% if you go out 8 years from gamma knife, but it is much less in sporadic cases, although as we saw, as you go to 10 years and 20, the sporadic ones do kind of catch up. It may not be a true good comparison because we tend to operate on bigger tumors in NF2. But the difference may come from polyclonality, other unrecognized differences in tumor biology, the propensity to infiltrate rather than displace the adjacent cochlear and facial nerves. You can have synchronous facial nerve schwannomas in up to 20%. And so there's a tendency to delay treatment until tumors are larger. The final slide here is this one. So I leave you with this sort of mathematical exercise. So if you think about that, the probability, let's assume that you could successfully treat a sporadic tumor, i.e. one that's monoclonal in its derivation, is 95% chance of success at 5 years. Then you look, if each clone in a polyclonal tumor is by its nature treated as an independent tumor that will gradually grow to form the larger mass. So if you then simultaneously give radiosurgery, gamma knife, or whichever type you use, to multiple clones, the probability of getting local control is 95, like 0.95 to the nth power, where n is the number of independent clones. And you go through this math, and you'll find that that suggests that you should get a 77% control rate at 5 years if the hypothesis of polyclonality is true, and that does actually correspond roughly to published data on gamma knife used to treat vestibular schwannomas. So the authors from the NIH suggested that this was proof, and I think it's intriguing, perhaps to be considered as to why NF2 tumors don't do as well in surgery situations, and perhaps also with gamma knife that may make it harder to gamma knife them, because if they have these little independent tumorlets, then you may not be truly targeting everything that you need to when you're trying to be very selective when you do radiosurgery. So it's very complicated. There's not really a straightforward algorithm. I will say in my practice, we have in NF2 a lot of patients who come to us for surgery who have the giant kind of tumors. They've waited until the brainstem has gotten quite compressed, and so we tend to follow the plan of operate, take out the giant tumor, but leave behind the carpet along the seventh nerve location, the eighth nerve, in an attempt to preserve facial function, and then we gamma knife. I've taken to doing gamma knife earlier because I find that those fragments do tend to grow, and if we turn our back on them for a while, they can grow quite substantially. So thank you for listening to my talk, and I guess that is the end of this session. Yes.
Thank you, sir, for the excellent presentation. I think that topics are open for discussion. Yeah. Mike.
This was an excellent session. I just want to congratulate all the speakers. Just a few comments as a neurosurgeon. Preservation of the cranial nerves during surgery, as very eloquently showed, doesn't equate to preservation of the function. So that's, even with the best hands, you can have the anatomical preservation. That's for the youngsters actually. That doesn't mean that the functionality of the nerve is going to be there. So one has to remember that. So considering that situation, leaving behind a little bit of tumor is not sort of, defeat. You have the options, but quality of life is important. The second thing is when we talk of, say, incidental tumors. Now, what about the patients who were incidentally found to have a tumor, and then on hearing examination, they have found to have a little bit of deficit, which they did not recognize. So should they call them incidental? Or they had a deficit which they did not recognize? So that's another question which is there in my mind. And the third thing is that Professor Rajshekhar did say that in India we are losing patients. I had recently a patient coming from UK all the way to India. The general physician was treating his hearing deficit for years, and Manjul is by my side. And in the examination here in India, the ENT surgeon has picked up that he has got a high frequency hearing loss and he has got a CP angle tumor, and this was going on for years in UK. So even in developed countries, we have situations, examples where people miss out, and that's also there. And I've seen patients, a pituitary losing one eye, no vision in one eye, is not aware of it. So, all these things do happen. And that's, so nothing between developed and non-developed. Might be the incidence is higher because of the lack of facilities in our country. The question is there any information on re-radiosurgery for recurrent tumors? So do you have any data on that, about how they do? And of course, the follow-up would be much smaller, I believe.
Yes, there are many series which are trying to perform radiosurgery for recurrent vestibular schwannomas after initial radiosurgery. But according to the general data, overall there is higher risk of cranial neuropathy after such treatment. Another thing that we don't know exactly, well, the cases of malignant transformation of vestibular schwannomas are not so frequent, but still there is, in each individual patient, there is a possibility. Therefore, while such series exists, actually, in my opinion, it's better. I prefer to avoid such treatment. I prefer if there is real recurrence, if the symptoms are increasing. So the diagnosis in such cases is very difficult. So we are trying to follow the patient according to the symptomatology. If there is definite increase of the mass effect, which is accompanied by increase of symptomatic burden, we prefer to send patient for surgery for probably subtotal resection. Then we can have a confirmation, histopathological confirmation that it's still benign vestibular schwannoma. And then for residual tumor, we can do repeat radiosurgery. So this is my opinion about treatment of such patients. Maybe there are some other opinions, I don't know.
Thank you, sir. There is one more question.
My question to Dr. Ian McClellan, like in neurofibromatosis too, like if a patient comes with bilateral schwannomas and one is large, one is very small, and patient is symptomatic of one larger tumor, and you are going for surgery or whatever surgery followed by stereotactic radiosurgery. What about the smaller tumor? Whether you will treat that upfront or you will wait for that, and what threshold? At what threshold you will like to treat that?
Yes, so generally, with our practice, we don't treat the small one unless the smaller one has shown growth and ideally also some symptom, which would be hearing loss. If we see a minor degree of hearing loss and the tumor's grown, then we're willing to treat it, typically with radiosurgery. But as we heard from Dr. Vedantam, as he said wisely, I think, if you have somebody who's asymptomatic and you treat them, you can just make them worse. And so I don't have personally trust that giving radiosurgery to a tumor will not over time cause an acceleration of the hearing loss. It's not that it's going to be guaranteed to do that, but given that you have these cases where there's tumor control of volume nicely just stable over years, but the hearing deteriorates over years, it makes me wonder if the gamma knife wasn't the responsible. So therefore, yes, we would operate on the big one. Typically, as I said, we would leave behind a fragment to try to preserve function and then gamma knife that, but keep an eye on the other one. And we also do encourage, as it was mentioned yesterday, I think quite rightly, we encourage people who have NF2 to learn to read lips, learn sign language, because we have this thought that there's a large chance that they're going to end up deaf no matter what we do. And so what we're trying mainly to do is to delay that until the longest possible time in the future. But we don't guarantee them ever that they're not going to go deaf.
So, sir, is there any threshold of size, or or just you wait for hearing loss?
We don't really have a size threshold. I mean, if it starts to say it's intracanalicular, it's a CUS grade 1 or even a grade 2, we would leave those be. But if they start to push into the cistern, the cerebellopontine angle, then we're kind of more likely to pull the trigger.
Okay, thank you.
Yeah.
Sorry, can I just ask a related question? I work in a proton center now, so we get all sorts of patients, particularly a few patients relatively young, diagnosed with a genetic NF2, and not only have bilateral schwannomas, but also have meningiomas, occasionally different schwannomas. And then it was so fascinating to see this polyclonality. I mean, it does make you wonder that there is something genetic going on there, and then whether, I mean, there are both approaches. On one hand, you say it's conservative, but one could argue why not give slightly larger volumes and improve from 77% to higher and maybe fractionate them if the volume is a challenge. And finally, you have these, I have two actually patients now, young girls, who have incidental spinal ependymomas. Now the question is, should we operate or should we observe? And the families are so stressed and they have had multiple treatments, opinions, bevacizumab, you name it. And then what do you do?
So I think your suggestion of the widening of the target zone and fractionating, I think that's a very reasonable, rational suggestion. We haven't done that, but I mean, the patients, the problem with NF2 is most places don't have that many of those patients. So doing studies on them, making it a rational kind of scientific approach is hard. So there's a lot of ad hoc kind of stuff done. But I think it might actually be worth trying, yes. In connection to the second part with the ependymomas, we've actually been wanting to take our patients with ependymomas in the NF2 group and study them and kind of write out a paper as to what's done with these, what's rational, what makes sense, what the patterns are, because nobody really actually knows. Nobody has published that, and so they're always just sort of looked at kind of in the same way that regular ependymomas are looked at, where we don't tend to operate on them unless they are starting to degrade function, getting myelopathic, that kind of thing. A lot of them, what I've noticed is a lot of them happen in the cervical cord, and including up to the cervicomedullary junction, where risks are definitely higher as you go higher in the cord. So we tend to be kind of conservative on them, but we have certainly operated on them and done so successfully. We tend to use surgery on them as our number one choice, but yet, yes, there are some which are just a little too perilous, if you will, way up at C1, that kind of thing, where we do irradiate them if we see them moving, because we know that even if they haven't gotten symptomatic, they're gonna, and we should probably forestall that, yes.
Yeah, so my question for the neurosurgeon, Dr. Krishna Rajshekar, can answer it. Many patients we see are with tinnitus. Tinnitus is a big issue. I just want to know the outcomes of, operative outcomes of these patients who are managed with tinnitus and acoustic schwannoma. How tinnitus flares out post-operatively in such?
Yeah, that's a very interesting question, because it's one symptom I tell my patients that I can't guarantee anything.
Okay.
If we have patients who have lost their hearing, I've cut the cochlear nerve, and this tinnitus still persists.
Exactly.
So it's obvious that this is a central mechanism that's the cause of this tinnitus.
Same
So
with radiosurgery.
I think this is something that I have at least a handful of patients who have this problem. And several years later they say, yeah, I'm otherwise well, but I still have that annoying noise in my head. And so that's, so on another note, I just want to talk about the patients who have had a failed radiosurgery or a tumor enlarging after radiosurgery, and we have gone in, we do a subtotal resection, but interestingly what we have observed is that the residue does not grow in most cases. So we are a bit hesitant to give radiosurgery at least upfront. We would wait and watch. I don't know whether that's a part of the tumor that has already been sort of radiated earlier and is under control, and we have taken out the growing part, and the sort of non-growing part has been left behind. But that has been our observation about that. I hope I have answered your question regarding tinnitus.
The follow-through question is, if there is a facial nerve which is damaged post-operatively, when do you time the radiosurgery, adjuvant surgery, if it is if there is a meaningful residue left behind? Because there is a paper which Dr. Chernov said timing really doesn't matter.
Yeah. So if
there is a facial nerve damage,
if there is a facial nerve damage, one should wait for
obviously.
a substantial amount of time. I would wait even up to a year.
That's what.
Yeah,
That's what
I don't think there
that,
is a big problem with that, because the residue generally does not grow. Anyway, we wait for 6 months for the tumor to sort of become a ball, and we could wait for another 6 more months to get facial recovery.
Express this, my personal opinion on this last issue. So if there is no difference between early and late radiosurgery, it means that early radiosurgery, even with dysfunction of the facial nerve, wouldn't be worse than delayed radiosurgery. So if the patient come to Kochi from the another side of India with long way travel, probably we should to complete treatment in one session, and then the patient will be treated, and then steadily probably facial nerve will recover. So it's just my opinion. In Japan, the situation is different. In Japan, absolutely, we can follow the patient with MRI, we can delay radiosurgery for several months. It's not a problem at all. But in such large countries as India, with probably some difficulties for patient transportation, maybe we should complete treatment in one session.
Just to understand, are you suggesting we do radiosurgery like within a few weeks of the surgery? 3 months is typically what, 6 months is what we wait for, typically 6 months, because the shell has to sort of become a good target, and that's what happens. So here, its only thing is that once the facial nerve is damaged, we are a little worried that adding radiation insult to injury, like, you know, you're going to give radiation there. So, so 6 months more is maybe not a bad idea. But I agree with you. You may lose these patients to follow up also. That's the other side of the.
So a couple of things. I think in the of the topics that were discussed. So in the reirradiation setting, actually, in what we've been following is surgery as salvage, and then waiting for any recurrence. So we don't directly add adjuvant radiation therapy. In the upfront setting for a planned subtotal resection, you know, there's a lot of data going back and forth between those, but now that we have 2 randomized trials which are positive in the upfront setting, essentially we have transitioned to change our guidelines to offer immediate post-operative adjuvant radiation therapy or radiosurgery to those patients, given that you can essentially improve their radiographic control and that there was no difference in hearing outcome. And specifically, as was mentioned on the first day, there's actually no difference in quality of life. So in the VREX trial, they looked at 26 different quality of life parameters, both patient-reported and physician-reported. And there wasn't any difference in any of those outcomes. So radiosurgery as an early treatment did not adversely affect a patient's quality of life afterwards. And so I think being aggressive in the upfront adjuvant setting is what we have moved towards. And then finally,
so in such case, what is the advantage of early radiosurgery? You mean there is no difference between early and late radiosurgery, or there is some advantages of upfront radiosurgery?
Yeah, so the advantage of doing an early radiosurgery is to A, preserve as much hearing as you can, and B, is to prevent tumor growth as well. I mean, you have 2 randomized trials in the upfront setting, right? So the base of Skull Society recommendations are now going to get changed. We used to have level 4 evidence, and now there's level 1 evidence in that we have 2 randomized trials. So I think at least in the United States, this is now, I mean, we've just had meetings over the last month since this got published to change our recommendations in the upfront setting.
One question about, is there a threshold? Like, you see a teeny weeny residue.
Yeah, but even, yeah, so even, yeah, so the question is how tiny is too tiny to not offer radiosurgery? So it's unknown, actually, in the randomized trials, any patient with a asymptomatic, newly diagnosed vestibular schwannoma, which we're actually seeing in the United States a lot because people get MRIs for any reason, right? So they hit their head, they get into a car accident. Every single emergency department will always do an MRI scan for any patient that comes in with a headache. But in these randomized trials now, because there is a benefit, we don't know, because those patients were enrolled and they would have been benefited from upfront radiosurgery. So there is no known threshold as to what is too small to offer treatment to in the upfront setting. But it should be at least a consideration, or what we've changed the guidelines to is at least the patient should have a discussion with a radiation oncologist. Doesn't mean that you have to give upfront treatment. Even in, for example, you know, United States, France, Canada, where you have access to a lot of imaging, I'd say maybe not as much as Canada, there are still patients who are lost to follow-up after they're told to continue follow-up just to prevent any tumor growth or loss of hearing. The national estimate is 16% of patients that are told to have their next MRI scan actually never show up for any additional follow-up. And so the problem is you're losing a lot of patients, and if you would treat them with 1 fraction of radiosurgery in the upfront setting, you have a very high control rate, over 90%. So at least these guidelines will start changing.
Okay, so as you can see, there are different parameters of strategies for treatment in different countries as well. So it's.
Since we are running behind schedule, I think we have to conclude this session. I thank all the speakers as well as the audience for the excellent talk and discussion. Thank you very much. I thank my co-chairs also. Thank you, sir.
Our third plenary lecture is set to enlighten us about modern radiosurgical strategies for the management of vestibular schwannomas. Our moderators for this session are Professor Nishant Sadashiva, Consultant Neurosurgery, NIMANS, Bangalore, and Dr. Pavel Ivanov, Head of Radiosurgery Department, Medical Institute, named after Dr. Berzin Sergey, St. Petersburg, Russia. I request our moderator to introduce our speaker.
Okay, we start our next session, and I would like to invite Professor Singh to give his talk on the topic of the modern radiosurgical strategies for vestibular schwannomas.
Good morning, everybody. I thank Dr. Debrata and the organizer for inviting me for this talk. But at the outset, I'd say that probably everything of the radiosurgery has already been discussed. So let me see how I can add a little bit more. So, yes. If you see the natural history of vestibular schwannomas, we always see that the tumor will grow once it is diagnosed, but the rate and the time of growth is unpredictable, and usually it is not associated with age, sex, the tumor size at the diagnosis, or the symptoms. So it is independent of we cannot say that this tumor is likely to grow or not, and the growth is definitely certain if you have a follow-up, and we will always see that the tumor is growing, and it is just a matter of time, and almost all tumors grow over a period of time. But around a big set of tumor, around 20%, once they start growing, but they stop at some point of time, and then they remain static for quite some time. So they may remain static for that time, and then again stay regrowing also. That is also a subgroup, and again we don't know that who are those patients. A very small subset of patients, around 5%, they actually go with the reduction of the tumor size. So again, we cannot say that who are those patients at the diagnosis. And on an average, the growth is around 2 to 6 millimeter per year, and a few of the studies say that it can be as high as more than 1 centimeter a year also. Now we see that we have come a long way in the management of the vestibular schwannomas, and we see that, let's see that what is the current status. It has become the gold standard for the small and the medium size of the vestibular schwannomas, and because of its superior safety. And the very many prospective studies have documented good control in the facial functions as well as the hearing preservations as vis-a-vis surgery. So, and if we, in the current era, we say that the surgery may be a good choice for the small to medium size tumors, so we have to take that with a pinch of salt. But unless we are doing that for the hearing preservation, that is a totally intracanaliculaar small tumors, where the surgery may have a little edge on that if we are only targeting for hearing preservation. And for the Coos grade 4, a lot of things have been discussed since morning. The subtotal removal followed by the radiosurgery has become a norm. In a country like India, I can tell you for the visitors from outside that by and large in our setting, we see huge tumors, and they are always Coos grade 4, and rarely we see that Coos grade 2 or 3. And those tumors, they are compressing the brainstem, distorting it, associated with hydrocephalus. So radiosurgery or any sort of the radiotherapy procedures, they are unlikely to control those tumors. So the surgery has to be done for those patients. And radiosurgery has become the standard of care. Things have already been discussed for the large vestibular schwannomas. So what is large vestibular schwannomas? Any tumors more than 3 centimeters, that is our conventional teaching, is considered a large tumors. But I would say that the volume more than 10 cc is definitely considered large tumor, because sometimes the tumor may be elongated, but the volume is less. That may not be a large tumor. So what to do? Because we see these tumors so frequently in our clinical setup in India. So no amount of radiosurgery upfront is likely to treat. We are going to kill, because the brainstem is pushed, it is thin like paper, and the patient will have hydrocephalus, lot of posterior fossa mass, not a suitable case. So the tumor with significant brain compression, they require surgery, and that has to be the first choice. A large vestibular schwannomas with tolerable mass effects. What are those tumors like this? On this side, so this is a large tumor, no doubt it is compressing the brainstem, but patient may not be symptomatic for the only the presenting complaint might be, and many times we see that only the hearing loss, and the patient is totally stable. There is no neurological deficits except the hearing loss, and there is no hydrocephalus. So that becomes confusion among the patient and the treating physician whether to recommend a radiosurgery or the surgical excision also. So the tumor volume definitely more than 15 cc is considered, should be considered a cutoff line with the definitely have the poorer outcome in the radiosurgery as compared to the surgical procedures. Large vesicular tumors, to treat them with the gamma knife, the decision has to be taken with great care, and we have to factor all many things, and including the pros and cons of going ahead with the radiosurgery for the large tumors. Patient should be counseled for the same, and have to tell that these are the options available, and gamma knife versus other sort of radiosurgery might have got the complications, and you have to accept that. Unless the patient insists or the patient is not fit for that, only then we have to go ahead. This is an index case done at our center. So you see that a large tumor around volume around 12 cc. So it is very good control. No question about that. Tumor has shrunk in size and the brainstem compression has completely gone. But every patient is not like that. We have to accept that. If we look at the literature about the thing that any tumor more than 10 cc, they will have significantly poorer outcome as compared to the small group tumors, and the literature is full of that. And how to make a decision in the large vestibular schwannomas, the advanced stage, and the patient has the poor medical condition where cannot be subjected to surgery, then you have to take these decisions. And the lack of significant brain compression should be the criteria. And there should be, even if it is compressing the brainstem, so there should not be any brainstem sign. If the patient has developed brainstem signs, so better to go ahead with the surgery rather than radiosurgery. And there should not be any hydrocephalus in these patients, because many patients post gamma knife, post SRS, they may have a progression, pseudo progression, and that can worsen the hydrocephalus. So they can deteriorate quickly, and they may require the surgical intervention in the emergency. Gamma knife, this is another very curious point in our setting, because this is not uncommon. We will always come across in our clinical setting that the cystic vestibular schwannomas has come to our clinic. Then how to manage that? So what are the cystic clinical vestibular schwannomas? So there may be a very small cysts inside the tumor, few cysts, many cysts, or a very large cyst, very thin enhancing wall, or maybe a solid tumor with a very large peritumoral cyst. So these are the definitions of cystic vestibular schwannomas. So now this is also labeled as the vestibular schwannomas, cystic. So thing is that if I think everybody will agree this is a small cyst, this is a very well-defined tumor, the radiosurgery is likely to help these tumors quite well. So I think there is no question about that. So now if I look at this, so this is also a cystic vestibular schwannoma. So what to do about this? You see that there is hardly any, you can see that there is practically very thin cyst wall along the brainstem, and even if we cover everything, so we are not sure that this thin cyst wall, which is the part of the tumor, is going to get the adequate radiation. So the outcome of these tumors are likely to be different. So not sure that this is likely to be controlled with that radiation therapy. This is an index case, cystic schwannoma on the left side, and there is one small cyst and one large cyst, but more or less is very solid tumor. But given a radiation therapy, that gamma knife, this tumor has significantly grown. The cyst has grown in size, causing the brainstem compression. So there is no option left but to go ahead and do the surgical decompression. So even then, despite knowing that, because this is a very heterogeneous sort of group, and radiosurgical outcome is very varied among different sort of tumors. So there is no uniformity in these group in literature, because we have a lot of papers on the efficacy of gamma knife in cystic schwannomas, but every tumor of the cystic schwannoma is different. So there is no practically, because to me a small cyst is a cystic, another thing is very large, which is practically not suitable for a gamma knife. So even if we consider that, so there is no comparison between these two groups. It can be, gamma knife radiosurgery can be a very effective method for the cystic, but we have to carefully pick and choose those tumors. And only then we can ensure that the patient can have a good optimal outcome. But if there is a cyst progression following gamma knife, and it is progressing, sometime it can progress within weeks. We have seen that a patient was okay, their cyst has increased in size. I can see that in my clinical practice. I have seen few patients, they come back within next a month later. So with all sort of posterior fossa symptoms, cerebellar symptoms. So the once we re-image them, the cyst has significantly grown in size. So those are the patients, they need immediate surgical intervention. So that is important. So we have to understand that this is a varied group, and we cannot generalize that this radiosurgery is likely to be very, very effective in them. No doubt this is one case, very large cyst, but in this case you see that I did that, but thing is that cyst wall is quite thick, and very large cyst is there. Little skeptical to go ahead or not, but this patient responded, but that cannot be in every single case. Another group is that intracranicular vestibular schwannomas. Now it is an era of MRI, so that every patient who is having any problem in the head, maybe a mild headache or anything else, or there may be a seizure, so going ahead with that MRI, so that the small intracranicular vestibular schwannomas are likely to be picked up. So what to do with that? Whether we should upfrontly treat them or to have a regular follow-up, that is again a matter of debate. So for example, a patient comes with the tinnitus or with vestibular symptoms, or maybe a hearing loss, gone ahead with this imaging, and a very small intracranicular vestibular schwannoma is there. Then the matter is again in our code that what to do with that. So whether to follow or to do the upfront treatment. So let's say that what the literature say. So I have picked up this series, and with a 136 consecutive patient with the unilateral intracranicular vestibular schwannomas. So the tumor control in this case, they were treated, all patients were treated, and the control rate, even for the small intracranicular tumor, the control rate is 91%, which is actually lower than the regular thing. The regular sporadic vestibular schwannoma, where the control rate is more than 95%, so it is slightly less. And the hearing improvement, in many of the patients do improve in hearing. They present with hearing loss, and the hearing will improve up to around 23% cases in this series. And in another around 26% patients, the hearing was stable. But now we have to look at that. It declined in 50% of the patients. So it is something like that. We cannot say that, oh, it's a very small vestibular schwannoma, we can go ahead with do that, because as a hearing preserving radiation surgery. So is it likely to help this patient? But even in intracranicular tumor, taking all precautions, many of these subjects will have the reduction in the hearing. So that we have to counsel the patient, tell the side effects, so that we are not sure that your hearing is likely to be preserved or not. And in this series, that 4 patients developed a transient facial paresis, even for the small vestibular schwannoma, and the 3 patients had hemifacial spasm. No doubt everything resolved spontaneously, but it developed. And another aspect of the small vestibular schwannoma which we have to factor in, that is the vestibular symptoms are much more common in smaller tumors. Why they are common? Because in tumors, but if we see that the normal natural history of the vestibular schwannoma, they start growing, the patient will have some sort of vestibular symptoms. The tumor has grown further in size, gone into the cistern, and because that the vestibular symptoms will disappear over a period of time. So they were very subtle, they were gradual in onset, and the patient has tolerated those symptoms well, and they disappeared. Now we do the gamma knife for the larger tumors. So that's why those patients do not develop the vestibular symptoms over a period of time. But a smaller tumor which person has never faced a vestibular symptoms, so once we give a very high dose of radiations, they actually develop. The incidence is higher. So the slightly lower tumor control may be due to the targeting error. Also, we should not forget that a very small target in gamma knife, and it is actually in the periphery of our center. So it is not exactly in the center of our 3D volume. where we actually plan our target. So it is little over there may be some distortion, image distortion factor which has to be factored in when we are doing the treatment planning, because we have to warn them. Sometimes we are planning very good planning, but even then the control rate or the side effects are more. So I personally feel that it may be a little bit due to this maybe the distortion or the targeting factor is there. Lot of things have been said regarding the hearing preservation, but we must understand that the hearing will decrease following radiosurgery, and the mean pure tone hearing loss worsen in all patients, all frequencies when compared to the pre-treatment levels. The dose margins, when the dose margins are overlapping the cochlear nuclear in the brainstem, would preferentially cause the low frequencies hearing loss, but exposure to the cochlea would cause the higher frequency deficits. Invariably, there is loss at all frequencies, which may be attributed to the exposure to both brainstem as well as the cochlea. The long-term follow-up will reveal the progression of the hearing loss. If we follow up these patients for 10 years, we have done radiosurgery for a small tumor, for example, today. So patient was doing well for 2 years, 3 years, 4 years, 5 years. We saw that very good result. Now, if a patient come back around 10 years later, so he will show a deterioration in hearing. So that long-term studies are definitely needed. So we cannot say that the patient is very good. Many of the literature, if we see that long-term study, the median period is around 4 years, mean is around 3.5 years, but nobody tells the median or mean of 10 or 15 years. So that is the situation. Dose-dependent toxicity beyond the tumor margin is the reason. So we have to factor in that cochlea or in the brainstem. So if we increase the dose to treat this vestibular schwannoma, the chances of the hearing preserving is less. How to make the strategies? We know that around 65% of the hearing preservation can be achieved, and it is very well documented in the literature. And the serviceable hearing of around if the patient has the serviceable hearing before the treatment. Lower radiation dose has the better hearing preservation than the higher dose. So if the strategies has to be like that, if the tumor is smaller in size and the patient's hearing is very good preoperatively, and at the same time it is, for example, incidentally detected, so keeping a little dose lower like 11 gray, so may be a good option. So but thing is that again, whether this tumor will be affected or not, that is we have to bargain that. The lower dose will have the lesser amount of the tumor control, but the higher hearing preservation rate, and vice versa. And the tumor volume, patient age does not have significant bearing on the hearing outcome. Another thing is that cochlear radiation dose. What is the tolerance dose? A lot of studies have done, the higher the cochlear dose, lesser is the chances of the hearing preservation. So cochlear dose more than 6 gray will definitely have the poorer outcome as compared to the cochlear dose less than 6 gray. So by and large, if we search the literature, people will settle down cochlear dose less than 5. We try to keep it around 4.5 gray. So thing is that many times it is very difficult to keep the 4 or 5 gray level in a large tumor with the good preserving good hearing and that ear, because if we are not treating the intracanalicular portion, we have to undertreat that. Only then we can achieve that the radiation dose to the cochlea is less. But that will lead the small part of the intracanalicular tumor undertreated. So that can lead to the growth later also. A good conformal plan with care to reduce the cochlear and the brainstem dose should be the idea to reduce the hearing deficits. I think this aspect has already been discussed. So I will just see that the failure in gamma knife, we have done the gamma knife or the stereotactic radiosurgery and the tumor has not responded. And in a meta-analysis of the 8 studies comprising around nearly 200, that is now 194 patients to be precise, the 2.2% patients had the failure, that is, they had the increase in the tumor size and that required further treatment. So the mean treatment with the first and the second was around 50 months, and the median marginal dose for the first as well as the second SRS around again the 12 gray. In the both time the median of around 12 gray was thing. No doubt the range is varied from 8 to 12, 8 to 24 in the first go, and in the range was 9.8 to 19 in the second. The outcome is that the tumor stability was seen around 30% of the patients, and the tumor reduction was seen in around 50. So it means that a very significant patients, they responded well. But the tumor progression around 50 out of 190 patient was there. But again, these tumor increased. Probably they remain static after they increased, and then they steadied after a few years. But they rarely require surgery, most of these patients. The trigeminal numbness incidence is definitely higher than the first treatment, and the worsened facial nerve was reported in around 4.3%. This is significantly higher as compared to the first sitting. And the hearing loss was again further noticed in the 54% of the patient. So, but now, where are we now? The recurrence is only 2%, and only if we treat those recurrences with the radiation therapy, this stereotactic radiosurgery again, then out of those 2%, around 85% patients are likely to get benefited. So this treatment is of benefit and should be offered for these patients. But despite our care and whatever we do, if the tumor is significantly increased, causing the brainstem compression, and with the hydrocephalus, so the re-radiation is not the answer. We have to subject that patient for surgical decompression. So I think Dr. Ayan has talked a lot of things. I have just kept one slide, not more than that. So gamma knife for vestibular schwannomas in NF2, it is a formidable situation, and we all know it's a very difficult situation to treat, because the patient is your lifelong friend. He will keep coming to you with one problem or the other in the cranium, in the spine, or elsewhere. So we have to make sure that these are taken care well, and we have to take those decisions very, very carefully, so that the patient will have a good quality of, because we cannot cure them, we can just offer them the good quality of life. So but we must understand that in NF2, the gamma knife radiosurgery is definitely, it is little less efficacious as compared to the sporadic cases. And the progression-free survival at 5 and 10 years is 88 and 75%, which is significantly less as compared to the sporadic groups. And the same thing is that the functional hearing is, again, the incidence is low. New facial palsies, subjective instability, trigeminal neuropathies, and the incidence is more or less is not different from the sporadic group. The low rate of mortality and morbidity as compared to the surgical decompression, I think then it makes sense that these patients should be subjected to radiosurgery when they are suitable for that. So we should not just keep on following them forever. So unless otherwise they are become bigger in size, they will require surgery, but the radiosurgery has to be offered at the right time. Another thing is the pseudo progression following gamma knife. So the average 20% of the tumors will increase in first years, and usually they get stabilized over 3 years period. And after third year, we see that there is a trend in the decline in the tumor volume, and which is usually the case in most of the patients. And at 7 years, the most of the tumors are at the 60% of the volume at the time of SRS, that is a 40% reduction is seen. So if we look at this thing, this is treatment, how they behave. So there is an initial tumor volume was 3.8. We gave the gamma knife, and the tumor increased over a period of time, which is around 4.1 cc became, and then it is reduced in size, which is less than the treatment tumor volume. That is one thing. Another thing is that there is a small vestibular schwannoma treated, but significantly increased, and we initially were wondering what is happening. So this is around 40 months later, but we just, even if they are not touching the brainstem, we followed up this patient, and then this tumor has significantly reduced, but the reduced volume is more than the treatment volume. So these pattern may be there. So always the tumor will not reduce to the pre-treatment level or the less than that. Sometimes they increase in size, and then they remain stable also. But they require regular follow-up. Never ask the patient that you have been cured. So keep the patient for follow-up. What we do at our center, so we try to do the very good conformal dose plan with a combination of the isocenters, well placed with the differentially weighted for a very good treatment plan, so that to reduce the complications. Usually we keep the 12 gray by and large with the 50% of the isodose line, and 11 gray only to hearing preservation to very small tumors, and we keep the patient informed that it might not be a very good dose, may require a subsequent treatment if the chances that your hearing is likely to be preserved. That we try to keep the cochlear dose less than 4.5 usually, but less than 5 is the target, and the brainstem dose is always less than 12 gray. Our outcome is around the facial worsening, rarely seen. I think very anecdotal, around a few cases, around 2-3 patients, and that is not a very significant weakness, it is a partial weakness, and many times those patients who do develop weakness, actually over a period of time they improve over the course of steroids. And the hearing output in our center is around 50% over 5 years, and the tumor control rate is more than 95%. Now again thing is that we should see that what are the complications of the radiosurgery. Actually, as a human, we should not say that I do not have complication in my studies, and we have to accept that the complication is part and parcel of our game, and even the smaller vestibular schwannomas are associated with a higher rate of post-decay vestibular symptom, which I already discussed. Radiation edema, the patient is doing very well, and we see the patient after maybe a 6 months imaging, or even sometime later also. So there is a lot of radiation changes into the brainstem and to the adjacent peduncle or the cerebellum. So many times these patients are asymptomatic and nothing is required, but you have to keep those patients on a close follow-up. So these are the patients may deteriorate also. And radiation edema is the chance which happens. It is a real problem, and it is more in patient where the Coos grade 4, or many times a few occasions the Coos grade 3 also can develop that. But if there is a radiation edema, they require steroid therapy, and sometimes it is quite long also, around maybe 2, 3, 4, 4 months also. And if it is responding well, fine. Otherwise, you may have to use that bevacizumab also. Delayed radiation necrosis, I think that is also a real scenario, and it can happen. So our center was established in 97, and it is going to be around nearly 30 years now. Thing is that the radiation, many of the things, these are very, one case I have brought it out, and radiation complications can happen after 15, 20 years also. So for AVMs, for pituitaries, for even vestibular schwannomas. So the patient are turning up around 18 years with the radiation necrosis, and with all the hemorrhages in the peri. AVM has gone, completely disappeared, but there is a hemorrhage after 20 years. So, and there is a lot of edema, and there is a necrotic patch. So what to do? The medical therapy is not going to work, and you have to enter surgically to take that all thing out. So that has to be kept in mind, that a small term follow-up is not the answer, that we have to look for the long term follow-up. So this patient was a cystic schwannoma, very well covered, but this developed this complication. This is an intracerebellar problem, and this is a very recent case, around 3, 4, 5 months back, and required a surgery, and the tumor was very small residual tumor, but there was significant necrosis in the peduncle and the part of the cerebellum. We took it out, and it was a radiation necrosis, nothing else, no new tumor development, no glioma, but this was all radiation necrosis. So these are the complications sometimes happen over a period of time. We should accept that, and we should be even telling the patient that in the long term you have to have a follow-up. This is a paper from Pittsburgh group for the quality of life issues. So good quality of life in the long term. The vertigo has the greatest impact on quality of life, followed by imbalance and then the hearing loss. These are the factors. Tinnitus in this group, interestingly, they said that did not have significant impact on quality of life. But I personally disagree. Many patients, they are very, very bothersome, and they really are bothered about that, their tinnitus, which is actually killing them. So that can be a factor which patient is very well treated in terms of volume of the treatment, and the brainstem compression has completely gone, and the tinnitus sometimes cannot leave the patients back. And the participants overall reported they are satisfied with the current level of functioning and activity. So I'm just concluding here. So the SRS is currently the standard of care, no doubt about that, and likely to halt the progression of the hearing as compared to the other modalities, and very low risks of cranial neuropathies all. And the redo radiosurgery is definitely likely to work in suitable cases of recurrence, and it has got a very low morbidity and mortality, and it's an excellent outcome. Thank you.
Thank you very much, Professor Singh, for your excellent presentation. I have a question for you. If the tumor recurrence after radiosurgery confirmed, but in some cases we see that not the whole tumor growth, but only partially one part. Sometimes we see such situations. What will be your decision to irradiate the whole tumor or partially?
You mean to say that if only a part of tumor is growing?
Yes.
I know that they're very difficult to differentiate on imaging that which part of the tumor has actually grown. Okay, definitely, but if the tumor is still within the volumes of our re-radiation surgery, so I would like to radiate the whole tumor again, not a part of it. Yeah.
Thank you for your insightful talk, sir. I have a question. When you demarcate the cochlea, in small and medium-sized tumors with lot of lateral extension, with preserved hearing, do you decrease the coverage, or do you want to increase the coverage and despite increased cochlear dose in your practice?
See, the idea is always to cover the tumor completely. So the situation is that if the patient has got a very good hearing, I would say that incidental tumor, good hearing without any, maybe a very around 10 decibel loss. So I would like to reduce a dose to the 11 gray, and maybe that the extreme lateral end of the internal acoustic canal. So I would like to remain little hesitant to go to that, because otherwise the patient, see, ultimately in the short term the patient may have a good hearing, but after 5-7 year young patient, so they will have hearing loss. But you have to bargain between the tumor control versus that. That always a matter of debate. I think we need to learn over a period of time more.
So your target is the maximum dose or the mean dose to the cochlea?
See, ultimately there always is a 12 gray with a 50% isodose line. Okay, so thing is that the mean, that the peripheral marginal dose has to be there.
My question is to the cochlea, for example, if
no,
you...
Yeah, exactly. It is basically the marginal dose should be less than...
the max dose should be less than 4 or 5.4.
Yeah, exactly.
So thank you for this comprehensive talk. And
yes,
yeah, I think we are living in a very interesting era where more and more patients are being diagnosed with vestibular schwannomas because of the early diagnosis of the hearing loss, because of more mobile phones and MRI. And at the same time, if you search for the natural history of a vestibular schwannoma on PubMed, you will find close to 200 articles. So we are lacking a definite knowledge about how should we define the growth of a vestibular schwannoma. And most of these patients, then they come with a psychological burden to get treated because they got diagnosed, and there are varied sources which show that the tumor should be treated, otherwise it may grow. And then we are in a fix whether we should treat in a patient with a functional preserved hearing or not. But as the tinnitus was the discussion today, I would like to say that the patients who have a tinnitus at the presentation, in their natural history, they are at the more risk of losing the preserved hearing in comparison to the one who do not have the tinnitus at the time of the presentation. So that's a very important, I can treat the tinnitus, but it can act as a prognostic variable factor with which I can categorize my patients, whom should I treat proactively and whom we can wait for the observation.
I know, but that I agree, but thing is that even then, that outcome sometimes is very unpredictable. Yeah, please.
Is it possible to go back to the slide set, just to go to the AIMS outcomes slide and that you had? So it's about 10, 15 slides back maybe. Just go to the AIMS outcomes. Right there. just look at this. So, sorry, that one. Go back one. So one thing here is if you look at, for example, the cochlear dose here in this area, you can see that the plan is actually spilling out to include the cochlea. So here, I think if you put your constraint on there as your mean dose, because if you put it as a max dose, as your peripheral marginal dose, you'll never make it, and the plan will actually never work.
Exactly.
So I think here the key thing is, and this will come out in the ISRS guidelines, is to try and reduce the mean dose, because then you'll see that plan actually pinch out there. So it'll try and reduce the dose versus in this plan, you don't see that
Exactly.
actually as a
So see
constraint.
if you look at because this case the patient didn't have the hearing, so that's why it is.
So you didn't even
exactly.
reduce it. Okay.
So thing is that this patient, because you see that everything is covered.
Correct.
And if the patient has got the more than around 60 decibel or more loss, so preserving the hearing, I think not. Preserving the tumor is the idea. So you have, because see, smaller tumor, and if the patient has a good hearing, so then you have to actually mark. You see that we have marked the cochlea, but we are not bothered about, because this patient, this particular patient had a poor hearing. That's why I didn't put up those slides.
Yeah, but going back to that question, so it's the mean dose typically that's 4 to 5. And then the second thing that you brought up at the very beginning, I think is really great, about not just tumor size, but tumor volume.
Yeah.
And I think, we see this at least more so in the neurosurgical literature, just looking at either the Coos grade and the tumor maximum dimension. But the volumes are not as often evaluated.
Yes.
In radiation oncology, we're always delineating the tumor, and so we end up getting a volume amount. There will be the new ISRS guidelines for vestibular schwannomas. They're accepted. They will be coming out in the next week or two. The key factor was actually the volume that fell out. And it was the same number that you had here, 10 cc's. So above 10 cc's, there's going to be a recommendation to consider not single fraction radiosurgery in those patients. The long-term outcomes are not as great. And to consider, if you're going to do single fraction, do surgery and then radiosurgery to the residual, rather than upfront single fraction radiosurgery. So that 10 cc's is going to be very key.
Exactly. This 10 cc volume is not only for vestibular, even for the other tumors in the brain, like the metastasis, as well as for the AVMs also. So many times the AVM, you see that they max out at 15, 20 or even more than 20 cc. So we cannot treat them in one go. Then you have to devise different strategies. Either you fractionate dose or the volume fractionation. So there are different strategies you have to make. So another aspect, because here the brain, it's not going to get a significant dose, but again the 12 gray volume, that is also very important. So we have to factor in what is the 12 gray volume of the 12 gray line in the brain, which is volume of the brain which is getting that radiation. So if it is exceeding that, so again the risk of complication, radiation, edema, necrosis is likely to be the high.
Thank you, sir, for your presentation. I have one question. Sir, actually, I have a question on that redo radiosurgery. So my point is, suppose you have treated a patient with 12th grade. So when you are doing redo surgery, what is the prescription dose you would like to give second time? And what are the factors you are going to consider? And does time to failure has an impact on this prescription planning?
Usually in radiosurgery, many times when we cause a failure, usually after even 4 years, 5 years. So many of the patients, they are not, because sometimes at 3 years the tumor has increased in size. So we keep in size that it may be a pseudo progression. We like to follow that patient up. So we always say that the tumor actually has failed to radiosurgery is after 4 years or 5 years. So unless this is causing a significant brainstem compression, only we will go ahead with the surgery. Otherwise, we'll keep a watch on that patient. And if after 4 or 5 years the tumor is still growing and is causing compression or is likely to cause compression, so then we will pitch in. And by that time, our prescription dose will not change. It again remains around 12 gray only. And we will try to cover whole tumor. We will not say that a little part of tumor is to be covered. We try to cover the whole tumor again.
Just extending the discussion on the volume of the tumor, the 10 cc or whatever, 8 or 12 cc. As Rupesh was mentioning about single fraction, but in community, people are using 2 fractions, 3 fractions, 4 fractions, 5 fractions.
and it's not very well established how the outcomes, exact doses. Of course, the radiation oncologists calculate the dose based on alpha by beta, but it's not well established about regarding the outcomes, regarding the hearing preservation, etc., etc. So I think there also we need to get a clarity on what kind of dose schedule should be used.
So for the ISRS guidelines that are coming out, we didn't actually put the 3 fraction guidelines because there isn't, and as you mentioned, any good long-term data. I think a lot of people in the community will use 24 and 3, potentially in patients who have good hearing, maybe 21 and 3, but that is kind of low. What we ended up writing is 25 and 5 for the larger vestibular schwannomas, and that's actually borrowing a lot from pooled series that include other benign tumors. And now there's long-term prospective data for 5 fraction for meningiomas, which have very similar natural history to this, with long-term tumor control in over 90% of cases. So there's a new Italian series that came out. So we actually end up using that for the current vestibular schwannoma FSRS guideline.
Okay, thank you very much again, Professor Simon.
I have a question to sir. So when we are trying to preserve the hearing by giving a lesser dose like 11 gray, are you just worried about the marginal dose keeping to 11 gray, or you also keep a check on the hotspot within the target volume, because there is a cochlear nerve also?
See, the hotspot will always come inside the tumor. It cannot be outside the tumor. So then we keep the 50% isodose dose, that hotspot has to be inside the tumor. It cannot go out. So we are actually covering the tumor completely and try to make sure that our radiation limit to the cochlea is within acceptable limits.
Thank you very much for the interesting discussion.
I'm sorry, it's just a comment, so I'm sorry. There was just an observation that we had a few years back. We were treating CP angle meningiomas. They are tumors, benign tumors in the same location as benign meningiomas, CP angle meningiomas. They are meningiomas, benign meningiomas in the same location as vestibular schwannomas. And we noticed that the hearing outcome is much better with CP angle meningiomas. We were perplexed by this. So we did a comparative study between the hearing preservation with vestibular schwannomas and CP angle meningiomas. And we found the hearing outcome much better with the CP angle meningiomas than vestibular schwannomas, although both had the same cochlear dose to both of them. The only significant factor was the Gardner-Robertson grade 1 was more common in the CP angle meningiomas than the vestibular schwannomas. That's the only significant factor.
So I think following comment of Professor Amaral Shehabi, I will say that there is Japanese study of the facial nerve schwannomas and exactly the same data. The cochlear dose in these cases was much higher than so-called safe dose, and still the hearing preservation was well enough. So it's not only cochlear dose. Cochlear dose is important, but it's not only cochlear dose.
Thank you very much for your discussion, but we have to close the session.
Thank you. We'll not have an official tea break. Tea will be served outside. People who can take at their convenient time. We'll proceed with the sessions.
Moving on, we have the next plenary lecture on radiosurgery of non-vestibular schwannomas. I invite Dr. Vijay Gopal K.S., Consultant Radiation Oncologist at MVR Cancer Center, Calicut, and Dr. Tanvir Shahid, Consultant Radiation Oncologist at Apollo, Kolkata, to moderate the sessions. I request our moderators to introduce the speaker for the session.
So we had a extensive and exhaustive discussion on vestibular schwannoma, and from there we are moving our gaze to non-vestibular schwannoma, which is a rare entity. So for that I'd like to request our speaker, Professor Pecker, for giving his deliberations.
Thank you so, Thank you so much. So, the subject of this talk will be non-vestibular schwannomas. So, we do see non-vestibular schwannoma very seldomly. They are only around 10% of the all intracranial schwannomas. Of course, most of them are vestibular schwannomas. But if we do see a non-vestibular schwannoma, they are mostly trigeminal, then jugular, then facial, then 3, 4, 6 nerve schwannomas, hypoglossal schwannomas are very seldomly seen tumors. So, as an anatomical reminder for the students and the residents, we do deal with these kind of cranial nerves. These nerves has Schwann cells around the axons, so the tumors growing from those Schwann cells. So, if you begin with the trigeminal schwannoma, it is a tumor of trigeminal nerve. So, in T2 image, yes, you see here the tumor. It's a partly necrotic cystic tumor. It is in the T1 contrast like this. If a patient has trigeminal schwannoma, he may come to us with facial numbness, facial pain, dysesthesia, sometimes diplopia, and headache. And when you look at the literature, you may see a lot of classification for trigeminal schwannomas, but these classifications are mostly for the surgical intervention. How can I approach that tumor from retrosigmoid or medial fossa or other kind of skull-based surgeries, etc. So for us who use radiosurgery for the treatment of these tumors, these classifications are not so important like in the surgery. So what can we do for a trigeminal schwannoma? We can totally remove the tumor or subtotally remove and do radiosurgery for the residual part, or directly we can use radiosurgery for these tumors. If you do surgery for trigeminal schwannomas, you may expect to have facial hypoesthesia in this patient. You can see different numbers in different series. Maybe in the experienced hands, this number is low, but you see here it is around between 25 to 80%. 80% almost means all patients I had facial hypoesthesia. Also, because of the neighbor cranial nerves in that area, you may see some cranial nerve deficits for third, fourth, sixth, and seventh nerve. So they are very bad for the quality of life. And other surgical complications. If you operate a patient, you may see CSF fistula, hematoma, infection, venous infarction, everything. These are ordinary surgical complications. You may see it in the surgery for trigeminal schwannoma also. And the total excision rate, when you look at the literature, you may see between 50% to 100%. If you are so aggressive, you may want to remove all the tumor out. You will get happy when you don't see any tumor in the postoperative MR. But in some articles, in some series, you see that subtotal resection is mostly choice of surgery. So there is an consensus statement of EANS skull-based section about these schwannomas. So in this article, there is a statement like this. Gamma knife radiosurgery is only one platform to deliver stereotactic radiosurgery. Of course, as a gamma knife user, I'm very happy with this sentence, but I think this sentence is not correct. So, and this article was published in 2022, last year. So, if I read this sentence in this article, how can I believe other sentences in this article? So to all article, I'm telling it to the young friends here, for all articles, all presentations, you have to be very skeptical. You must evaluate everything in your mind. And in this article, they said that stereotactic radiosurgery offers good control rates for smaller tumors, trigeminal schwannomas, and can be offered as a primary treatment in those cases. So this is one of our articles in the past about trigeminal schwannoma radiosurgery. In that time, we was using here, you will see, our mean dose was 16 gray many years ago, but today we mostly use 12 gray for trigeminal schwannoma. If it is larger, it can be 11 gray. So the success rate for all these series here seems to be more than 90%, and most of them are 100%, but you may see very seldomly facial numbness or facial pain kind of complications, side effects after radiosurgery. When you compare it with surgery, it is much more better than surgery. Another article, it's a new article from recently published article from Pittsburgh, and they showed that they do have a good tumor growth control rate, and also here you see the complications, the rate of the complications, and the clinical improvement of the patient. And when you compare surgery and these results are in favor of radiosurgery, of course. Another paper from Marseille group, and they also checked their results for trigeminal schwannoma, and they found the tumor growth control rate more than 90%, and most of the tumors decreased in the MR image. Only progressed tumors is 9% in this group, and trigeminal neuralgia improvement, they mean pain improvement, is 63%. Third nerve improvement, almost half of the patients, but clinical worsening was seen in 10% of the patients. So when we check all these information, we can say that if there is a huge trigeminal schwannoma, of course surgery should be done. Maybe subtotal surgery is better than total surgery, total removal, I mean. But if the tumor is small or moderate size, to do radiosurgery is better. When we come to jugular schwannomas is like this. You see the CT, the jugular fossa, the jugular foramen is enlarged because of the tumor compression, and the T2 and T1 sections, MR images of these tumor here can be seen. The jugular schwannoma means the schwannoma in the jugular foramen. It can be rise from the 9th, 10th, or 11th nerve, mostly from the 9th nerve, but you cannot understand which one is the source for that specific patient. So in jugular schwannoma, the patient came to you with hearing loss, hoarseness of voice, dysphagia, swallowing difficulties, headache, fasciophagia, etc., etc. And in some patients, you may see shoulder weakness because of the 11th nerve is affected. And for jugular schwannoma, of course, surgery can be done, but the risk of surgery is high here also. The lower cranial nerve dysfunction is almost 50% in the series. If you have a lower cranial nerve dysfunction, it is a very bad thing for you for quality of life. You cannot drink well, you cannot eat well, you cannot talk well. So it's a terrible position for the patient. Also, you may see other cranial nerve deficits, and ordinary surgical complications can be seen in these patients. And the total excision rate is changing in the literature between 30% to 100%, depending on the surgeon. So this is our article from about jugular foramen schwannomas, and in these patients we used 13 gray as a mean doses, and we were reported it when we had 17 patients in that time, and in one patient we had temporary hoarseness because of the effect of the radiation, but the success rate here you can see that is very high. This is an article from the IRRF, and they collected the jugular schwannoma patients from the centers, and you see here the risk of side effect is very low, and the chance of tumor growth control is very high. And that area, jugular foramen area, is not easy to operate. It's a tricky area for an ordinary neurosurgeon. It should be operated by a very experienced neurosurgeon who performs this kind of surgery very frequently. Another article from Japan, and they saw the same results, almost the same results. So for the functional outcome, they see better results when you compare with surgery. Only a few patients had some problems due to the radiation. And when you see the surgical series in this article, you can see a lot of side effects, morbidity after surgery. So I want to show you this example. For example, this patient had dizziness and diagnosed with jugular foramen schwannoma, and we gave 12 gray to the margin, and you see here the tumor is necrotic after 18 months, in the 18 months later MR image. So when you come to fascial schwannomas, in the MR image of fascial schwannoma, you may see like this here with the contrast. You may see the tumor like this. This is a small fascial schwannoma. So most of the patient comes to you with fascial weakness, some level of fascial weakness. Some can come to you with total fascial palsy, but some of them may come to you with fascial weakness. Hearing loss, vertigo, tinnitus, and in some patients, hemifacial spasm can be seen. Surgery can be done for fascial schwannomas too, but yesterday and today we were talking about the incidental vestibular schwannomas, incidental meningiomas, etc. If I see an incidental fascial schwannoma, if the patient has no complaint regarding to that tumor, I would not touch it, because the risk of fascial palsy is very important. If a patient becomes deaf in one ear, I cannot understand. Maybe I am deaf in my left ear. Can you understand? No. But if I have left-sided fascial palsy, you can understand, and my quality of life will go down. And if these patients are operated, you see the fascial nerve dysfunction rate is very high. 60 to 70% of the patients get fascial palsy after surgery, and they may have also cranial nerve deficit. The patient may have deafness after surgery and other ordinary complications, etc. And the total excision rate is high for these tumors in the series in the literature. This is our results, which was published a few years ago, and there were 11 patients in this series, and we had only one patient, two patients with fascial palsy after radiosurgery. But we use almost 12 gray for these patients, sometimes 11 gray. When you look at the literature about it, the margin dose is around 12 gray, same as all schwannomas, and the tumor growth control rate is very high. Permanent worsening rate is very low, and permanent worsening for the hearing is very low also. So for facial schwannoma, if it is not so huge, to do radiosurgery is better for the patient. This is a patient with facial palsy on the left side. We use 12 gray, and this is the third year control MR image. This is another patient. We gave 11 gray. This is the MR image after 72 months later. When we come to oculomotor, trochlear, and abducens nerve schwannomas, they are very, very seldomly seen tumors, and they may cause diplopia, ptosis, pain in the orbit, around the orbit, and they may cause sometimes, if they are very large, proptosis. So when you look at the literature, same as the other indications, the success rate is very high, and the complication rate is very low with radiosurgery. So to do a surgery for these kind of small tumors, most of the 3rd, 3rd, 4th, and 6th nerve schwannomas are seen in the very small size, because they immediately shows some effects on the patient. Patient comes to the doctor with diplopia or ptosis, so they cannot wait to see 4 centimeters, 5 centimeters of oculomotor schwannoma. They are very tiny. Here they collected all the published literature. Here you can see the tumor growth control is almost 100% in the series, almost in all series, I mean. In most of the series, this is 100, and the morbidity is very low. You can see it in some series, that's all. So only for abducens schwannoma, they published 6 patients, and they are from India. I don't know any one of them is here, but these results are also very good about this very seldomly seen tumor. This is a patient example from our center. This female patient had 3rd nerve palsy in the last 6 months, and this MR image showed oculomotor schwannoma in this patient, and 6 months later you see the tumor is smaller and necrotic. A good response for us. And also look at the face of the patient. You see here she was with a ptosis here, and 6 months later it is much more better than before, and the eye movements are better than before. So it also, I mean that gamma knife radiosurgery didn't only stop the growth of the tumor, also it helped the relief of the cranial nerve in this patient. Another very seldom tumor is hypoglossal schwannoma. I took this picture from the article which I showed in the bottom. So these are very rare tumors. They may cause tongue weakness, atrophia, neck pain, cerebellar signs, or lower cranial nerve signs. And this article collected, the IRF collected the hypoglossal schwannomas in the centers, and there are 12 patients in this article. Only one of them demonstrated a growth after treatment. The success is very high. And when you check the other articles in the literature, the success is very high. The side effect rate is very low. So to do radiosurgery instead of surgery is better for these patients also. As a conclusion, non-vestibular schwannomas are relatively rare tumors. For small or medium-sized tumors, radiosurgery is a very good option. And results of radiosurgery series are much more better than surgical series. So I would recommend a patient with non-vestibular schwannoma mostly to the radiosurgery, not to classical surgery. Thank you so much.
Thank you, sir, for a wonderful presentation. That topic is open for discussion.
I think everything is clear and everyone is convinced about the effect of radiosurgery.
I have to say it does seem quite compelling with the graphs that you showed. And they are rare tumors and nobody really builds up a lot of surgical facility with taking care of them. That may have something also to do with it.
Thank you.
Thank you, sir, for this wonderful session. The next plenary lecture, 5, Radiosurgery of Glomus Tumors. I'm glad to invite the moderators, Dr. Ashish Pathak, Consultant Neurosurgeon, Fortis Hospital, Chandigarh, and Professor Ian McCutcheon, Department of Neurosurgery, MD Cancer Center, Texas, USA. I request our moderators to invite the speakers for this session.
So our speaker will be, yes, Professor Manjul Tripathi, who is approaching the podium as I see, from Chandigarh, and he's going to speak on radiosurgery for glomus tumors.
Good morning, everyone, and I am sincerely thankful to the ISRS, the Educational Committee, and especially the organizers, Professor Datta and Professor Jalali, for giving me this wonderful opportunity to a disease which is now considered probably the last chapter of the neurosurgery, because there are only few things left in the neurosurgery which take you out as a surgeon of your comfort zone, and you think many times before operating on these tumors. These are my disclaimers. My experience is limited to gamma knife. I am a microneurosurgeon and gamma knife radiosurgeon, and we are one of the leading centers along with AIMS and NIMHANS while doing these tumors. There is no financial disclosure to this talk. First, taking you to my place. It's in the foothills of Himalaya, and it's a tertiary care teaching institute. It takes care of nearly around 80 million catchment area of the patient population. And I'm very happy that one of my teachers, Professor Pathak, is actually today moderating me for this talk. Looking at the history of the gamma knife, just a brief one, we have 5 functional centers in India at present, and there are a few more coming. And AIMS, PGI, and NIMHANS, we are doing close to 1,000 plus cases per year with the gamma knife radiosurgery for different indications. Now, coming to the present talk, I'm talking about paraganglioma, which is also known as the glomus tumor, and for this topic I am keeping myself limited to the temporal paragangliomas. This is a rare tumor, relatively rare tumor, with the presentation in the later stages of the life, with a slow growing benign tumor. And these are hypervascular tumors. That's the reason. One is the hypervascularity, and second, their location in the remote areas of the skull base where they engulf the surrounding neurovascular structures. The extremes of presentation include a bilateral presentation in around 2% cases. In 7 to 10% cases, you have multiple tumors, so you need to take this patient, evaluate this patient to find out other paragangliomas in the body. They have a tendency to grow along the lower cranial nerves. That's why their intracranial component is usually smaller in size in comparison to the component which is towards the skull base, temporal bone, and going down. You may find multiple tumors in BHL and MEN, and 1 to 5% cases are the malignant variants with an early age presentation, genetic mutations of the SDH and multicentricity, and very rarely you may encounter a secretory paragangliomas, and these are the rare ones. The origin is a disputed one, whether it's from the pericytes or the parasympathetic chromaffin cells, and you may find these paragangliomas at different locations in the body. Now the question comes, you are actually usually get these patients referred by your ENT colleagues, and sometimes they just come with the initial presentation of a hemiatrophy of the tongue or some dysphonia or something like that, or sometimes a hearing loss. So what to do in those patients, whether you should just observe, you should give option of surgery to these patients, and what are the factors to be considered. For an asymptomatic or mildly symptomatic older patient, surgery did not provide any significant advantage to this patient population except for increasing the morbidity and mortality, and morbidity in this patient profile is related to their lower cranial nerves, and that's a significant morbidity compared to losing your hearing or any other thing. So you need to wisely choose your treatment modality. The factors to consider is the age. If it is an octogenarian or a septuagenarian, you can just sit tight, just leave the tumor as such because its growth potential is very less. And if there is a 20%, more than 20% increase in the tumor volume, then you should call it that there is a significant growth in these patients. Is the gold standard of the surgery still the gold standard? That's really a question now, because you are not only treating the MRI, you are also looking at the functional quality of life of these patients, and the surgical excision has a dreadful outcome if it not goes as per plan. Radiosurgery with different platforms is emerging as the optimal primary treatment modality for these patients. IMRT and EBRT is still applicable for lesions which are not amenable for SRS. And definitely the fractionated regimes with the stereotactic radiosurgery, with the frameless radiosurgery, that has pushed our limits, and there is a paradigm shift in the management of these patients. Still, I am a surgeon, so when to offer the surgery? The surgery is to be offered when you have a dispute in your diagnosis. If you are not sure, you have a radiological masquerader, there are secreting tumors, there is a significant brainstem compression, and your prior radiotherapy has failed to control the tumor. Sometimes you need all the knives to take care of such kind of patients because there is a significant brainstem compression and you cannot wait for the radiosurgery for its latency period so that the patient can be benefited. If you look at the surgical series, the total resection could be achieved in the best of the hands in 90% of cases, but that came at a cost of nearly around 18.7 to 44% morbidity. 44% is nearly half of your patients are morbid, and a mortality rate of 13%, that's a significantly high. And even if you achieve a total resection, the recurrence rate is still high to the tune of 5.5%. That's a huge recurrence rate. And you can look at the last column, there is a new cranial nerve deficit in around 39% patients. I especially like this study because this was a very robust literature analysis which took care of around 1,310 patients in which these are surgically treated patients. 85% patients had an improvement. Now, if we look at that, 1183 patients had a preoperative cranial neuropathies, and in the postoperative cranial neuropathies, we added 965 new neuropathies to these patients. And when I read this study, they did not consider the hearing loss because that was not evaluated. This was only the lower cranial nerve deficit. And vagus could be functionally preserved only in around 11 out of 254 patients. So that's a very morbid outcome with the surgical series in these patients. Then we looked at the alternative options. So they evaluated the surgical series with the radiotherapy series. That's a conventional external beam radiation therapies and the IMRT series. So they could achieve a tumor control much impressive. You can look at the p-value in the last column. With a very improved morbidity and the mortality profile, the major complications reduced to close to half, and the new cranial palsies were practically absent after the external beam radiation therapy for these tumors. So we can say that yes, this was a significant change for a benign disease. If you look at the gross total resection, this is the pooled analysis of the same study. And in the last column, you can say with the gross total resection and the SRS, the number of the complications in the two are very visibly, comparably improved with the radiosurgical series compared to the surgical series. Then we moved to further refined radiation techniques from the EBRT and compared the external beam radiation therapies and the IMRT to the SRS, and it was a further leap of advancement in these patients with the tumor control improving to 93.7% and major complications significantly reduced, and there was practically no cranial nerve palsies. If you look in the table number 6, the total complications in EBRT were 57 compared to the 16 in the SRS group. This is a literature review of SRS series with different platforms, predominantly the LINAC and the CyberKnife ones, and you can see an impressive local control of in the short and in the long term. in the short term, it's practically 100% local control compared to the long-term control of nearly around 94%, which is not bad for a disease which is so morbid. This we did a literature review for this. We were invited for this chapter, Intracranial Stereotactic Radiosurgery book, and we could find that in different fractionation regimes, the dose was very variable from around 11 gray to 18 gray. The local control could be achieved in 94.2% patient, and the symptomatic control could be achieved in around 87% patients. This is again a very good consortium study published by the Jason P. Sheehan group with an overall control of 93%, 5-year control of 88%, no death related to SRS, and no difference in the upfront versus the salvage radiosurgery. Now, if you still want to operate on these patients, you should ask your patient whether you would be able to take this patient out from your OT in a better situation. And if your answer is yes, you can elegantly operate on this patient without creating a deficit, without adding a new deficit. You can go ahead with your surgical procedure. And you should also ask whether your aim is a tumor eradication or a tumor stabilization for a benign disease which has a very low potential for the growth, and you are still convinced that you should operate, then you should ask your patient whether your definition of the acceptable complication is in sync with the definition of acceptable complication of your patient. If you both are in sync, you can go ahead with the surgery. Otherwise, there is a very safe treatment modality available to you, and the paradigm shift has already happened, and most of the centers have practically stopped operating on a jugular paraganglioma these days. If you look at the worldwide literature, this is the LGKS statistics. Glomus tumor takes care of nearly around 1.03% of the all benign tumors treated from 1968 to 2019, probably because of the relative rarity of this disease. We evaluated the safety, efficacy, and the complication profile of a dose-fractionated gamma knife radiosurgery for large volume glomus tumors, and this was before the ICON era. We treated these patients with the fractionated gamma knife. Dr. Narendra Kumar is here today, so we discussed all these regimes, and we fractionated with the frame-based manner in 2 to 3 fractions to these patients. And these were all large volume jugular paragangliomas. This was our protocol to do that. The exclusion criteria was the brainstem compression, secretory paragangliomas, and the previous intervention. And the decision to fractionate was when we were not able to preserve the brainstem in a single fraction from 12 gray and the cochlear preservation 4 gray, and we meticulously managed these patients in a clinical radiological follow-up. All patients were treated on a perfection, and the dose range was 15 to 24 gray. The 24 gray sometimes raises an eyebrow, and we think that this is slightly higher from what we routinely, conventionally give to around 18 to 20 gray. The reason we thought that most of these glomus tumors are hypervascular tumors, and they should be treated on the line of an AVM rather than a vestibular schwannoma or a meningioma. So if you take care of the vascularity early, you are able to take care of most of their symptomatology in those large tumors, and fractionating that 24 in 2 to 3 fractions, that's going to give you a significant clinical advantage with a shorter latency period. The frame was kept in situ during the procedure. Around 62 patients we treated in 2011 to 2019. 17 were in multi-session, 45 were in a single session. And this was actually the presentation to these patients, and 54% in the multi-session, probably because of those tumors were large. They had a clinical neurological deficit compared to the 42% patients who were treated in a single session gamma knife radiosurgery. And the most common presentations with these patients are usually headache, tinnitus, hearing loss, lower cranial nerve deficits. But the headache, tinnitus and the hearing loss is the one which usually they present with. While I discuss about the hearing loss here is not only a sensory neural hearing loss, because this tumor frequently invades into the petrous part of the temporal bone. It practically eats it. So it's a mixed hearing loss with the sensory neural and a conductive hearing loss. So you cannot just rely on your radiosurgical technique to give them a benefit. These were the complications, the symptoms, sorry, not the complications, symptoms like all these symptoms, these improved. The headache improved, tinnitus improved, or they either remain stabilized in these patients. Only in one patient I had a new onset headache, and in one patient I had a late onset facial paresis. Otherwise, all those symptoms over a latency period of around 6 months to 2 years improved. That's the graph in which the patients either got stabilized or improved. Now coming to the first case, this was a large volume 47.63 cc glomus tumor. This was treated in 7 gray in 3 fractions, and this is his MRI, comparative MRI by the end of the 3 years, and the tumor reduced from around 47 to 19.77 cc. You can look at the extent of the tumor pre-SRS and the post-SRS. If you meticulously follow these patients and do a co-registration, you would be able to understand where is the tumor increasing, where it's not, where is an in-field response, or there is a failure. So this was at the time of the treatment with the fractionated gamma knife. This patient got fractionation because we were not able to preserve the cochlea in a single fraction. He was with a preserved hearing, surprisingly. And this was 20.13 cc. At 2 years, it just marginally reduced to 19.88, but 4 years it reduced to 17.52. And if you follow these patients for a longer duration of time, you can see that the volume further reduces. Again, this was a single session treated patient because the patient didn't have any hearing and the brainstem was far away. We treated it with the 16 gray, and looking at these large volumes, they have a very small intracranial component, so we could get some liberty in treating with a higher dose. Had it been with an intracranial component larger, we might need to reduce our dose in those patients. You can look at the volumetric response to these patients. This was again treated with a fractionation. So what does improve first? In my clinical analysis of these patients, I realized that the first thing to improve is the headache. The headache might be multifactorial, it might be a dural stretch headache, or it might be a vascular headache, but if I gave a dose close to 20 gray, the headache improved within around 4 to 6 months, and the second thing to improve was the tinnitus. Probably that high dose takes care of the vascularity of the tumor, and that leads to a relief in the headache and the tinnitus component. This was a relatively dramatic response within 6 months, a good response. I cannot always guarantee such kind of a response, but infrequently we get this response in these patients. If you look at the radiosurgery response classification, we took this criteria from the literature in other studies, and we found that a grade 1, that is a tumor shrinkage more than 10%, when we treated with a multi-session to these patients, 90% of the patients had, by the end of the 3 years, had a more than 10% tumor shrinkage. In the single session, nearly 85.7%. And if you just take it as a tumor size stabilization, 10% in the multi-session and 9.4% in the single session. Only one patient I had a failure, and then I had to subject it with an additional dose of that out of the field failure it happened, and I treated with the additional radiosurgery in that patient. So the question happens, how much dose is too much for a single session or in a multi-session? The literature, different case series and the reports, they reported from 12 gray to 30 gray. The 30 gray is the maximum dose which has been reported in the literature, but the conventionally anything which is close to 15 gray is usually the one which is usually preferred. You can go with the hypofractionated regimes with 5 gray into the 5 fractions with the icon, because you do not need to rely on your frame anymore. And the factors to consider are the tumor volume, neighborhood, and the secretory status. Cranial neuropathy improves, and this is one thing which is a significant factor in deciding the quality of life of these patients, and this improves with the SRS. That's a proven fact in these patients. And that this is a volumetric response in what I found in my patients, and there was a 30% volumetric reduction in patients which were treated with a multi-session compared to the 42.35% which were treated with a single session. That might be because of the large volume of the tumors which were primarily treated with the multi-session gamma knife. But there is no correlation between that volumetric reduction versus the clinical improvement of these patients. We know that these tumors engulf your lower cranial nerves, they pass through the tumor. How does it happen? I do not have a definite answer to this one. Probably the radiosurgery has some functional effect over these nerves, but there is no definite correlation. Sometimes the tumor just remained stabilized, but the patient had a clinical improvement, and it's a delight to see an improvement in the dysphonia and the problems with the deglutition in these patients. So with the hypofractionated regimes, we could avoid an unacceptable spillage. Fractionation was established in other entities. This we did in 2015-2016 time, when actually the fractionation was not that much common for these tumors. And there was some challenges in the treatment planning regarding the alpha, beta, BED, and the LQ equation, and the dose per fraction, how much should we decide, and how should we decide to the dose for the organs at risk at that time. So we relied on our earlier experience on treating the large volume AVMs with the dose fractionated gamma knife. And the similar dosing pattern and the is placed to the organs at risk, we evaluated and extrapolated to this. This is the fractionation regime which we followed in these patients for the glomus jugular. One thing is that your surgical classification scheme doesn't work for an SRS, whatever is the extent till you can achieve the tumor target that's going to be effective with an SRS. If it is too much large, you can just do with a fractionation. If it is a small, with a single session. It's a safe, effective, potentially better treatment modality for glomus tumors unsuitable for the single session, and the clinical and radiological response for both multi-session and single session were comparable. We initially had some problem when we were doing a fractionation with the frame base when the tumor was extending too deep into the neck. And then it was a relatively heroic effort to fix the frame over the maxilla. At that time, we fixed the frame over the maxilla, we jammed the neck, put it on a hard cervical collar so that the neck remained minimally mobilized during that time. We published it into the Acta Neurochirurgica. That's the way we did it, and these patients were treated in the 3 fractions. So our reach could be up to the C3, C4 level, and those patients had a marvelous outcome compared to our conventional ones which we had, and we didn't need any other treatment modality and no failure in these patients. This paper received a good response from the Marseille group. If you look at the complications of these treatment regime, the Sheehan group had a neurological deterioration in around 6% patient. The Lee et al. Were very categorical in saying that the trigeminal nerve dysfunction was a poor predictor, because in those cases, the tumor is extending intracranially and you need to be really conservative with your dose. Overall, we found a complication of 7.9% in our patient, and with the literature review found that with the LINAC based ones, compared to that one, the complication profile was slightly better in the gamma knife series. A unique complication which we found in these patients is a non-secretorial focal alopecia for these large volume glomus tumors which were towards the surface. And then we realized that this is just a transient phenomena. Most of these patients regain their normal hair within around 2 to 3 months of the stereotactic radiosurgery. And if you are able to preserve your dermal appendages from less than 3 gray, this doesn't happen, but sometimes you are not able to do that because the tumor is coming to the surface. Some patients which had a radiation-induced neuropathy, we prescribed them. Earlier we treated with the pentoxifilin and vitamin E, and if they remain resistant to that, a short course of the bevacizumab helps in regaining their function. As a word of caution, glomus tumors are usually treated without any pathological diagnosis, and we had one failure in one patient. This patient was treated at some other center and then for nearly around 10 to 12 years. This was radiologically looking like a glomus tumor to on all parameters at the first go. And after nearly around 9 years, there was a subtle out of the field failure. We treated again with a second round of radiosurgery at my center. We again thought that this is just a glomus tumor, but the patient presented to us back with a massive cerebral edema. We couldn't save the patient despite all the endeavors, and when we did the biopsy, we found that it was not a glomus from the very beginning. It was an intracranial extraskeletal mesenchymal chondrosarcoma. So whenever you are in doubt, you need to have a biopsy. If you're finding a radiological masquerader and the tumor is not behaving in the way it should. So finally, I would say that surgical management of the glomus tumor is only for the symptomatic brainstem compression, secretory paragangliomas, and patients with the intracranial hypertension. SRS is safe and effective treatment modality for glomus with an excellent long-term clinical and radiological control. It should be offered as a primary treatment option rather than as a salvage. There is no point in causing an injury to the lower cranial nerves and then administering it. The clinical improvement is irrespective of the radiological reduction, and it's a very cost-effective treatment modality. That's one thing which we evaluate in our setting. So if you look at the hypofractionated and hyperfractionated SRS, the need of the hospital stay is very less, and the patients need to remain absent from the workplace for a very short duration of time. This I found in the literature an interesting report about a secretory paraganglioma which was primarily treated with stereotactic radiosurgery. Because most of the ones which we treat is a non-secretory paraganglioma, and this patient needed a higher dose. their approach towards managing a secretory paraganglioma is on the lines of a functional pituitary adenoma. They thought that we should be a little bit more aggressive with the dose. And a word of caution is that because you are causing a destruction of these cells with a high dose radiosurgery, there are chances of a sudden hypertensive crisis in these patients. So whenever you are treating, you need to preload those patients. You should be mentally ready for a hypertensive crisis which may happen in these patients. EBRT is usually not working in these patients as usually. I couldn't find much literature on the proton therapy for the head and neck paragangliomas, but I can see that it was mostly local tumor control was impressive to the range of 100%, and the symptoms either remain stabilized or improved, and there was no upper grade toxicity in these patients. So there are definitely limitations because the tumor extends deep in the neck, the radiological diagnosis, because most of the times they are being treated with a primary radiosurgery only. The dose is still not defined in the literature for the large tumors, and for the late onset failure, we need to follow these patients for a longer duration of time. And still we are doing with a frame based, like we are getting a frameless one very soon, so that would be a significant advantage for us. I sincerely thank late Professor KKM, Shihan, Ian Paddick, Ajay Niranjan, and Antonio Sales for encouraging me with all this, and my patients for trusting me with these difficult frame fixations and fixation on the maxilla in a couple of them. Thank you so much.
Thank you, Manjul, for an excellent exposition. I really see the great work that you have done. Apart from the fact that the large tumors with the D2 groups, which might need surgical intervention or a biopsy or treatment of hydrocephalus, anything like that, most of the patients, I think, now can be treated by this technique that you have shown. Now this talk is open for discussion. Please. Yes, enough that.
Schedule with radiosurgery. And the series that have been reported, although are promising, most of them are reporting crude local control rates and not time-dependent outcomes, and without any data essentially beyond 5 years. So where is your cutoff that you would recommend for radiosurgery, either in 1 or 5 fractions, versus something that you would refer, for example, for conventionally fractionated external beam radiation?
I take a little liberty in glomus because, as I earlier told, that we are not having that much intracranial component as the tumor is extending down. So in those cases, I take a liberty as far as the dose is concerned and the fractionation is concerned. So I do not like to fractionate it into multiple ones now. I give with a slightly higher dose than reported in the literature towards the tune of the 20 to 22 gray, because I'm in a safer zone as far as the radiotherapy is concerned. Second point is that whenever I evaluate the exposure to the brainstem and the 12 gray in the surrounding area, if I'm able to save the brainstem safely, I would still like to go with a single session. But if that is not the case, then I fractionate it usually in the 3 fractions.
So if you can meet your constraints, it doesn't matter the volume, you would treat something 50, 70, 90 cc's?
No, volume I would definitely take into consideration. If it is a large volume, I would like to fractionate it.
Dr. Gupta.
Yeah, here, Manjul.
Yeah, sure, Chief.
2 things. Number 1, it was a very good presentation. I'm seeing glomus tympanicum missing from your series. Have you treated any patients?
We have treated multiple, but in this particular series, I haven't shown those ones.
Can you please educate us about the outcomes of radiosurgery in glomus tympanicum, specifically the pulsatile tinnitus component?
I usually give a higher dose, and if the patient has a worrisome pulsatile tinnitus, then I ask my ENT surgeon if they can safely excise that, because glomus tympanicum can be safely excised compared to the jugular paraganglioma. So if they say that they can easily excise it, I offer them that okay, just go ahead with it and do it. But if they are not comfortable with that,
with a significant risk of loss.
Yes, that comes. Yeah. But usually these tumors are identified early. Yeah. The second problem with the glomus tympanicum, they usually perforate the ear. And then the patient comes with a otorrhea. And that otorrhea with radiosurgery takes a very long time till the vascularity takes control of that part. The patient keeps coming to your OPD saying, showing you that cotton pledge that, sir, my ear is still bleeding. So that part is a little disgusting for the patient, and I offer those patients to undergo the surgery. If that is not the case, then radiosurgery is a very valid alternative for those patients. The latency period for the tinnitus to go on those patients, because most of that tinnitus is a pulsatile vascular tinnitus that takes somewhere around 1 year to 2 years to go, and the results are equally good as for the other temporal paragangliomas.
So this is a hypervascular tumor, all of us know. So do you advocate perfusion imaging in your follow-up scans as well? And if so, what is the decrease in the CBB and RCBB?
Not so far. Not so far I haven't been doing. I am just following them clinically as far as the perfusion is concerned. And if the patient reports that they are good with, with their headache and the tinnitus, I just take it in as a symptomatic improvement. I take those all before deciding the treatment if I have a single iota of doubt about the diagnosis of these patients now. So I take all the help of the DOTA, look at the CT and co-registering that, and looking at the bone pattern destruction. So that I do pre-operatively, but in the follow-up, definitely in the CBV studies I haven't done.
Can we have another discussion, please? Somebody's waiting. Yep.
Hi, Manjul. Excellent data, and I think thanks for adding to the already growing data for primary radiosurgery for glomus. So I have two comments. One is, you see, when we have larger glomus tumors, they are actually jugulotympanic. Yes. You cannot actually classify it as purely a jugular paraganglioma. So there we land up with the problem which you mentioned, that if you, sometimes you land up with this ear discharge problem, and if you do a CT, you actually see osteonecrosis. Yes. So what I've started doing in these cases is I'm less aggressive in marking out the lateral part of the tumor, which is close to the external ear canal. So if you avoid the normal bone there and the normal skin there, at least what I've seen is the chance of leading with the ear discharge post radiosurgery actually comes down substantially.
I agree, sir.
And the second comment is chondrosarcomas are actually very good outcome cases for radiosurgery. Yes. So the case that you showed failed was actually a bit of a surprise.
Sir, that's an intracranial extraskeletal mesenchymal chondrosarcoma. So that's not in the same league of our conventional chondrosarcomas, which are very good responders to the radiosurgery. And because of the rarity of this disease, nobody actually knows the natural history. It's something like a solitary fibrous tumor. They can remain in your brain for decades altogether, having a totally indolent behavior, and they may present in an extremely aggressive, unexpected manner. So that happened with us in the second time. But good that the patient agreed for an autopsy. Attendants agreed for the autopsy.
Yes, somebody at the back, please. Yep.
Dr. Costa.
Can you get the microphone, please?
So chondrosarcoma, I'm just extending the discussion. Chondrosarcoma in that location, chondrosarcoma traditionally, conventionally have required very high biological equivalent doses of radiation. So radiosurgery also, your BED has to be so good and so effective and sparing other structures surrounding. So chondrosarcomas in that location, I mean, I'm not surprised that they will be failing. So I buy your point that chondrosarcomas in that locations fail because traditionally they require a very high BED.
Excuse me.
Yes, please.
So you must have seen some large glomus tumors as well. So till what size actually you are comfortable to treat with radiosurgery?
I wouldn't say comfortable, but what I have treated is a 72 cc is the maximum volume.
Okay, and size would be around?
Size would be around 8 centimeter in the maximum dimension, but that's a vertical dimension.
Yeah.
So that's the maximum dimension is an 8 centimeter.
So if you encountered, somewhat bigger, or maybe 10, 12 centimeters, so you can still treat, or would you prefer any other modality?
Then you would need to increase your fractionation. If I'm comfortable up to the 5 fractions, I would go with it. But if I'm not, then I will send it to the IMRT or the other radiation techniques.
I think I would just add a little bit of caveat to that. If it is that big, D2 or beyond that, I still believe that I can shave it off, make it big, smaller for you, and then you can do a very good job. But I won't do the extensive petrosectomy and all those things which we used to do in the past and burn our fingers. So we can always reduce it. That scope is there, and just simple retromested approach, bring down the size of the tumor, shave off whatever you can, and then that becomes amenable to all this nice treatment which it can provide. So there is a role for giant ones which we see going extensively into different corridors in the posterior fossa. There is still a scope in those patients, I would say. And of course, group 1 and B, AB, tympanic, and they can be very well be treated by the ENT doctors. So they do a very good job. So there are roles of surgery, but then for the ones which are C1, 2, 3 involving the carotid artery and all the deeper structures in the internal ear, there of course radiosurgery has definitely a very good advantage, and that's probably should be the line of treatment.
Thank you, sir. Very exhaustive and impressive talk. I have a comment. I mean, I really appreciate the fact that you showed one of your cases where you said you failed to do a biopsy, and it learning point for all of us. But I mean, just to understand, I mean, if a tumor recurs, you're giving re-radiation, I would definitely say one should probably attempt a biopsy. But how easy or how difficult is to do biopsy routinely? I mean, of course, if it is clear-cut radiologically a paraganglioma, none of us would biopsy. But in what situations you would biopsy? Because chondrosarcoma also is a very classical radiological diagnosis. But yet we can miss it. That's the lesson.
Probably this was radiated also, so the nature must have changed.
Possibly, yes.
So, are you asking me to then approach to the biopsy with surgical approach?
Is it very difficult? Is it
not very difficult?
Is
you
it,
can definitely
is it
achieve
very risky? And why the reluctance for a biopsy?
If it is a jugulotympanicum, it becomes relatively easy because then you can ask your ENT colleague to have take it from the ear. But as you are aware that this is a highly vascular tumor, so whatever the surgical approach you take, you go in easily, but coming out becomes difficult in those patients. So just, yes, biopsy can be done, but as far as the surgical resection is concerned, that's still not a preferable one. Whenever you are in doubt, be sure with the histopathology. There is no point in treating a disease where you are not sure what you are treating. So yes, I agree, biopsy should be there.
I think, you want to ask them? Yes, please.
Sir.
What I understand that in paragangliomas and gliomas, there's a late recurrences. Usually, the recurrences usually doesn't happen in first 5 years. So how do you consider control at 5 years or 10 years? I was just taking the Rupesh's question, that there are sometimes the recurrences at 7, 8 years time. So when you will call it, because 5 years control will be 100%, but 10 years may not be. So how will you address that?
So the only answer for all kind of diseases, like we were discussing about the vascular and vestibular schwannomas, all those, live in the present. Because the longer you wait for these patients, definitely you are going to have some radiological failures. Definitely. And the criteria for different disorders to decide that the tumor has grown is different. Sometimes you just follow the Rano criteria, sometimes you take it as an greater than 10% increase or 20% increase, until unless we have a definite uniform criteria to decide what is a control and what is a growth. I can't answer this question at this forum at present. It's very, very, very variable, and that depends on the imaging parameters you are choosing. So it's difficult for me to see, but definitely it's a disease for the life because it's not going to disappear from the skull base, and you need to follow these patients for a very long duration of time.
Thank you very much. I think with this we conclude the session, and on behalf of my co-chair, I thank Dr. Manjul for this excellent talk. Thank you.
We move on to the next plenary lecture on SRS or SRT of skull-based malignancies. Moderator for this session is Dr. Srinivas Chillukuri, Consultant Radiation Oncologist at Apollo Hospitals, Chennai, and I request Professor Ian McCutcheon to be seated at the dais for the next session too. I request the moderators to introduce the speaker for this session.
So yes, our speaker is Professor Yoshimasa Mori from Kawasaki in Japan. who's going to speak to us on SRS and SRT for skull base malignancies.
Thank
Go
you,
right ahead.
Chairman. I will talk on skull base malignancies. Nowadays, we can use some different modalities for SRS, SRT, and IMRT, IMSRT. Malignant skull base tumor involves many various different histological types. Primary tumors, choroidoma and paraganglioma is benign but infiltrating character into surrounding tumors, and sometimes total resection is difficult. And I talked on non-benign meningioma and hemangiopericytoma yesterday, and others metastasis and invasion. There are two types of invasion. One is distant metastasis from visceral cancers, and this is isolated tumors. But another type is direct invasion of head and neck cancers continuously from the primary site. And in addition, I will talk on some possible good candidate of upfront SRS, SRT among primary head and neck cancers, orbital nasal, paranasal cancers, and external auditory canal cancers. Skull-base tumors usually often involves cranial nerves and optic apparatus, auditory apparatus, brainstem, and major vascular vessels. And they are sometimes large, and they are sometimes after multiple surgery or radiation therapy. And fractionated SRT is favorable other than single session SRS when involvement of the structures vulnerable to radiation injury was involved. For example, optic apparatus, auditory apparatus, brainstem, and the tumor is large when skin is already affected by surgical intervention or prior radiation therapy. This slide is sorted by indication. For primary skull-base tumors, as an initial therapy of primary skull-base tumors, it is a limited case. Usually, primary skull-base tumors is treated by SRS as additional therapy for residual or recurrent tumors after surgical resection or after obtaining histological diagnosis. For metastasis, as additional therapy or as an effective therapy for isolated distant skull-base metastasis. I will talk about this later. And possible good candidate for of radiosurgery or SRS or SRT as an initial therapy for early stage head and neck cancers after histological diagnosis by biopsy, orbital nasal and paranasal cancers, and external auditory canal cancers. I will talk on one by one. This is benign meningioma. Sometimes we we do SRS or SRS or SRT on such kind of cavernous thymus tumors without histological diagnosis. Meningioma, maybe possible cavernous hemangioma. Cavernous hemangioma has a better response after SRS. So next, as an additional therapy for residual or recurrent tumors. First, chordoma. This slide shows the reported series by particle beams. Local control is about 80% and survival is about 90%. So the response looks good. And this slide shows the reported series by photon beams. Local control is about 80% and survival is 90%. So looks the same as proton beams. So photon beams with large single fraction, those are effective for chordoma if the tumor is not large. I will show two cases. This case, gamma knife was done for residual tumor after transnasal resection. The paracellular tumor was treated by 60.2 gray using gamma knife, and the tumor was controlled for 3 years. Next, tough case. This is the initial images. T2-weighted image is most useful to identify the tumor extent of tumor. We performed gamma knife repeatedly for the small recurrence of the tumor. First gamma knife at the left cavernous portion, and second right orbital medial wall, third paracellular, fourth left orbital apex, fifth right medial wall of orbital. Then supraorbital portion and right paracellular portion again. After this gamma knife treatment, the patient tumor was stable for 2 years, but the tumor recurred again, and we recommended second resection. After the resection, first 1 year, for 1 year, the tumor was stable but relapsed again, and we did Novaris SRT then with 42 gray in 10 fractions. And the patient, this patient tumor was stable about 3 years. And the patient keeps good condition with only minor trigeminal symptoms. My colleague published one paper for chordoma, initial aggressive surgical resection, and gamma knife radiosurgery for recurrence. They treated 19 patients. 11 patients relapse occurred, but timely assessment with additional therapy, including EVRT or resection and SRS or SRT, that helped the patient's survival. So survival was 100% with median follow-up of 71.2 months. So timely assessment for relapse and marginal relapse and distant failure is important for long survival of the patient. Chondrosarcoma. This paper showed chondrosarcoma, the clinical course resembles that of chordoma, but shows a little better response to SRS and SRT. A little better response. Paraganglioma. This slide shows the list of three hypotheses. Local control and survival is almost 100%. I will show one case. This patient had relapse 20 years after partial resection. The patient developed a huge tumor both in the middle skull base and posterior fossa. The second resection was performed, but it is very difficult to remove tumor because of vascular rich character. So we did SRS for this patient by two-staged, volume staged manner. First gamma knife, the target is posterior fossa portion, and the second gamma knife was middle fossa portion, including petrous bone. The interval is 1 year. First gamma knife, 30 gray in 5 fraction was delivered, and the patient developed transient deterioration with truncal ataxia due to perifocal brain edema, but it disappeared, and the significant tumor shrinkage was obtained during the interval of the 1 year. And the second gamma knife was done only 2 months follow-up after that, so we will observe this patient. Yesterday, I talked on already non-benign meningioma, so skip this. Next, carcinoma metastasis. As I said, there are two types of metastasis. One is direct skull-base invasion of head and neck cancers, like these figures. They have difficulties in curing, and less chance for improvement of cranial nerve deficit involved. But another type of metastasis, isolated distant skull-base bone metastasis, they are more demarcated and have possibility to cure with improvement of cranial nerve deficit. We have to distinguish these two types because the prognosis is much different. First, direct skull-base invasion. We treated relapse of epipharyngeal cancer by gamma knife. This was a relapse after conventional radiation therapy, but the tumor shrunk within a half year. This slide shows recurrent nasal squamous cell carcinoma. Small tumor was treated by gamma knife, and tumor was controlled for half a year, but then recurred it anteriorly and posteriorly. This time we use fractionated IMRT. The tumors controlled for half a year again, and we observe him. Another recurrent case, adenoid cystic carcinoma in the paranasal sinus. It was treated by SRT. The tumor shrunk, but it had local relapse, and then we treated it again, the same manner, and complete remission was obtained again for 5 years. And this patient had lung metastasis, and those were also treated by SBRT. He is in a good condition now. This is a recurrent case after proton beam therapy. The historical diagnosis is S-stage neuroblastoma. We treated the local recurrence, and the tumor much shrunk, more than the tumor was controlled more than 1 year. This is nasal malignant melanoma. After resection, the tumor spread a little in the nasal mucosa. We treated it 50 gray in 10 fractions by helical tomotherapy, like this. Next, distant skull-base bone metastasis. This patient developed skull-base bone metastasis with complete left facial palsy, and we treated it 40 gray in 10 fractions. The patient obtained facial function again in several months, and the tumor much shrunk within 1 year, and 2 years have passed. The last possible good candidate of SRS-SRT among head and neck cancers, periorbital or nasal or paranasal carcinomas close to eyes and optic pathways, and they have less incidence of lymph node metastasis, so local tumor control is important. And another one, malignant melanoma, has a character of radio-resistant for against conventional radiotherapy. So large fraction dose SRT looks preferable other than conventional multifraction IMRT. And another one, external auditory canal carcinoma. It often found before reaching a large size because the patient develops ear obstruction sensation in early stage, and the tumor was visible from the outside, even the tumor is small. This is small supraorbital adenocystic carcinoma in 9-year-old male. We treated it 45 gray in 18 fractions, and the tumor was controlled 5 years. This is external auditory canal squamous cell carcinoma. Very small tumor was treated by CyberKnife, and it is almost cured. Complete remission until 9 years after the SRT. Another external auditory canal tumor, a little large. The tumor was shrunk and almost disappeared. This slide is which I showed first, various indications. This is also I have shown first. When we treat skull-based tumors, those constraint of cranial nerve is important, but it is difficult because some different papers published in those optic pathways and extraocular motor nerves and trigeminal nerve and auditory vestibular cochlear nerve and lower cranial nerves. We have to these constraints into consideration. Fractionated SRT is better than SRS if the tumor is not small, if the tumor involves optic pathways. And I don't like large central dose by gamma knife and CyberKnife. If the tumor involves the optic pathways inside, maybe flat dose distribution would be better for the optic pathways located at the center of the tumor. Even with sparing the optic pathways by contouring, by intensity modulation, we create flat distribution around the tumor. So I will talk on some imaging. On imaging, identifying the optic nerve is very important. For intraorbital portion, CT is useful because we can see nerves in the fat very low density, and intracanal portion is good by CT because the optic canal was created by bone. And as for cisternal portion, we use some MRIs and CT. MRI T2 weighted image and heavy T2 image, and gadolinium enhancement 3D SPGR image. Each image gives us different information. And 3D SPGR image does not have flow void, so T1 weighted image is better to identify the carotid arteries in the paracellar portion as the flow void. And the coronal section is useful to identify the lower border of the tumor for paracellar lesions like this. We can identify the lower border of the tumor easily with coronal section. This is the right study. Last slide. Indications and treatment results of SRS-SRT for malignant skull-based tumors were presented. First, benign but invasive tumors. Residual and recurrent tumors after surgical resection were treated. If they are smaller, the result would be better. Skull-based carcinomas, primary and metastatic. Recurrent tumors, even after prior radiotherapy, would be treated successfully if localized. Distant skull-based metastasis, bone metastasis, could be treated successfully with improvement of nerve deficit if localized. And upfront SRT might be feasible for orbital nasal and paranasal carcinoma and external auditory canal carcinoma if the tumor is small and localized. Thank you for your attention.
Thank you, Professor Mori, for this elaborate review. The house is open for discussion, but I'll take the liberty to ask the first question. Especially invasive tumors such as chordomas, if you look at the patterns of failure after radiosurgery, they typically fail in the opposite side cistern or the contralateral cavernous sinus or along the root of the surgical route. And you very elegantly showed in one case where you did multiple radiosurgeries every few months because there was progression. Would you agree that if we would have treated maybe larger volumes with fractionated treatment, we probably could have avoided some of those progressions? And those were quite rapid, 7 months, 6 months, 9 months.
Retrospectively, we had better to do a large area radiotherapy, but at first, aggressive tumor resection was done, so the surgeons recommend local therapy. So we treated small, and then when the patient developed a little continuous lesion from orbital, periorbital, and to the cavernous sinus, we recommend surgery again, and we did 10 fraction treatment to a little large area.
Thank you. Dr. Mori, our philosophy is a bit divergent here. We actually treat with liberal margins, including a lot of for microscopic disease spread as well, including the route of surgery if feasible. If it's too far, it's not feasible, it's not probability. But we'll take a few questions from the audience.
Okay. Yeah. Come to this chordoma, continuation of that. Don't you think particularly in a recurrent setting, and a proton would have been much better than CK that you have used?
Yeah, I think so. But sometimes the patient hopes the treatment at local physicians. So we treated some cases of chordoma without proton beam therapy, actually.
My question is also regarding clival chordomas. We would want to go up to 66 and beyond gray to achieve a good control, I would think. And there isn't any dose fractionation that in stereotaxy that EQD2 of beyond 66 to 70 gray. So especially in slightly bulkier tumors which are close to the optic apparatus and the brainstem, is stereotaxy even justified in clival chordomas? Because we want to achieve a very high dose, which doesn't seem to be possible with any dose fractionation.
We use only photon beams, so we have to use large single fraction dose. So about in 10 fractions, more than 45 gray, maybe that is the limit, because optic nerves are very sometimes close to the tumor.
I think for recurrent chordomas, I would have a different philosophy as a surgeon. If it's a recurrence which is coming after 4 or 5 years, which happens, I have a patient who had a recurrence after 17 years. Lower part of the clivus, yes. Transoral removed, radiotherapy given, high dose, some 17 years ago, absolutely fine. Then comes the recurrence higher up in the clivus, lower part is clean. In those cases, I went in, removed the whole thing again, and we found that it's all clean, but then another dose fractionation was given. So now it's 22 years. This lady came young before her marriage. She's married now, having grown-up children. So chordomas have a different behavior pattern. So they're not uniform, as we say chordoma is chordoma, no. That their behavior is different. So you have to go patient by patient. If they're coming back early and you have not done a good resection, or it's not been possible to do a good resection, now we use endoscope. So we even go around the corners and scrape out everything and it comes out. In that case, the longevity or the recurrence might be late if the biological nature is not too bad. But if the biology is different and it's coming back again and again, of course, then, of course, I think a proton beam would be a better option in that situation. That's my thinking. But if it's a large recurrence, I would go in again, and that would debulking the tumor, and cytoreduction would give a much better beneficial effect, followed by radiotherapy.
Yeah, Costa.
Check the biological equivalent dose. I think we are talking a lot about volumes, the constraints, and what we are talking in this session is about biological equivalent or biological effective dose. The BED would be 110, around 110. To achieve that BED in 5 fractions, you need to deliver almost 36 gray in 5 fractions or 37 gray in 5 fraction. Which is absolutely not tolerable by the optic apparatus, the optic nerves, the optic chiasm. So I think we, somewhere down the line, when from traditional, conventional, external beam radiation, we are shifting to radiosurgery, we need to take into account the biological equivalent doses also.
In fact, more than 66 is probably the bare minimum. We would probably go 74, 74 to 76.
So then you need to do 40 gray in 5
Yes.
fractions.
But sometimes the optic nerve is very close to the target, so I can't not give.
So I agree with Dr. Pathak that in bulky lesions there is some data that the volume of the residual disease matters, that is prognostic as well, and the dose received with the coolest portion of the tumor would actually determine outcomes. We have seen that in patients where we could not give higher doses, we've underdosed a portion of tumor, there you see a recurrence after early recurrences rather than late recurrences which are usually seen. Chordomas, most of the literature on gamma knife and very short fraction radiosurgery are just 10-15 patients, very short follow-up. These chordomas need to be followed up for a longer period of time to actually see progression. And as you showed in your series as well, that 5-year progression-free survival was 48% in your 19 patients which you showed, which clearly, and more than half of them actually progress and fail.
Yes,
Yes,
so I
Rupesh.
think for radiosurgery for clival chordomas, there's very limited experience that we've seen here. You see that a little bit with some of the spinal chordomas that are smaller, not the giant kind of sacral chordomas. And kind of getting back to the dose and fractionation schedule, the lower dose fractionations like 16 gray, 18 gray single fraction, or 35 gray and 5 fractions or less have terrible control rates. I mean, they're like 40 to 50%. They're very low for very small sized tumors. There's one experience from MSK of using 24 gray and 1 fraction, which initially had a very high control rate, and it was like 90%. The problem is when they followed those patients out past 1 year to like 3 years, the control rate started dropping very quickly. And then also the risk of neuropathy went up significantly. I mean, the chance of a patient having a high-grade toxicity was like 35% in their last review of that data. So it ended up being a toxicity issue with 24 gray and 1 fraction, which is the only thing that gets you to a biological equivalent dose of what we would give with protons. So I think the uniform recommendations have been for particle therapy for these patients.
Concern was with the volume, then it could have been treated with fractionated radiation therapy. 50.4 gray or 54 gray in 28 to 30.
I think that was shown very well as well. I mean, with IMRT, there is very good data, long-term data. I think the largest data is from William Mendenhall's group, which showed long-term control rates with the paraganglioma with IMRT is close more than 95%.
Yeah, I think actually most of the series with IMRT essentially is like 98% if you look at all of the data together. So, and again, I think if there is data at least here about treating larger tumors, that's why I was getting back to the point. I think it's important to report that as time-dependent outcomes, so it's not just crude local control rates. And I think that's important to add to the literature. But otherwise, I mean, at least, for example, at our facility, following from the UFPTI experience, we would treat all those patients with fractionated radiation, 50.4. We use 54 gray, because you typically see it for younger tumors, and they're larger volumes. So anything that's more than 3 centimeters, I mean, as a smaller cutoff, we would treat with fractionated protons with particle therapy. And again, you have a very high control rate, and these patients are going to live forever. So it's not even about 5-year outcomes, right? You care about 10, 15, 20-year outcomes when you're treating even a 50-year-old with a large paraganglioma.
I think in the IMRT there is 10-year outcomes data, more than 95%. So no need to really stretch by giving all those.
If it was just an access to care issue, then we would do it. But otherwise, I think fractionated radiation is the easier and safer way to go. Especially
fractionated is more accessible than radiosurgery.
Well, no, say for patient access. Like if a patient said, "I'm coming from the middle of nowhere, I can only come for 5 treatments," then yes, I think about it. But otherwise, again, going daily fractionation to 54 gray, you also know the toxicity of that, right? A lot of the radiosurgery literature is in malignant tumors, patients that are not going to live 20 years down the line. So you don't know what high doses to large volumes will actually do long-term for these patients.
Yes.
I think most of the things have been discussed, but again, sorry to bring up chordoma again. Whatever experience we have had for the last 4 years is absolutely critical that we have realized, and I'll show some data in my talk later. The impact of the fractionation, we frequently try to go to 76 gray, and then of course there's non-contiguous spread of chordomas, we all know. But the point I want to make is, it is very, very important for chordoma optimal management to have a good collaboration with a skull-based surgeon. You can't have parallels, and sometimes we have seen surgery done somewhere else. They go to a proton site thinking proton is going to cure them, and vice versa. Yeah. So it needs that synergy between the two, and in about 25% of our patients, actually we had to redo surgery, and we have a very good skull-based team, both from the neurosurgical and the head and neck team to decompress, especially from the optic apparatus and brainstem, and there is tons of data out there, as you also rightly said, to deliver the optimal doses. And wherever we have compromised, and as Srinivas said, we have had seen recurrences. And that it's one of those tumors where there is a beautiful dose-response relationship, which actually translates into clinical outcomes. So an optimal management does need this nice synergy rather than just a radiosurgery, just a proton, and just a skull-based surgery.
I would reiterate the point. Chordomas can be approached by skull-based surgeons very well, and very good decompression can be achieved. That's possible, and that sometimes is very important. Or most of the times, that should be the first goal. So. Yeah.
Thank you.
We're going to close the session. Thank you, everybody.
Break for lunch.
Oh, no, that's not. We have one more session.
So I think we'll break for lunch and then we'll
We'll break for lunch.
So thank you. I think we'll break for lunch and then we'll continue with the remaining sessions after lunch break.
and Professor Harish KP, Consultant Radiation Oncologist, AIMS Delhi. I request our moderators to introduce the speakers of this session. Mike.
Good afternoon, everybody. Next speaker is Dr. Manjul Tripathi, and I think nobody needs any more introduction for him. He's a consultant neurosurgeon at PGI Chandigarh. So he'll be speaking on the current status of radiosurgery in India and how to establish a gamma knife center.
So, changed my talk a little with my experience also with that. So, yeah, my slides. Thank you, chairpersons, and thank you, organizers. This is actually, I do not have any financial disclosure for this talk. Personally, we have treated at our center close to 4,500 patients, and with the radiation oncology robust team with Dr. Narendra and Dr. Renu Madan. And if you look at the current status of the radiosurgery in India, we have 5 gamma knife radiosurgery centers, 1 proton center, probably 2 proton centers now, 7 cyber knife, lots of linear-based centers, and there are a couple of other centers coming. Dr. Manmohan is here. We published our supplement on the gamma knife radiosurgery and the Indian experience recently with the Neurology India. So, this journey, I have been tasked to present my experience over the last 13 years with the gamma knife radiosurgery. Once we started earlier, our indications were mostly vascular malformations, benign tumors. For spine, we sent for the cyber knife. For present cases, we go with we have expanded our horizon, and now we treat some metastasis, movement disorders, psychosurgery, hypothalamic hematomas, and some rare indications with that. If you look at the status of stereotactic radiosurgery performed with gamma knife, this is a slide borrowed from the Lexel Gamma Knife Society. If you look at the lower corner, in 1991, throughout the world, there were somewhere around 7,000 patients treated with stereotactic radiosurgery with gamma knife, and this number rose to 1.4 million before COVID period. So that's a significant increase, and that shows the acceptance, and that's a testimony for its effectiveness, safety, efficacy, and the complication profile. And you name an indication, it's there, which has been treated here, from the regular ones to the uncommon ones like the nasopharyngeal carcinomas and Langerhans cell histiocytosis and all that. But if you, during the COVID time, we tried to identify what is the current status of the radiosurgery awareness in India, and we did a survey in the low and middle income countries. Then we found that only 1/3 of our residents were actually aware of the radiosurgery, which patient should be treated with it, and which patient should be referred for it. Nearly 1/3 had no idea about it, and 1/3 were somewhere knowledgeable about it. So once this is a very important surgical knife now, this only 1/3 awareness is actually a dismal figure in a low and middle income countries, and that shows that we need to improve our awareness about the radiosurgery. Radiosurgery, it's an entirely new way of thinking. It's a primum nil nocere. It's a minimally invasive intervention with a more cautious, partial, conservative approach. It's an early preventive tool, and this philosophy is it should be a neurosurgical philosophy. It should be trained during the time of your residency, along with your neurosurgical training. The radiosurgical training and the philosophy should be taught at that time. I encourage you to read this autobiography by Lars Lexel. According with the existing results in those times, he envisioned the stereotactic radiosurgery, and the results, especially for vascular and the skull-based tumors at that time, they were a testimony of his success, which we are reaping it now. So gamma knife radiosurgery, it's gamma because it's gamma rays, knife because the results are mostly comparable to the open surgery if you choose your patient wisely, and radiosurgery because it's a radiation tool used by the neurosurgeon with the radiation oncologist. When do we treat? We treat the disease early in the course of its natural history. We try to treat them before they become symptomatic. We do not want them to create a mass effect, potentially grow, and to preserve the functional quality of life of these patients. Just to come to the technology, there are 192 sources, and this is just like a surgical strike. Any part of the brain you can treat with it. And the beauty is a sharp dose fallout, which is still unmatchable with any other treatment modality. So if this is your pituitary adenoma and here is the optic apparatus, the dose deposition is inside the tumor only, not to the optic apparatus. So you can preserve your organs at risk while depositing the radiation in your target. And an ideal target for the radiosurgery conventionally is less than 3 centimeter in size or less than 10 cc in the volume. But with frameless techniques, we became bolder. We somehow lost that sharp dose fallout when we are treating with the large targets, and then there is a risk of the radiation exposure to the surrounding tissues. And then we need to modify our strategy with the gamma knife radiosurgery. And the strategy was modified in the form of fractionation. Either you do a dose fractionation or you do a volume fractionation, or if you balance the use of both the knives. You do a reduction in the tumor volume like we do in the plant partial resection for the vestibular schwannomas, and when there is a residue, just treat it with the stereotactic radiosurgery, and the aim is to provide you a long-term tumor control while maintaining your quality of life, and that is the most important thing which matters to the patient. We expanded our horizon. This would again may raise some eyebrows, but this patient has been twice treated with surgery, and the surgery was abandoned. This is a cavernous sinus hemangioma, 100 cc. The patient presented with a 6 nerve paralysis, and that was treated with a 5 grain 5 fraction, and you can see that it practically melted to 1/4 of its volume within 6 months of its treatment. And this is the visual recovery, extraocular movement recovery, and there was no visual deficit to this patient. We have been listening to this vestibular schwannoma talk in the morning, and for course grade 1, 2, 3, we have a very good experience with radiosurgery for the vestibular schwannomas, providing a good tumor control and the functional preservation and the quality of life. One thing which I again want to reiterate, that this is a completely evolved concept in the management of vestibular schwannoma, and the volume doubling time before treatment is 1.36 years in these sporadic vestibular schwannomas, but after gamma knife this increases to 13 years, and that ensures that you are providing a very long-term tumor control without the need for any additional treatment to these patients. I won't comment on it again, but cystic vestibular schwannomas are no more a relative contraindication. They are providing a good result. So once we discuss all this, we need to identify that are the surgical results easily reproducible. That's really a difficult task. Once we talk about the complications, we talk about Majid Sami, we talk about Michael J. Lawton, but it's always better to evaluate your own complication. Compared to the microsurgical series, with a certain level of the radiosurgical knowledge, you are able to actually reproduce these results of a facial neuropathy less than 1%, trigeminal neuropathy less than 3%, and that's actually the goal in management of these patients. With our hypofractionated gamma knife radiosurgery for intracranial pathologies, that's a single center study which we treated nearly around 229 patients with a frame-based fractionation. For functional pituitary adenomas, we could achieve a hormonal remission in 68% patients by a median time in 24 months. Especially for the skull-based meningiomas, the quality of life, when the tumor is in the petroclival location, CP angle location, and the cavernous sinus location, the benign confined cavernous sinus location. In those cases, a primary radiosurgery, when the tumor is small in size, that's going to give you the best functional quality of life until unless the patient presents to you with a trigeminal neuralgia. That one point which got missed in the talk today is that if it's a CP angle tumor and presenting with a trigeminal neuralgia, hit it with your surgical knife. Do not rely on radiosurgery, because the trigeminal neuralgia, secondary trigeminal neuralgia with radiosurgery, the results are poor, and that's a very important prognostic factor in the functional quality of life in those patients. Apart from it, rest of all the cranial nerves, they show a very good improvement. We are now treating these patients with metastasis, and there is a gradual acceptance. Yesterday there was a discussion, what is the patient profile like in the radiosurgery referral. And one more important thing is that apart from your own community, you need to go to the other departments, you need to go to the other gatekeepers who get those primary patients, and then you need to show your results and the literature to them that the radiosurgery is providing a better outcome, not only in the functional quality of life, but an equal outcome in the survival. Some indications which we are treating are still on an evolutionary phase, and we are still dealing with them. We tried to treat some patients with the intracranial histiocytosis with good results, and we could publish it in World Neurosurgery. Coming to the vascular malformations, cavernomas, especially the deep-seated ones, are an established indications with the gamma knife radiosurgery, but the superficial cavernomas presenting with epilepsy, they are a controversial zone, and I prefer to treat them with surgery to provide you an immediate benefit. But we recently did this study and we found that solitary cavernomas with at least one episode of seizure, if you treat them within 1.5 years of your seizure presentation, the chances of achieving an Angel 1 status is pretty impressive, close to the tune of the 70%. We published our series with the hypofractionated gamma knife in this gamma knife supplement, a single center prospective analysis. I earlier told that this is a frame-based fractionation. We treated 202 patients in 1 decade. And this was the 41% patients were treated in 3 fractions, 59% in 2 fractions. This is actually very difficult for conventional mindset to accept that this kind can be done, but this has been extrapolated with the icon now, and this is now a standard of the treatment throughout the world with the fractionation going with this. Some patients we needed to treat because those were large in size, and some patients we needed to treat because they were in close proximity to the organs at risk, and we couldn't avoid the spillage in a single session to those patients. And you can look at all the indications, practically every indication is there which we treat with the radiosurgery in these patients. This is a 14.2 cc AVM with a venous pouch. We do not need to jump over it, that this was an unbled AVM treated with 9 gray in 3 fraction, and this is the result at the end of the 3 years. So I especially took this patient because you do not need to embolize these patients, you do not need to utilize all the modalities. Just with the primary radiosurgery with the 9 gray in 3 fractions, this is the complete disappearance and the patient is safe. We treated these patients which were in the motor cortex, deep thalamic AVMs, brainstem AVMs, large volume with our fractionation regime which is well published, and we have shown the impressive results with all these patients. This is a 35 cc AVM, an insular AVM treated with a 11.5 in 3 fraction. He developed some radiation-induced edema which needed bevacizumab administration, but it shows a complete nidus obliteration and the patient is back to his routine. Sometimes we try to find some new ways to treat the disease with our existing modality, like this is a mandibular division trigeminal schwannoma which was extending deep into the jaw, and for that because there was you can't just ensure an immobilization with a cleansed teeth, so we did a jaw immobilization with the non-invasive dental wiring treated with the fractionated gamma knife radiosurgery in 2 sessions, and this lesion showed a 70% reduction, published in International Journal of Radiosurgery. This I have already shown. This was a custom tailored approach because the patient had no other choice. And this was, this lady was actually a case of, operated case of an IDM with an intracanalular component. And then it was not having any proximity to the spinal cord, so we could safely treat it. Sometimes I had some miscellaneous complication, like as Dr. Manmohan showed, the cystic degeneration, already a matter of disputed identity, and the temporary non-cicatricial focal alopecia. And you get wiser while treating these patients over the course of time and to try to find what might be the root cause for all these ones. We could add to the existing literature with our experience with single fraction and multiple fraction is that it's the utilization of both the philosophies by providing a significant advantage by the steep dose fallout for sparing the organs at risk and the normal brain. Coming to the functional indications, trigeminal neuralgia, I treat that disease. It's an orphan with many fathers because there are many takers right from your surgical knife to the radio frequency and all those, and none take the responsibility for the long-term cure of these patients. But if you compare the treatment modalities, you will find that the best results and the safest results are, best results are with the MVD and the safest results are still with gamma knife radiosurgery. This is a very difficult treatment modality, the giant hypothalamic hematoma, ridges grade 6, expanding everywhere, both above and below to the hypothalamus, and we treated these with the fractionated gamma knife with the patient as young as 9 months. And we could achieve an Angel 1 status in 60% patients at the 3 years follow-up. We are coming with our further series. There would hardly be any tumor reduction, hematoma volumetric reduction, but it shows a very good response as far as the seizure control is concerned and the endocrinopathy normalization is concerned in these patients with an excellent neurocognitive outcome. This is a palliative treatment which we published. You can use it as a primary treatment modality because none of your treatment modalities for Lennox-Gastaut and all these patients is a curative intent. So this is again a palliative intent without putting a single knife in the brain, and it is providing an equal relief. You can use it as a completion callosotomy or you can use it as a primary callosotomy in your patients. This is gamma capsulotomy. Because of some psychosurgery related rules and the issues, we are not able to do it now, but we had some very good results in the obsessive compulsive disorder. We also had a complication which we need to manage with the surgery with the earlier versions of the gamma knife, where we couldn't prevent the dose spillage into the surrounding areas. I would like to take you to, I'm sorry for the quality of the video. This is a person with the hemidystonia. He was offered all the options, right, from the radiofrequency pallidotomy to the DBS and then the gamma pallidotomy. Gamma pallidotomy has gone into the disrepute, but I'll show that this posterior 1/3 of the GPI was targeted on left side with 140 gray, and this is his result by the end of the 6 months without putting a single knife in this patient. I can't always say that this would get replicated in every patient, but yes, we could achieve this much effect in these patients. This is a patient of the Holmes tremor. We have been treating the essential tremor with radiosurgery, and this is a Holmes tremor, young boy, again, strictly against any sort of any invasive procedure. We treated it with VIM thalamotomy with 140 gray, a single shot. You can see the radiological signature, MR signature over there, and this is the result by the end of the 4 months. He has improved to nearly around 80%. The improvement is better in the right upper limb than in the right lower limb. But I found this is with a precision similar to a surgical knife. We had our own set of complications also, and we were very vocal about presenting them and publishing them. The use of the bevacizumab, which has been included in the recent IRF guidelines also, and they reviewed our article over that. We devised a checklist for the gamma knife radiosurgery so that each step is monitored and the chances of complications remain minimized. Again, I can show that the hearing loss is not a permanent, and the people regain their normal hair by the end of the 3 months. This is a large AVM over the surface. I'm slightly on the philosophical side of the radiosurgery also. We found a patient who was weeping, and this was considered as a collision error by the machine. And it again showed a collision error when we were sure that the frame is not sticking anywhere, but still we found that. I find that accepting the radiosurgery as an option for a traditional mindset becomes very difficult for a neurosurgeon. And for the young neurosurgeons, it excites you, something like a teenage sex, and for a seasoned, it may aggravate, it may deceive you like a midlife crisis, but it's a very balanced, partial, conservative approach. It may hit your ego, but it would save the functional quality of life of your patient. During the COVID time pandemic, we had to adapt our radiosurgery practices. We could do that, and we found that we could seamlessly treat our patients despite having a pandemic throughout the world. So when it's a matter of the brain, I would definitely like to say that it's not about just hitting the right target, it's about missing the rest, because the quality of life is important to the functional outcome and the overall well-being of the patient. If you look at the evidence in the literature, there is a significant difference. Nearly 70% of the evidence is with the gamma knife radiosurgery. I'm not promoting that, but that's the hands-on evidence present over there. In the last, I just like to take Michelangelo into it. Do you know why these two fingers never meet? The God has extended his finger completely, but the Adam has flexed his distal phalanx. This flexion is an indication of the free will. Until you have a free will to embrace any technology or to evaluate it properly, you are not going to meet these two fingers, and that's going to hurt the science and your patients too. So for many things, like most of the skull base, I do not think that there is still a debate on the surgery or other indications. That debate part is practically over. Let's accept it, and let's be more refined in our technologies over it. At PGI, we are treating these patients in a very protocol-based manner. Over the last 10 years, I realized that to meet the patient's expectations is a very important task. So to give them a patient information booklet showing them the videos, and then they have a realistic realization about the outcomes. One of the most important things to learn is that the tumor is not going to disappear in most of these cases. The patient comes with a follow-up MRI, the tumor is still there. He should be aware that this is going to be there. It might reduce in size, but it's going to be there. If he agrees to that point, that's the best part we had. So I again say that use make the best use of your knives, and that would give you the best results and the patient satisfaction. Thank you so much.
Very good talk, Manjul, as always. The house is open for any comments or questions.
Yesterday, Dr. Tejpal, let's see, as there are so many data on dosimetric parameters which are showing difference. Gamma knife is excellent in terms of LINAC-based treatment. But when it comes to the outcome, there may not be too much of difference. How you take it?
So I think the Rupesh would be a better person to answer because he's going to have a talk on that on the different radiosurgery platforms. But I think we get wiser with the growing time. It might be something like a Second World War when the people used to smoke and then they had a completely new generation which is filled with the lung cancers down the line 4 decades. So most of the parameters are now getting equal with different radiosurgery platforms. The only thing what we are looking at is the 12-gray volume because it's the matter of the brain and the extracranial dose distribution. So for among rest of the parameters, the things are more or less equal, but as far as the safety and probably that long-term complication, probably still we are having machines with some differential values.
Yeah, I think the point that you made earlier, which I think is important, it's that the published literature right now is particularly with Gamma Knife. If you look at the published literature on radiosurgery, so different than what you looked at is just the number of publications. If you look at radiosurgery publications, 75% of them are actually Gamma Knife publications. If you look at the technology that is used, and actually Gamma Knife accounts for more publications than all of the other radiosurgery technologies combined. So that's been the historical precedent. Now, some of the outcomes with LINAC-based radiosurgery are getting better and better as the parameters are being evaluated, as the technology gets better over time. So I don't think it'll become to a debate of actually choosing the technology for the particular patient scenario and what you have at your institution. How do you make that technology work for you? But at least that's where the published literature has been to date.
Okay, man. Thanks, sir.
Thank you.
After this wonderful talk, let me invite Professor Nishant Sadashiva for next talk, Gamma Knife Icon, the experience with advanced innovative technologies. Over to you.
Thank you for the wonderful talk, Manjul. I hope I'll not be boring you after this wonderful talk. I'll be mainly focusing on what changed in our institute at NIMHANS over time and how we have evolved over time rather than delving into literature review or our publications. So I'm working in NIMHANS since almost 9 years, and there are no conflicts of interest. So stereotactic radiosurgery as such, if we see since almost 7 decades, it has been evolving, and we have evolved over time since with different machines, different radiation sources, and different mechanism of delivery. But still after so many years, we still consider Gamma Knife radiosurgery as a gold standard in spite of having a good competition from many other delivery machines. So Gamma Knife radiosurgery as such is truly multidisciplinary, and though it is headed by neurosurgeon, it has equal contributions from physicists, radiation oncologists, a nurse, and radiation technologist as well. So over time we have seen, this slide is already shown by Manjul, there is an increasing trend of patients getting treated with radiosurgery in spite of many platforms being there. So right now in India, there are 5 fully functional radiosurgery units using Gamma Knife radiosurgery, though throughout the world there are more than 370 centers. Over time, even Gamma Knife radiosurgery through different machines has evolved from Model U to presently the more recently Icon and then Esprit. We are using Icon since the past 3 years. Past 2.5 years, we skipped from 4C. We had 4C, we have used 4C for almost maybe some 14 years, and then we skipped Perfection and directly went on to Icon. So it was a huge leap for us. It was a totally different experience. That's what I want to show here, how we evolved. So this was the gamma knife version C, which we had. It had a helmet, and patients had used to go inside this helmet. And after positioning with different collimator helmets, like each size of collimators had different helmets. For example, 4 mm size collimator helmet would be different from 8 mm collimator helmet. So we had to go in after each collimator delivery and change the helmet. So that took up a lot of time. So like any other standard frame fixation, we had to fix frame for all our cases. In some cases, we had to fix the frame up, some cases fix the frame down, so that reachability is not an issue, especially with the limited space available for movement inside that helmet. So we had to do a lot of circus to do so that the lesion is the center of the frame. But over time, I'll show like how that has changed. So because of this, we had a lot of cancellations of gamma knife. So we used to fix the frame, and sometimes preoperatively we thought in the pre-op discussions we used to cancel the case because of reachability issue or something else, or large tumors. These are the breakdown of cases. Around 121 cases we had to cancel over 13 years because after fixation of frame we thought that okay, this may not be. For example, a small lesion might have grown, a small lesion might have a cystic change, a lesion might be non-reachable. All these things were different reasons for our cancellation over time. So this was a typical example of why we cancelled that case. It was because of the target was not reachable because of the eccentricity of the tumor located. So the same plan is done with ICON. So we didn't have any problem in reachability issue. So this is another case where we had to cancel this case and operate because just for the reachability issue earlier. And this case was easily treatable in the present machine. So after that experience with 4C, like I got to work with, I got this Ladislaw Melita Steiner Fellowship under the aegis of Lexel Gamma Knife Society. I visited Roswell Park Cancer Institute under Dr. Dhirendra Prasad, after which I gained a lot of insights, like how a newer machine can be versatile in treating many patients, what is the advantage of the teamwork, and how complex planning, dose distribution, titration was very important for individual patients, and how many cases can be treated in a day with in a streamlined manner. Especially how it was an eye-opener for me, especially by seeing a lot of metastasis cases getting gamma knife done. So after that, I came back, and we fortunately the government allowed us to install the ICON machine, and we started using ICON. So the ICON machine, I already told you, we skipped perfection. The dose modality or the dose treatment is almost the same. But it has 28 sectors all around the conical or cylindrical space, and it has almost 300% increase in the volume of space available inside the machine. So the dose reachability was not an issue for us. And especially like with the complex shot arrangements, with composite shots, for example, on 8 sectors, you can shape the beams into different sizes with opening 4 mm shot in one sector and 8 mm shot in another sector. That was an eye-opener, and especially made the dose titration in organ risk very particular and important. So this is how patients have been treated throughout the world. If you see, there is a gradual increase in trend of the number of cases which each gamma knife center does. So approximately 350 is the number at around at the end of 2020, where individual center used to do 350 cases per center. But if you see ICON model, like there is a drastic increase in the number of cases which can be done. So especially in Asia, the average is almost 770. So this is how our number of cases treated varied according to the year. Like after like a few of the younger people joined, like we wanted to do more and more cases. From 2019, 2017 we started doing more cases, but still it was not up to the numbers which we can do now with ICON. We have almost done around 865 cases in 1 year after installation, in 1 year. So on an average, it comes to around 68 cases per month. This is the gamma knife indications from the start of gamma knife center in India. Like a majority of them are vestibular schwannoma, followed by AVM and meningioma. But if you see how the geography has changed, like over time from in ICON, we have treating more of arteriovenous malformation also. This number, increasing number, is especially because we are able to treat larger untreatable AVMs now with fractionated treatment. So we have treated almost 2,300 treatments we have done almost in 2 years. That is almost 1,000 treatments per year. And we have done 184 fractionated treatments in 2 years. That equals to almost 600 treatments for, in fractionation. So thanks to fractionation, like it can be done in ICON, like patient can be put in mask. There is inbuilt cone beam CT, which we can use it to do a scan. The patient goes in, gets a mask, gets the cone beam CT done. After the cone beam CT is fused with the MRI, and the treatment planning is done, and dose delivery can be done. During dose delivery, the important thing is there is intra-treatment motion management, which can be done by a fiducial placed at the tip of the nose. And if any movement happens during dose delivery, for example, if you see, if there is any movement happens during dose delivery, the treatment stops. So when the patient goes back, if the patient goes back to the previous normal position, the treatment continues. And you can set it like what is your range in which you can allow movement. For example, a metastasis, like if you think that the accuracy is not more important, you can increase the level in which you can allow it. So fractionated radiosurgery has been a game changer for us. Like we have treated almost 86 patients of AVM with fractionated radiosurgery. Previously or anywhere else, like those patients might have been considered non-treatable or not treated. These patients many are symptomatic, many have bled, but many would have undergone multiple embolization, multiple bleeds. So it was not even gamma knife radiosurgery. I am not telling that that is the epitome of treatment right now. At least we are able to offer some treatment for these patients. So this is how patient gets the docking of the cone beam CT happens first. We explain to the patient that the patient can relax and not move, and there is a signal indicator in the switch in the hand of the patient. If patient is uncomfortable, we can go in and release the patient. And after docking the patient, like we come out and cone beam CT is done. After the cone beam CT is fused with the previous scan, then the treatment continues. I'll just skip it for time sake. So this is how the patient is positioned. After that, the patient goes inside, and high definition motion management is done during treatment delivery. So coming to planning, like previously we used to do forward planning, manual forward planning. We used to place individual shots inside the volume, and we used to build a dose cloud so that it is more conformal. But over time, we got a thing called inverse planning with fill and optimize that came with perfection model, which we easily skipped it. It was not great. And then presently we have a thing called fast inverse planning, which is called lightning. The good thing about thing is it is easily reproducible. It doesn't require an experienced person to use it. For example, manual forward planning needed a lot of experience. Like our physicists were very good in it. Like after this came, like our physicist, actually the skill set has gone to waste. So this is how the planning, the lightning works. Like you can set the prescription dose. If you want your isodose line is very important, you can put the max dose allowed there, and then you can titrate the low dose or beam on time, and then you can hit optimize. After hitting optimize, it will fill the shots and do optimization on itself based on the ideal scenario. And this is how we already got the plan. So after this, like if you have already given the dose constraints, it will make sure that it is within dose constraint thing. So for example, there are some extreme situations where it is so close or it is not possible. At that time, you have to go in, fill in shots or delete some shots, and you can still do manual change of this plan. So we did a small pilot study of how the treatment time and the time taken to plan and all varies. The time taken to plan drastically reduced, and in the same time, the time taken for treatment has also increased because it is filling more small shots. And gradient index is also increasing over time. That is the greatest gift for any planner. So with ICON, we have several treatment pathways. Like we can frame up, like regular how we used to do, frame up, do MRI, do plan, verify and deliver. Or if you can do, if you have an MRI done yesterday, you need not repeat an MRI. You frame up, and if your accuracy is very important and you still want to treat with frame, you frame up, then do CBCT, co-register and treat. And if you have, if you want to do a mask-based treatment directly without framing at all, so you can, previously MRI would have been done, you plan in that, you do mask up the patient and you do CBCT, verify the plan, fuse the plans, and then straight away you can give, deliver the treatment. So these are some of the examples. This is glomus jugular treatment which was done day first yesterday without any plan. And then like I'm just showing how a new plan is done for this typical AVM. So like we just use fine gradient and we just choose what are the what things you need. It is more important to consider beam on time, or if you want to consider more low dose inside the lesion, you can change according to the grids available there. So after you hit optimize, so it will give you a plan within a very short period of time. And after the plan is made, you go ahead, verify the plan whether it is acceptable or not. If it is not acceptable, by changing the low dose and beam on time, you can change, multiple iterations can be done. So though it is multiple iterations can be done, the plan time taken is very fast. You can see the coverage is 99%, PCI is 75, and gradient index 2.45, though it is 2.5 would have been better. But so multiple iterations can be done, like how I am changing here. Like for example, I thought I can decrease that beam on time. So I changed the beam on time, and then it would have given a lesser beam on time. So this is how a typical plan would be, and how there is a rapid dose fall off. These are some of the examples of small vestibular schwannomas. Please don't expect the same in every case. So you can, because of dynamic shaping and those composite shots, you're able to restrain some of these organ at risk, and then deliver more hotspots or whatever higher doses to the away from the organ at risk. So this is another example. And with this upgradation from 4C to ICON, like at least in our center, we had cut short the planning time a lot. For example, patient is in MRI, and by the time patient comes back from MRI to your console, we have already prepared the plan and patient directly goes for treatment. So there is no interruption. Like earlier with 4C, every time we had to go in. Like if you ask any person, they would tell that interruption would cause a lot of decrease in cumulative dose. So there is shorter treatment time. Cone beam CT has helped us to increase mask-based treatment, and total overall, at least in our experience, at least 20 to 30% increase in indications has happened. So these are some of the examples. This patient with cavernous sinus hemangioma, everybody knows like we don't operate them, especially if it is small anymore. So this has complete improvement in third nerve palsy. Though some people still feel that, okay, like optic nerve, if it is compressing optic nerve, we have, if you see here, like we have undercovered a bit, 1 mm undercoverage is there. But still patient has a fantastic response. This is at around 3 years. So as expected, initially AVM can have some edema. So over time, if you treat it properly, it goes off and it has a fantastic response. Glomus tumors, good response at 3 years. And this is a typical example of how vestibular schwannomas respond over time, like they shrink. This is another example, like how initially there is a cystic change, necrotic change, then subsequently there is decrease in size. So coming to bigger tumors, we always strive to decrease the volume of the tumor as much as possible. We try to leave only the intracanalicula part or the lesion which is stuck to the brainstem. So it's been proved that the smaller the tumor size, the better is the outcome. So we decrease as much as possible, and then preserving the facial nerve. This is another example. You leave as small as a tumor as possible. These are some of the examples like that. So basically we try to do a combined radiosurgery and surgery combined that would give a best result as well. So this we operate pituitary adenomas as well as much as possible. See, there is a small nubbin of tumor in between the vessels, so which we felt that it is more risky to remove. We left that tumor and we gave a gamma knife in 3 months. So patient with AVM who had a good response at the end of 3 years, there is almost total disappearance. There is a small blush still, but I would come to complications. These are some of the complications I want to show, like especially Dr. Manmohan talk about a delayed hematoma. Like this is typically called as a chronic intracerebral hematoma. So this can happen because if you do angiogram of these patients, like there may be total obliteration of the AVM, but still it can bleed and it can have a lot of edema. It's rare, usually less than 1% at the end of 5 years. It can happen, and it may require surgery if there is no abatement of edema with steroids. So this is another example. So this is another example of how cystic change can happen. This is at the end of 5 years, patient had a cystic change for which patient had to undergo surgery. So these are some of the examples which we have recently treated with ICON, fractionated, and we have only preliminary results so far. At the end of around 1 year to 1.5 years, the early changes have happened, promising changes are revealing. So there is a mushy appearance. If you see here, there is a bit mushy appearance and a small amount of necrosis which naturally occurs in the initial part of treatment. So that has happened over time. All these cases are done in the recent past 1 to 2 years, which have shown that they have started to respond, but we don't have a long-term results yet. These are some of the examples. So this is our team at NIMHANS, and the only thing we lag right now in all of our Gamma Knife Center in NIMHANS in India is that we are not doing metastasis enough. So if you compare with any other center throughout the world, I think especially in Asia, the number of metastasis done by any of the 6 Gamma Knife centers is less than maybe 5%. So I think with improvement in immunotherapies, targeted therapies, and as improvement in survival happens, I think people should switch over to radiosurgery rather than giving radiotherapy. Thank you.
Excellent coverage of the update in technology of Gamma Knife and your personal experience. Now the house is open for discussion.
I'm talking about the instrument as such. Here we can treat only the cranium, not the extracranial parts. Any thoughts on that?
I have no idea. Whole body Gamma Knife.
Thank you, Dr. Nisant, for a nice talk. Just wanted to know, have you claimed that after the ICON, the number of patients increased? How it is related to the, whether it is perfection, 4C or ICON, number of patients? Because it depends upon the source decay time when you are taking the patient. Suppose you are comparing the patient with the 4C, in which cobalt was last year, was the last year of their decay. And now you have taken the perfection where all the cobalt sources are new. So obviously you can treat more patients. But as far as you are saying the planning time is concerned, whether it is 1 minute, 2 minutes, 10 minutes, the treatment time will be remain same. So how it can be increased? Execution time is same.
So I think you mistook my talk. I told about increase in the number of patients who can be treated in a day, because and as well as increasing the indications, 20 to 30% increase.
Yes, if indication increase, that is okay, but the number of patients increase in a day,
I think you have not
that
used,
will depends upon the.
I think you have not used 4C. We used 4C. We came from 4C to ICON. You cannot treat more than one patient.
I can answer your question.
So better to not compare with the 4C, compare with the perfection and then to the ICON. Why you are comparing with that 4C?
I can compare only with ICON because I have ICON and 4C because I have used only this.
So that is going to give a wrong message. Na? You are comparing with 4C to the ICON.
It's my experience.
It should be step-by-step comparison. I don't buy the literature.
Yeah. Okay, for 4C or the model B, if we compare with the perfection or ICON, the situation is there is a hell of a difference. Because the perfection and the ICON is basically a robotic system where we don't have to change the position of the patient and head, so that you save time. Because in model B on 4C, you have to change physically each and every coordinate on each shot which you are giving. That consumed a lot of time. If you want to treat even for a small tumor in model B, I can tell you that you can take hours for that. And that can be done in a matter of in half an hour or 40 minutes. So that's why you are saving time and you can do more cases in one single day. So that is the
Especially
reason.
with shot blocking, like
Yeah, exactly.
because
If you have
it
to
used
block
take
the
forever.
shot, it is all physical. You have to take out and block the ports.
Nodes. Yeah,
Nishant, excellent presentation.
Yeah.
Yeah.
Dr. Vastu, please.
So we have to stand up.
Since our MD days, I'm a radiation oncologist, and since our MD days in CMC, Bangalore, in Tata, and all over, we have been hearing that gamma knife is the gold standard and LINAC has limitations. You know, today you have features in gamma knife like ICON, which is cone, the CBCT, cone beam CT matching. You have multifractionation, you have mass-based treatment systems, and various other features. Your inverse planning, inverse calculations, Monte Carlo, motion management, all these concepts have been brought from LINAC. So in terms of dose conformality, definitely gamma knife was the gold standard. Having said that, LINAC also had various features which, you know, the merger of both or the amalgamation of both would have made it more complete. So LINAC-based systems have had their own merits and they have been good. Now that those features are available in gamma knife, I think it's a wonderful system in ICON, and you yourself are feeling much more comfortable that the location which you are able to treat.
No doubt.
Nishant, wonderful. I learned many things today. Thank you so much. I have only one question. It's just a follow-through of what discussion you had there with Narendra. How much time does it take to treat, say, acoustic goose for 1 or 2?
It all depends on the source.
12 gray is what you're doing.
No,
How much it is taking now? That's the question.
So it all depends on the source. For example, newly loaded source.
Yeah.
For example, it may
Now
be
I'm
50
asking for
right now it may be like 40 minutes, 30 to 40 minutes. It all depends on you also. Like we can plan based on your time constraint also. Like the quality of the plan and time constraint are two different things. Like you have to balance. Like it's your decision. It gives multiple iterations. You can do multiple iterations. Ultimately, your experience and what is important, what is not important, you have to choose. Beam on time. If you keep beam on time is my main constraint. It will give a bad plan in a very short time. And big shots. Like if you want smaller shots, sparing of organ at risk. So time might.
So if you treat a trigeminal shooting 85, 90 gray, how much time it takes?
Trigeminal neuralgia, right now it is taking around 45 to 50 minutes.
Okay.
It can go from 45 to 7 hours. It can go from 45 to 7 hours. That I want to make clear. So I am adding to, because if you are treating the latter part of the cobalt decay, then it may take 7 hours even. So that's
yeah.
Just
so like there is one more important thing, especially you made that point, especially with functional neurosurgery and like AVMs and such. So dose output is also important. So like you have to modify your plan according to the dose output as well. For example, high dose output in a small tumor with high dose, complications may be high. So you have to modify your plan according to the dose output as well.
Just to clarify the whole body gamma knife, I'm not sure there's a whole body gamma knife. Are you confusing with cyber knife? I mean, so it's a whole body gamma knife. I'm not very sure.
It was brought out in the China, sir.
I think the issue is not cyber knife or gamma knife versus each other. I think the technologies are quite similar. There are good points in each machine. You have to amalgamate and get the best of what you have. The treatment times are sort of significantly reduced, not because of the on-beam time, but because of the changing time. So all that has been automated, and that is why the reduction has occurred. And you don't have those things of long time periods. Previously, when we were doing on the manual systems, I started with the CUDA system, the first gamma knife in Sheffield. That was the third gamma knife in the world. To fuse two targets, two shots together on the CUDA system would take you 45 minutes to 1 hour just to do the calculations, which in the subsequent moderns was with a click you could get it. And now, when we were doing with the B modern, we were not wanting to do more than 7 to 10 shots in each case. Now you can do 100 shots and still do it in less time. So it's not a matter of trying to sort of have these fights amongst ourselves. We need to know the technology is there, and we can use it for the benefit of our patients. Whether you use it or I use it, whether we use a gamma knife or a cyber knife is not the issue.
Yeah, you can use, it can increase the number of patients.
Sir,
increase
just
the number of
continuing.
patients.
Yes, sir, please.
If you increase the number of patients, if you work like the Chinese, they have got 3 shifts. So you can keep on doing 24 hours, procedure, and the source remains the same. So they extract maximum from the source.
I think
keep
we
on
are
doing.
losing time. And
Just one last comment, sir, if you, with your permission.
Yeah.
I think as a neuroscientist, you need to ask yourself whether you are getting hooked to the question or you are getting hooked to the answer. If you are hooked to the answer, then it's going to be a dead end for everyone. That these technologies would come, they would evolve over the time, and you would gain your experience with the passing time with your treated doses and all those indications. Let's remain hooked to the question rather than getting hooked to the answer. We will get better with these technologies over the course of time, but at the current level of evidence, we can definitely discuss, and that discussion has no end.
Yeah, Nishant, just only one small thing. See, now you're using the mask, so you're giving the margin as well.
No.
So then it's something which is usually when you talk about linac-based treatment, and if you're putting mask, the thing is that as you're putting the mask, the errors are there, and so you need to put a margin. And the advantage of Gamma Knife is that is a fixed frame, so you don't need a margin. So how it goes?
So they've done like there are many studies which have shown that with intrafractional motion management, like it is the accuracy is up to less than 0.15 millimeter, but like we have seen patient moves, and like I shown that this thing patient kept moving, patient moves, on, the treatment stops.
Yeah, that's the question is now. That the time will tell the answer. If we are talking about some millimeter accuracy that we are achieving by the linac base, even now we are going to that some millimeter accuracy without the frame we are trying to get. And we have no answer whether there is any interfraction moment in the Gamma Knife with the icon. That's still
we
to
can
be
discuss
answered.
everything over a cup of tea, and I think everybody is now dozing off.
Nice discussion.
So I think we close this session now. Thank you. Okay, bye.
We would now begin with Satellite Symposium on Radiosurgery of Intracranial AVM and Brain Metastasis. The moderators for this session are Dr. Kaustav Talapatra, Consultant Radiation Oncologist at Navnati Max Hospital, Mumbai, and Professor Subhash Gupta, Consultant Radiation Oncologist at AIIMS, Delhi. I request our moderators to welcome our speakers for the upcoming session.
So good afternoon, everyone. So in this session, we'll be discussing about radiosurgery in intracranial AVMs and brain metastasis. So without wasting much time, I'll invite my first speaker, who is Professor Aditya Gupta. He doesn't need any introduction to the house. So over to you, Professor Gupta.
Thank you, chairpersons. I'm not sure how, yeah, okay. So again, a big thanks to Dev for this very kind invitation and to the organizing committee for this excellent meeting. How do I advance the slide? Okay. So I'll first take you through some overview, then imaging process, then how to contour AVM case, and then obviously some illustrative cases. Now, AVM is a very, very interesting entity when we treat it with radiosurgery, and there was a lot of interesting discussion about acoustic schwannoma natural history. So I can assure you the AVM natural history has much more components, and it's probably 3 or 4 times as complicated as tumor natural history. In simple AVMs, I think which modality you want to choose is basically a question of what kind of AVM you're dealing with in terms of both the natural history and the angioarchitecture, including the age of the patient, what kind of presentation, and these are the options available. Let's not forget the last option, which is labeled as observation. And I think this is a very important point to keep in mind. Now, radiosurgery is, and I think will likely remain, a very, very important modality for AVM management. And the reason are these 3 very, very key attributes of AVM radiosurgery, which is being very, very low on invasivity, proven long-term reliability with a large body of literature especially gamma knife literature, and relative independence from angioarchitecture, which is actually a very, very valuable attribute which enables us to treat many AVMs which cannot be dealt with endovascularly. Now, the mechanism of action is well known. There are several nice studies, including some histologic studies, which show the sequence of events once you deliver a high dose of single session radiation onto an AVM. There are certain molecules which get secreted, and basically it is a late phase reaction which begins actually around 6 months after you've delivered the radiation. There is also some protective effect which kicks in at around 6 months, and the process is usually complete by 3 years. Next, let us look at the imaging. So radiosurgery being an imaging-guided treatment, I think nothing can be more important than imaging. How do you define an AVM? So personally, I've done gamma knife for 15 odd years, and this is what we used to do. The fiducials, when you do a DSA, help you to, using the crosshairs, help you to delineate where is the actual AVM. And that is what you then contour on the MRI images, and then you deliver the radiation. Now, using this kind of a planar imaging, what essentially you're using in a gamma knife scenario, basically it's pretty easy to overestimate the AVM volume. I think that has been shown by several studies, one of which I mentioned here. Additionally, if you look at this very nice imaging paper from Pittsburgh, they've shown that the conventional DSA is actually very low in resolution because your voxel volume is very high. So if your voxel volume is very high and you're using planar imaging, then the resolution is actually not very high. Things like CTA and MRA, which have a lower voxel volume, have therefore a higher resolution. Now, going to when I started doing radiosurgery for AVMs on the CyberKnife, this is about 2014 or 13, the method of doing frameless radiosurgery is slightly different. You don't have a fiducial box and you don't have a frame. Therefore, how do you localize the AVM? So this is a technical article by Professor Colombo. I was lucky to have the opportunity to sort of visit him and learn from him. And this is well described now as a very, very good procedure which can be used in most of the CyberKnife and Linac platforms. Now, what has also happened is that the rotational angiography imaging quality has improved drastically. Now, look at this image. I don't remember seeing these perforators from the basilar enter the brainstem. You know, this kind of fine imaging is actually very, very striking. And the current VASO-CT, which is basically a 3D rotational angiography using a biplane DSA, enables us to do this. Now, this just uses 5 or 6 milliliters of extra dye, and it takes an additional 5 minutes to acquire these kind of images after you do a biplane DSA. Now, this is a classic example of a VASO-CT, and very soon you will see this AVM, which has been partially embolized. And you can see the embolized and patent parts of the AVM very, very clearly. On the right side is the technical protocol which can enable you to do this and to get these CT-like images on your system. And I guess most of the CyberKnife and Linac platforms would be able to do that. Now, integration of this kind of three-dimensional rotational angiography enables us to be more selective in our contouring of the AVM. And as I said earlier, AVM contouring is probably the most important step in achieving a good outcome, in my opinion. And there are several papers, of course, which have demonstrated that 3D rotational angiography enabled them to create a more selective contour for the AVM. Now, CT angiography itself, I think the resolution is very good. MRI angiography is also used by several institutions as the modality of choice. In fact, it's not a bad idea to include it alongside the other information. And in fact, in many institutions, MRA is used as the modality for imaging in AVM. The recent exciting sequence is the arterial spin labeling, which I think has a high potential for use in the future for radiosurgery. And in fact, this is from one of the Gamma Knife centers in which they have done what they called as a triple MRA, in which they have the MRA using both the techniques, the time resolved and the time of flight, along with the arterial spin labeling. And they have quoted very exciting results, which we are also exploring. Now, coming to the contouring, which is a very, very key part. As we know, for radiosurgery, this is probably the single most variable step as to between two operators who will contour the AVM in which way. The confusion is also there because, in this picture, if you see the typical T2 MRI, there are several vascular structures which you could contour. And in fact, if you contour all of this thinking that this is the AVM, then actually you're heading for a disaster. So the reason is you have the true nidus, which is, of course, the holy grail. You have draining veins. You have a surrounding venous congestion, which can be very prominent in some AVMs. You saw a recent slide showing a very pronounced venous pouch that can be there. There can be aneurysms, there can be new vascularizations, and associated vascular abnormalities such as DVAs. Now, what we like to do is, especially for the complex cases, I like to sit down with my endovascular colleague. But really, for simple AVMs, what I do is I begin with the vaso-CT images, and that, for me, is a very specific and selective starting point. After doing that, I finish it off by using the axial imaging. And of course, the volume then will determine what dose we use. I think I'm a bit conservative with the dose that I use. This is just to be very careful. And of course, the basic guiding principle is that your V12 has to be in a certain range in a given location of the brain. Now, after this, let us take a look at few illustrative cases. So this was a typical left thalamic AVM. And in fact, this patient had bled, but there was actually no other option of treatment. Surgery was not possible, endovascular treatment was not possible. And we chose to treat this patient, and this is the vaso-CT. So if you see, it's a very fine delineation of the AVM, which enables you to contour it very selectively. And this is the contour which takes into account both the vaso-CT and any normal tissue, of course, which needs to be spared in the contour. So currently, as I said, I'm working with the cyber knife. This is the final contour of this AVM. The T2 MRI, as you can see, can be very fallacious, because in patients who have bled, there can be a lot of hemosiderin staining which can surround the AVM. So in this particular example, the AVM volume was 1.5 cc, and the V12 was 1 cc, which we thought was a good trade-off. We were able to give 18 grays to this AVM with a good conformity index of 1.22. And this patient actually showed obliteration in 3 years after radiosurgery. So another example, a left posterior temporal AVM. So I tried contouring it just on the MRI. I landed up with the contour with a volume of 5 cc's. But once I contoured using the vaso-CT and the MRI, the contour volume was only 3.5 cc's. Now, I think clearly, there are certain vascular structures you have to exclude from the contour. And if you look at the right side images, you will understand why what I'm saying is that the draining vein, you do not need to contour all of the draining vein. You just need to include just the proximal part of the draining vein, which is actually a part of the nidus. Now, tectal AVM with bleed, again, a very small AVM, no other solution available. So look at the vaso-CT. It gives us a very, very clear guidance of what you want to contour. Now, micro AVMs is a very interesting entity in which sometimes it can be very hard to localize these micro AVMs even on a vaso-CT. So this is a young person with a bleed, and that's the micro AVM there sitting on top of the corpus callosum. And we delivered 20 grays in a single fraction to this. And this small AVM, if you notice the draining vein draining anteriorly, in 18 months, this AVM was gone. So micro AVMs is a very interesting entity in which there are several studies which have shown why it's very easy to miss these micro AVMs, and a cone beam CT angiography, basically what vaso-CT is very useful for making sure that we are not missing these very, very small AVMs. Now, a couple of post-embo examples. So we'll come actually back to the same example. This is a left frontal unruptured AVM, post-embolization. This was biggish in volume. So a partial embolization helped us to reduce the volume. So again, the same vaso-CT which I showed earlier, in which you will see that there is a clear embolized part laterally, and there is a medial and posterior patent part which we contoured, and we created a radiosurgery plan. So that's the contour. And that's a very, very selective contour which excludes the embolization material. This is our CyberKnife plan. So this was a 7.9 cc AVM. The V12 is 4 cc, and we were able to deliver 16 grays in a single session. This patient was on the couch for 48 minutes. And this is 37 months post CyberKnife. So in the top image, you can see the embolization material and the AVM. And in the bottom two images, you see only the embolization material. Another case, medial parietal AVM, rather small. So in fact, for these small AVMs, it's actually not good to embolize them. And I think it increases the complexity of doing radiosurgery. And at such a volume, actually, prior embolization is not necessary. But we do get these kind of patients all the time who come to you post-embolization of a small AVM, which I think is not a good practice. And the same patient, after 2 years, showing complete obliteration. Now, obliteration rate is something which can very easily be predicted using this very simple calculation. This is from the Toronto group. And if you just divide the margin dose with the AVM diameter in centimeters, you will get a value which you can then see what kind of obliteration rate it gives you at 3 years. So this is something which is very useful for counseling a patient in the clinic. And in fact, upfront, even before delivering radiation, you can have a dialogue and kind of convey what kind of obliteration rate you are looking at. So interestingly, even for judging obliteration, arterial spin labeling is coming in a big way, and there is a possibility that in the future, you may not need to do a digital subtraction angiography to document that the AVM is completely gone. But of course, till such time that it is proven, we do continue to use DSA at 3 years post-radiosurgery as the gold standard modality. Now, in several complicated AVMs, we may need multi-session embolization, and finally, we have a small volume left which can easily be given radiosurgery. So this is one example of a multidisciplinary treatment. Ideal case for AVM radiosurgery. So I would say if I was to wish to get an ideal case for AVM radiosurgery, it would obviously be an unruptured case, compact nidus, 2 centimeters in diameter, volume of less than 5 cc's, location lobar, low or moderate flow, no fistula or aneurysm or venous hypertension, and actually the angio architecture, barring these 2-3 attributes, does not matter. So for the endovascular neurosurgeon, what actually creates a problem for them are the end passage feeders, which are supplying the normal brain. But for radiosurgery, these do not create any problem. Now, once you give radiosurgery and you have a case in which the AVM was located close to the midline, and this is of course very similar to treating a parasagittal meningioma, you can have patients who develop edema anywhere between 6 to 18 months. So usually in about a third of them you will see these, and about a third of them only are symptomatic. Usually they respond very well to steroid, and in fact, in patients who develop this very early, it can be a harbinger of a quicker obliteration. So this is something, if you see very early and the patient is not symptomatic, actually it's a good finding. It tells you that the AVM will go away quicker. Now, this is from the UPMC group, published in 2008, in which you see this very nice elaboration of what the AVM radiosurgery complications basically depend on. And they basically depend on the dose, on the volume, and on the location. So these are the three variables which you have to look at very carefully if you don't want to land up into the problem. Now, there are these diffuse AVMs which we should learn to recognize on the MRI. So these are what is variably called as a diffuse or a dysplastic AVM or proliferative angiopathy. And the key feature is, even in between the vascular flow voids, you will find normal brain tissue. So if you see an AVM like this, my advice would be to stay away. If you look at the DSA, this is a very large volume AVM if you look on the DSA. But once you look at the MRI, it becomes very clear that these are the patients you should not be treating because you will land up into complications. And most of these patients do not have many symptoms. So that is all the more reason why we should steer clear of getting into these kind of patients. So we've had the CyberKnife for more than 6 years now, and this particular protocol I've been using for 5 years. So we've done 86 cases on this, of which 12 have been deep AVMs. We haven't had a single adverse reaction so far, and we've had 3 bleeds, 6 months, 6 months, and 8 months following radiosurgery, of which 2 were in the deep AVM group. So the check angiography is starting to happen. 32 cases have completed 3 years, and of the 32 cases, we've done check DSA for 16 cases, of which we have a complete obliteration in 70%, which is 11 cases, which is quite a healthy figure. Partial obliteration in 3, and no change in 2. So more or less, I would say very, very similar to what we expect. And hopefully in another year or two, we'll have much more numbers and systematic data to comment. So to summarize, I would like to say that radiosurgery is an important method, and it's likely to become even more important. The important thing to realize is that the natural history is very heterogeneous, and that combined with contouring, which is not so easy, makes it one of the difficult indications to treat well using radiosurgery. A very, very selective and sensitive vascular imaging is what I would say is very, very imperative for accurate contouring. And at least in our hands, using a high definition 3D rotational angiography helps us to do high quality contouring, which is very important for complex AVMs, for micro AVMs, for post-embolization cases. And of course, as you've heard in the previous talks, attention to key variables like the dose, the planning, conformality is very, very important to have a good outcome. Thank you.
Thank you, Dr. Aditya. Excellent talk. Srinivas has a question. Srinivas and then Shankar.
Very impressive talk, Dr. Gupta. I've learned a lot. The one question I have is the vaso-CT, you mentioned. On one hand, you're saying vaso-CT is very good for delineation, but on the other hand, you're saying post-SRS, for the response evaluation, you need a DSA. Why is that?
So what I'm basically saying is, what I mean when I say that we do a DSA is basically a DSA would include a vaso-CT. So what we do is a biplane DSA, and at the end of it, we do a rotation, and that is how we create this 3D rotational angiography. So 3D RA is a part of a biplane DSA diagnostic procedure. It's not separate from it. Yes, so actually if you just acquire planar APN lateral or oblique DSA images, you don't have any way of putting it into the CyberKnife system.
Third dimension.
So vaso-CT is what actually allows you to work directly on the angio images.
It's a CBCT, Srini.
Yeah.
CBCT on the biplane cath lab.
No, so certain Linac-based systems, I think, have a way to import the DSA and contour on the DSA, which may not be possible here. Is that?
No, DSA planar images in general cannot be contoured.
So we have done that.
Contoured because they are planar images.
But all your Eclipse planning systems and all, they allow you to import and contour on that.
Kausi, it doesn't allow. We have done all the homework.
Not to my knowledge.
Even the Proton system also doesn't allow, planning system, registration also cannot import the DXA images.
No. Agreed, but but it has a way.
Format is different. Yeah.
It can be used.
So
3D
this is
DSA can be
3D
used, and you can contour and
So,
you can
so
see the
just
congruence.
let's ignore that. Let us get to the other question. When you are using the DynaCT, you are, in few of the cases you mentioned, you have embolized them, right? So didn't you get the artifact there? Because in the patients which I was doing, I was having trouble, including the interventional vascular neurosurgeon.
Yeah.
He was not sure about the nidus delineation.
So you're absolutely right. If you have a very, very dense blob of embolization material, that can create some scatter, that can create an X-ray scatter. So just behind that, there is possibly you could miss a part of the AVM. So that is why I never only rely on the Dyna or the vaso-CT.
TOF and T2
I will
also.
always combine it with the
Correlate
MRI
with
base
MRI.
images and the MRI.
Fair enough.
Yeah.
And the second one is, if we are planning to, a majority of the cases that you have selected, it was single fraction, right? So
All
where-
are single fraction.
Yeah, so
Each
do
one
you,
of them is single
if you are getting a large volume, AVM, do you consider doing dose stage radiosurgery?
So
or probably volume stage?
No, so I work with a very skilled interventionist, and our protocol is a large volume AVM. We reduce the volume and then give single session radiosurgery. So that has been our protocol. It may need more than one session of embolization, but that's what we largely follow. Having said that, I have done recently 4 cases with a dose staged radiosurgery. Not volume stage, but dose stage radiosurgery.
So Dr. Jalali has, one second. Dr. Jalali had a question, him, then you can ask, and then Amit Jain.
No, actually, I wanted to ask the same, because we have been talking about large AVM data. I wondered if you had, but you didn't have any experience in your previous Gamma Knife Center too?
So we did volume staging as well, but honestly, the long-term data, as you know, that is one big problem with working at AIMS is long-term data is very hard to come by. I don't know if Manmohan has some of that volume staged AVM data. Maybe we can ask him if he's aware of some of that data. But we did basically volume staging. We did not do dose staging, at least till the time I was there.
And as you said, post-embolization, although you said you do, but it's quite a challenge sometimes to delineate, even with the interventional radiologist who has actually done the embolization.
Yes, that's
even
what I
even
follow.
that person also
That's
struggles.
what I follow. So
But
it's a to and fro. So he will ask me, this could be it, can you contour it? Then given the location and the volume, I'll say, well, yes, I agree, let's include this little bit also. You know, so it's a to and fro kind of
What we used to do actually was we used to take another interventional radiologist opinion as an independent, as a check, because as you said rightly, the delineation is the
Right.
most
So,
important.
well, I've been working with this colleague of mine for past 25 years. And I have a, we know what we are talking about.
I just wanted one final comment. Was very, very exciting what you told us about ASL, because ASL we have been using for the last 8-9 years now.
Right.
And it is amazing in gliomas, as you know, we use it routinely. And it doesn't need contrast, and it actually shows the cerebral blood flow as compared to the classic DSC perfusion, which is, or even the APT, which shows the cerebral blood volume. So I was still thinking in my head how the cerebral blood flow would correspond with the nidus. I mean, we have to, I think, delve deep into it.
Oh, absolutely.
Yeah, yeah.
But the exciting data about ASL, no doubt.
Yeah.
Sure.
Yes,
So
so
I
you
think-
can, no, no,
I
he,
think
I,
for
I think he's
post-emboli-
waiting for a question there.
Post-embolization also we can use the MRTOF images, which are more helpful. So one question is that you have mentioned some of the like not exactly contraindication, but you do not like if the AVM with aneurysms. So what is your
So,
opinion related
see-
to small AVM with internodal aneurysms?
Right. So you see, if it's a flow-related aneurysm, slightly away from the AVM, I'm not bothered about it because I know once the AVM is gone, even that will disappear. But what I'm bothered is if there is an intra or a perineidal aneurysm which has ruptured. So if I'm treating AVM which has bled, and you can identify an intra or perineidal aneurysm which may possibly have bled, then I'm not very comfortable treating this patient upfront with radiosurgery because I know I will need 3 years to take off the AVM.
But sir, it is extremely difficult. One small AVM which has bled, even the good neuroradiologist, they're not sure whether the AVM is bled or the aneurysm has bled.
So if it has
That
bled,
is the question.
and if we don't find an aneurysm which we think is a culprit in that, we would go ahead with radiosurgery only if there is no other method to deal with it. Like I showed you the thalamic AVM case. It had bled, and there was no endovascular solution, there was no surgical solution.
Okay, so it is not an absolute indication for embolization.
It's not a contraindication.
Because we have also seen many cases, internodal aneurysm usually disappears.
Yes, agreed. Unless it has bled. You can say that, oh, this is the one which has bled, which as you know is very tricky to say. But in those cases, and especially if the AVM is on the bigger side, we may hedge by partly embolizing it and then going for radiosurgery.
Dr. Amit.
Yeah, very wonderful talk. I have two questions actually. One is like, how do you select patients for radiosurgery rather than embolization, except as you said in patients with diffuse AVM large and who have bled recently. So any other indication?
That's you know, that is a subject of probably not one but several talks. How to select a AVM for radiosurgery? I'll give you a short response. You can make a very simple 2x2 table: ruptured, unruptured, small, big. So your small unruptured AVMs would be excellent indications for radiosurgery unless they are on the surface, in which case they would be very good for surgery as well. So ruptured, unruptured, big, small, superficial, deep. So if you can have this classification in your mind, this is a very good, very quick clinical way to choose what are the options available in a given instance. Now, having said that, the challenge that we face is a patient with an AVM on the surface. Both me and my endovascular colleague will counsel 3 times that you should have surgery. The patient will say, I don't want surgery. You know, that is one challenge. On the other hand, the challenge is AVM which has bled in some of the locations which are deep, and there is no endovascular solution, there is no surgical solution. That is the other challenge. So historically, one of the problems with AVM radiosurgery has been, on one hand, it has been shot at, that you take 3 years and you don't excise and it's not a cure. And on the other hand, it's become like a dustbin. You can't treat it with something, do radiosurgery. You know, so there have been these 2 aspects historically of AVM radiosurgery. So given these 3 criteria, I think you should be able to largely select what kind of treatment you will offer. And obviously you have to see what expertise exists at your institution. So for me, I do surgery and the radiosurgery part, and my colleague does the endovascular part. So we can cover all the 3 solutions.
Okay. So have you had experience?
Last question for this session.
Have you had experience of treating cavernous hemangiomas or cavernous malformations? Also?
Cavernous malformations, you mean cavernous hemangiomas of the cavernous sinus? Yes.
No, not of cavernous sinus.
So cavernomas, I have generally stayed away except for the deep cavernomas. I have not yet got into the superficial cavernomas, but yes, as Manjul said, there is exciting literature about the efficacy. Maybe we will slowly, but you see superficial cavernoma, why not remove it?
This is the last quick question.
I have a few comments on this discussion. I think very nice presentation. But personally, in 25 years we have been using in women's, we have interventionists, but we have never sent the patient for embolization. Many patients come embolize outside. So the same problem comes with artifacts. So we simply include the embolus also in the lines, maybe slightly larger volume, and may not have helped us to reduce the volume, but it is better to cover maybe slightly more than doing slightly less. So all the embolized portions we cover. Most of the embolization sometimes comes at the center of the nidus. So even if you want to avoid it, we can't avoid, because embolus is in the middle of our nidus. So it is better if we look at the early draining vein and try to reconstruct a nidus. It takes time to have multiple imaging, MR angio, CT angio, you try to fuse everything. And then you will be able to make a good delineation over years with experience.
I think I agree with what Mahip is saying. You see, very frequently we come across embolization which has not been done properly. So couple of things is, if somebody is just putting some glue into the feeding vessel, they don't even reach the nidus. That is, in fact not good practice. Second is, if you're doing a salt and pepper kind of embolization, that is again very detrimental, because you have to contour the whole thing, which Mahip is suggesting. You have any ways to contour the whole thing, and if you have to contour the whole thing, then why get embolization done in the first place? So our approach is always a tailored sectoral embolization.
In the earlier embolization, when onyx was not there, then there was problem of recanalization.
Yeah.
So still, at that time, we used to cover all embolus, so that their chances of recanalization may be reduced.
I agree. I
mean, Dr. Jalali's point, we have tried quite a few volume stage with Anand Balasubramaniam and Manish Srivastava. We had a very good team in my previous institute, around 7 to 8 cases and very mixed responses in volume stage. 3 to 4 cases did very well, 3-4 cases did very badly. Thank you, Dr. Aditya.
Thank you.
Thank you.
Thank you.
So now we move on to brain metastasis, radiosurgery in brain metastasis. So next speaker is Dr. Rupesh Kotecha, who is the Chief of Radiosurgery, Department of Radiation Oncology at Miami Cancer Institute, USA. Over to you.
Okay, well, thank you to the organizers for having me here today. And I'll apologize in advance because there are a lot of slides. I asked Dr. Datta what I should cover as an update with regards to brain mets, since it's a huge topic, and he said everything. So we'll try and cover as much as we can very quickly here. So this is really an update of brain mets, essentially from initial diagnosis into how we manage patients and their follow-up. These are my disclosures. Let's see if this is running. Okay, great. So at our cancer center in Miami, we have a variety of technologies, and actually on the last day, we'll talk about the advantages and some of the limitations amongst all the different technologies that we have. We're actually upgrading the Icon to an Esprit as of today. I'll get the report from physics. And then we're also installing the ZapX as well, so next week. So we have basically 5 different machines that you can treat a patient with stereotactic radiosurgery. Now, we'll talk about this again on the last day, but there are a lot of comparisons between the dedicated radiosurgery platforms and essentially the efficiency index, which is a combination of the conformality, the gradient, and then the mean dose to the target is actually the highest for Gamma Knife, and specifically with multiple METs is actually the lowest for HyperArc. We've also talked about the planning time for GK, and it's significantly shorter than some of the other technologies, but then again, the treatment time is going to be shorter with, for example, HyperArc than with Gamma Knife. So there's some advantages and disadvantages to each of the machines, but I won't get into these debates now, seeing as how controversial that is here. Now, with regards to radiosurgery, this has actually been the greatest growth that we've seen with the management of patients who have brain tumors over the last 10 years, as you can see in this top part of the bar graph. It's actually the most commonly performed procedure now for patients who have cancer in the brain. And specifically, for example, McDermott, who works in our department now, came from UCSF. He said the most commonly performed procedure in the Department of Neurosurgery was actually a radiosurgery treatment. And specifically, when we were thinking about indications for radiosurgery, we talked about yesterday, brain mets is the substantial indication basically in most centers in the United States. You can see it makes up about 85% of that pie chart. Now, when a brain mets patient comes into the clinic, there's a lot of things that they help generate volume for in the cancer center itself. For example, the MRI scans, the growth in radiology, the extracranial disease needing management, which requires referrals to medical oncology, physical medicine, rehab, the palliative medicine team, the nutritional team, and also as those brain mets come into the department, at least from a radiation oncology perspective, they increase the machine growth for radiosurgery, which is why we have so many of these machines, also increases neurosurgery program growth in the neuro-oncology programs itself. So I think a brain mets patient is very key to building a cancer center. We're thinking about updates in brain mets. I think the easiest way to think about this is the workflow of radiosurgery, and we'll break down each of these parts and then what advances we've seen in each of these sections. So first is just the treatment planning aspects itself. These are all the sequences that we use for patients who have brain mets treated at our center. You can see it's a pretty comprehensive set of imaging that includes both pre-contrast and post-contrast imaging, T1 and T2 sequences. Just focus on the very right-hand column, which is actually the use of a T1 post-contrast sequence, which is specifically known as a space sequence. It has a little bit higher of a T1 resolution. We'll talk about what those imaging shows. So historically at our center, essentially all patients had an MP-RAGE at diagnosis. A neuroradiologist would evaluate the number of lesions, and then they would get a treatment planning MP-RAGE sequence. Then a neuroradiologist would again recount all of the lesions, and then we'd also have a multidisciplinary team. So a neurosurgeon and a radiation oncologist would triple check the count, and then the patient would receive radiosurgery. Then on the bottom cohort is actually what we changed to about 3 years ago. So patients had that first MP-RAGE, and at the time of treatment planning, we'd actually get an MP-RAGE and a space sequence, so a dual sequence approach. Neuroradiologists would count the number of lesions on both scans, and then as this would be triple checked with a radiation oncologist and a neurosurgeon. And essentially this allows us to pick up very small brain metastases that were not detected back on the MP-RAGE sequence alone. As you can see here, one lesion set on the left-hand side. And the right-hand side, there's actually a lesion in the left parietal lobe, and the patient came for radiosurgery for that single brain metastasis, and there's a second lesion that we were able to pick up on the space sequence that would have been missed on the MP-RAGE alone. The use of the dual sequences have increased our detection of brain metastasis, as you can see here on the left-hand side. Both the increase is about 15%, and then the triple check, having 3 physicians evaluate all the images, gives you another 5%. And this is also translated to a benefit to our patients in that it reduces the risk of distant intracranial failure, or their time to next gamma knife went from about 3 months to almost about 12 months in our patients with the use of the dual sequence approach. The second thing about treatment planning is not just the sequences themselves, but what is the timing between planning and radiosurgery treatment. So these are images for a patient undergoing radiosurgery treatment, and you can see their MRI scan on a diagnostic scan versus the treatment planning scan just done 7 days later. So if it takes 7 days to make a radiosurgery plan, you're going to be substantially underdosing the target. This can happen because of tumor volume enlargement between the images, as you can see here. And you can kind of account for that by increasing the margin of what you plan, but not always is that going to be a growth that's circumferential, and it could be just a growth in one direction. But what it doesn't account for is potential tumor dynamic changes. So you can have changes in the shape of the lesion, and then also this can result in displacement of the centroid of the target between what you initially would have planned with. So we've been doing the diagnostic and the treatment planning scans, and we went back and actually looked at every single contour for every patient and recontoured them both on the diagnostic and the treatment planning sequence. And essentially to account for all of those changes, you would need essentially a 3 millimeter margin, even with a treatment planning scan, to account for 95% or more of the actual targets themselves. And this is actually driven not only to tumor volume changes, but also to directional displacements, as you can see here on this right-hand side. Essentially, even if you use a 1 millimeter margin, which is what a lot of facilities in the United States do for the treatment planning time, essentially every day between your MRI and your actual treatment increases the margin that your tumor volume is going to be outside of that zone by 5%. So it's 5% per day is going to be outside of a millimeter. Moving on to immobilization. So we have different forms of immobilization. We've talked about a little bit the frame and the mask treatment. At our facility, we have specific guidelines as to when patients are treated in a frame and when patients are treated in a mask. So if I just graph, for example, our volumes, you'll see that the percentage will vary based on the caseload for that month. And so month by month, overall, there's about 50% of our patients being treated in a mask and about 50% of patients being treated in a frame. This question got brought up earlier about when you use a mask, do you have to add additional margins? One of the things is that in addition to having the robust IFFM monitoring, you have to choose your patients and select them for a mass-based setup. And typically we use this for tumors that are more than 4 millimeters in maximum dimension, treatment times that are going to be less than 45 minutes in total time, and for patients who can tolerate the IFFM with a interfraction difference or intrafraction difference of less than 1 millimeter. And so therefore, these are patients treated in a frame versus patients treated in a mask without any additional margin. And you can see the 1 year freedom from failure is essentially the same, over 90%. Now, for large brain metastasis, this came up in the session yesterday, what option is the best? And essentially you have two options. You have staged radiosurgery and you have fractionated radiation therapy. And so we have indications at our facility as to why we choose one versus another. As we talked about yesterday with brainstem metastasis, typically we don't offer staged radiosurgery given that there's really a lack of long-term data for those patients and you don't know the dose constraints for the brainstem with staged radiosurgery. And then for fractionated radiation, we typically use those for when patients have very few number of lesions in total, or if all the lesions are more than 5 millimeters in maximum dimension. So these are kind of our indications for one or two. With regards to the simulation process itself, this is actually not brain mets related, but related to the last talk. The tradition, especially in the Gamma Knife world, is to do the DSA or the angiogram and fuse it with your images, with your MRI scan for planning and with your CT or CBCT. And with the Gamma Knife system, because you have a stereotactic frame on the patient at the time that they're having the angiogram, you can fuse all of the images. Not always possible in other LINAC-based workflows. But just like ASL was brought up, we're also doing research into a different form of imaging, which is actually using an MRA and then what's called a package, which is vessel tree mapping. And then you can actually identify and contour the nidus. And actually, in our early experience, as you can see here, it's actually even better than the angiogram, or our volumes are better defined. So potentially this could be a way that you could use for LINAC-based radiosurgery or even skip the angiogram at the time of frame placement. With regards to radiosurgery dosing, these are our guidelines, at least at our cancer center, for how we treat intact brain metastasis. So we use the lesion diameter and then either offer a single session, a hypofractionated radiosurgery, or a multi-session or a staged approach. And you can see this is depending on the size itself, with dose reductions, specifically if it's close to the optic pathway or to the brainstem. Now, single fraction radiosurgery is a majority of what we do, and this is essentially based on limiting the risk of radiation necrosis on the historical RTOG 9005 trial. There have been 2 large data sets that have been published subsequently that really support the use of that high-dose radiation. So University of Toronto experience showed that the risk of local failure at 2 years was lower with a minimum dose of 21 gray. And then a second series that we had published at Cleveland Clinic of 3,000 lesions, and essentially 24 gray was better than anything less than 24 gray, even 23 or 22. The last is actually a series of a graduate here. So Sriniha is actually with us right now, and she's done this analysis now of 250 patients treated over 1,300 brain mets at our facility, and we've used 3 different dose levels. So we have 20 gray, we have 22 gray, and we have 24 gray. And this, although very small, on the right-hand side, is actually her figure. She's designing the presentation for Astro this year. And you'll see that 24 and 22 have a very similar risk of local failure, versus 20 gray does have a higher risk of local failure. So potentially, that's going to be the optimal dose that we will recommend. Now, there is poor local control with radiosurgery for large brain mets above that 2 centimeters. You can see the first 3 series are kind of the historical series in the United States for the earliest Gamma Knife centers, UCSF, Pittsburgh, and Cleveland Clinic. And especially when you get to more than 2 centimeters, that local control rate drops to be less than 60%, somewhere around 40 to 50%, and then also confirmed by the series from the Netherlands. And so we really don't offer single fraction radiosurgery for those patients. There are kind of 4 different options that we can use for these. The first is to do pre-op SRS followed by surgery. You can do staged radiosurgery, you can do fractionated radiosurgery, or you can do surgery and post-operative SRS. So these are the outcomes that we presented last year at SNO. And you can see essentially the best control rates in our experience have been with pre-op SRS and surgery. That's even with a median tumor size of about 3.6 centimeters. We have a 95% control rate. Now, we can offer hypofractionated radiosurgery. Typically, this is 3-fraction radiosurgery, except for the very large lesions, more than 4 centimeters, and then those we will give 30 gray and 5 fractions. This is a meta-analysis of the literature essentially for multifraction SRS for large brain metastasis, more than 2 centimeters. You can see the 1-year local control rate is about 80%. There is a randomized trial of what dose to use for large brain mets more than 3 centimeters. And in this trial, patients were randomized to 24:3 versus 27:3 versus 30:3. Essentially, 24:3 had a very high rate of local failure, or a low rate of control. 30:3 had a high risk of radiation necrosis at an early time point at 6 months. And so therefore, kind of that in-between dose of 27 gray and 3 fraction is thought to be the best. This is actually a randomized trial. So this is NRG BN13. This is the lucky number that I was given from CTEP last week. So this is a prospective clinical trial that will be run internationally. It will start in about 8 months from now. But for patients with intact brain metastases with tumors that are more than 1 centimeter or less than 3 centimeters of maximum dimension, they will be stratified according to the presence of symptomatic lesions, targeted therapy or immunotherapy, and the number of lesions. And they'll be randomized to single fraction radiosurgery or fractionated radiosurgery. And the primary endpoint is local failure. So we just got this approved from NCI, and we also got approved this to be an international trial. So looking for international partners. With regards to multi-session or staged radiosurgery, this has been significantly in vogue, I say, over the last 2 to 3 years as we've had more outcomes and basically the development of ICON systems across the world. This is used traditionally for lesions that were greater than 3 centimeters in size, but then moved to greater than 2 centimeters in size. Now there's a debate as potentially should this be used for even smaller lesions as well. If you look at the pooled data, I've just put a table here of the series on staged radiosurgery. This was initially developed in 3 fractions or 3 treatments, and then they went to 2 treatments, essentially because of insurance issues, and the separation time went from 2 weeks out to 4 weeks. And basically the local failure rates across the series is about 10 to 27%, although most of these are crude local control rates and are not actually time-dependent rates, and a lot of them haven't published 12-month local control rates or higher. At our facility, we're actually treating patients with staged radiosurgery, but also using amino acid PET scans to potentially develop a biomarker for response to staged radiosurgery. So this is just an example of a staged radiosurgery case. This is a lesion that was more than 2 centimeters, had 15 gray, and then the stage 2, 4 weeks later, is another 15 gray, and then you can see with follow-up, and then eventually that will completely resolve. So this is data that we will be presenting at ASTRO this year. So this is patients, again, with the staged radiosurgery, and you can see their amino acid PET scan at the interim and with their follow-up scan. And what's most interesting with this data is that, similar to how you think about PET scans for extracranial SBRT, you can see that the response, which is the green line on the right-hand side, the response on the PET scan with regards to the SV max actually reduces faster than the tumor size itself, either with regards to volume or diameter. So potentially this PET scan can be used as a biomarker. Now, we got asked earlier today about preoperative radiosurgery, and we use a dose-escalated preoperative radiosurgery regimen at our facility, and potentially as to explains our control rates. But you can see here what we use for single session, which is the majority of cases, or potentially hypofractionated radiosurgery. Not commonly done. It's really dependent on the OR schedule as to when we would use a hypofractionated approach. This is a summary of the literature for preoperative SRS for patients who had operable brain metastases. One thing I would point out is if you look at most of the series, the first kind of 5 rows here, you can see the dose in the preoperative sense is typically lower, so about 15 to 16 gray. At our series, which is the second to last one, you can see the higher dose, about 18 gray on average, or the median dose, and you can see the risk of local failure at this initial analysis was very, very low, so less than 2%. I think that's what's really driving with pre-op SRS, the better control rates. And although with pre-op SRS, we've seen changes with regards to some of the tissue factors, this is an increased risk in necrosis. If you compare the patient's primary tumor versus the pre-op SRS and resected sample, you don't see that this really is affected by time. So the risk of necrosis is the same as long as you treat the patient after 24 hours. So essentially, we would like to treat the patient not same day, but at least the next day afterwards to get some effect from the radiation if you're going to do pre-op SRS. Now, post-op SRS is also done in our facility, And the way that we dose it is actually based on cavity volume. So we don't use tumor size like we do in the intact or in the preoperative setting. And essentially, we use 3 fractions for the majority of patients. Very small cavities may get single fraction, but those really are rare to see. And then the risk of radiation necrosis obviously goes up with increasing cavity volume, and therefore we will change potentially to 5 fraction. Now, if you look at, with regards to post-op single fraction versus post-op fractionated radiation, there's probably a benefit to this. So your control rate goes up from about 60 to 65% to about 85%. This is the trial being run in the United States. So A071801 is a randomized trial of single fraction radiosurgery versus fractionated radiosurgery in the post-operative setting. This trial finished its accrual, so we will hopefully in about 6 months or so start to have some data report out from this study to see what's the optimal fractionation schedule in the post-operative setting. Let's talk about treatment planning a little bit. So how many brain mets should we treat? You know, the clinical data has historically been on 1 to 3 or 1 to 4 brain metastasis. And then in ASTRO in 2020, we had the data released from the MD Anderson randomized control trial of 4 to 15 brain metastasis. And that showed essentially the similar survival, but less neurocognitive deterioration with radiosurgery. And so although majority of facilities were actually using 8 to 10, potentially up to 15 lesions already, that helped kind of cement the practice, at least in the United States. There's still a randomized control trial being run out of Canada for 5 to 15 brain metastasis, which is comparing radiosurgery versus hippocampal avoidance whole brain radiation therapy. That trial is very slowly accruing, and it kind of gets harder and harder with time. So we have no idea if that will be a 2020 something release or if it'll be 2030 before we have results from that type of study. Now, for patients who receive radiosurgery in the upfront setting and then have a distant intracranial failure, you can salvage them with stereotactic radiosurgery and still preserve a patient's quality of life and their performance status. So this is a series I had put together of very heavily treated patients at our facility. So 59 patients who had 765 brain mets treated with radiosurgery. So if you think of this, these patients have had at least 3 courses and up to 8 courses of Gamma Knife. And these are patient-reported quality of life metrics. And if you divide them out into the red line, which is the patients who had only 3 or 4 courses of Gamma Knife, their quality of life was the same as if they had more than 4 courses of Gamma Knife. So this is one of the reasons why we really are strongly in favor of radiosurgery for brain mets for our patients. Now, if you look at what the machines can offer kind of in modern practice, this is, for example, a whole brain radiation therapy plan compared to what you can offer with Gamma Knife radiosurgery. So we talked about this a little bit in yesterday's session. If you have lesions that are less than 5 millimeters on the Gamma Knife Icon or Esprit, as they have the same treatment planning capabilities, you can treat 177 lesions and still give the brain less dose than you would with conventional whole brain. Now, again, in the United States, I wouldn't recommend doing that. We don't treat that many lesions, but this is what allows us to get up to 60, 70, 80 lesions, because the whole brain dose is still going to be about 5 gray or so. Now, not to get back into this comparison amongst the technologies themselves, but we did the same exercise with Gamma Knife as we did with CyberKnife, and you can start doing this across each of the machines. And essentially with Gamma Knife, as I mentioned, you can treat 177 lesions, but with the CyberKnife system, you can only treat 135 lesions and still give the brain a less dose with whole brain. So again, if you're getting up to that many lesions, maybe you can choose a technology, but other than that, I think you'll be fine between the two. One thing we heard about earlier in the session today is the introduction of Lightning, which is a fast inverse planning optimizer. And that's really allowed us to speed the time of the planning process itself. So you can see a clinical plan for a vestibular schwannoma for a patient that we treated, and that's probably one of the lowest PCIs that we would accept for a vestibular schwannoma, but it's an odd tumor volume or shape. And you can see with the Lightning plan, we'll give you conformality that's about 0.79. In our experience, it gives you a clinically acceptable plan in about 97% of cases, but you can see here that target coverage adjustment, so about 52% of the time, we still have to tweak the plan after the Lightning plan. So you got to see the video earlier today, and it gets you a great plan in 30 seconds, but we are still tweaking that plan about half the time. Another thing that you saw earlier today is you can change the optimization parameters in the system itself. So I went back to the physics team and we asked, well, what's the equation that's used? So this is the equation that goes into the yeah, it's very simple from a physicist stand. So then I said, well, how many different variables could you potentially change into what you would input? The answer is 121 different variables. So then lesion by lesion, I had the physics team replan each case 121 times. And essentially, at some point, if you're looking at the conformality, which is the yellow dots, you get to this conformality that basically is going to be about 0.88, which is the threshold that we used at our facility, about 0.87, 0.88. And so at some point, you're really not going to get much more out of it. So that's kind of the threshold that we use. So we developed, these are the optimization parameters to use. And these actually are different for every size brain met. So less than 5 millimeters, 5 to 10, 10 to 15, and then 15 to 20. So if you look at this paper that we published just recently, it'll tell you kind of what would be the optimal input settings to get the best plan out. Also, what was covered earlier is, planar variability with Gamma Knife was very variable in the forward plan setting, but now with things like Lightning, your planar variability can be significantly reduced. So what I did is I had a senior planner compared to a junior planner compared to somebody who just started Gamma Knife, so they'd only gone through training in the school and never actually planned a Gamma Knife case themselves. So we have 3 different types of planners, and we gave them 3 different types of cases: a postoperative case, an intact case, and then a vestibular schwannoma, a more complicated tumor. You see the definitions that we used for senior, junior, and novice. And you can see initially these plans all over the place could be very variable, but the key thing here is that when you start to use the Lightning, the planning time is shorter for everybody, and the variability then gets significantly reduced. And essentially the junior planner gets you a clinically acceptable plan, and a novice planner can actually get you a clinically acceptable plan. A senior planner actually still does tweaking after the fact, and so at that point, I think the senior planner is still winning, but at least it gets your junior planner. I think it's really important for facilities that are brand new, that install a Gamma Knife and that don't have anybody with any experience, then your physicist can get you a clinically acceptable plan very quickly, and that was a concern previously. Let's go to the treatment standpoint. So, at least at our facility, we've coordinated a lot between neurosurgery and radiation oncology for our radiosurgery cases. And this is a debate. At a lot of facilities, they're either neurosurgery only driven, and other facilities, it's only radiation oncologists, and they don't want neurosurgeons around the Gamma Knife at all. At our facility, essentially about 44% of the time you had radiation oncology and neurosurgery input when I started. And then we revised all of the model, got the neurosurgeons on board, got radiation oncologists on board, and it was 78% of cases had their involvement. And then essentially for the past 3.5 years, we've had 99% of our cases have both radiation oncologist and neurosurgery input and plan the cases. The last thing I want to talk about is just clinical trials for brain metastasis. So as many of you know, I work with Manesh Mehta, and he's been a pioneer really in clinical trials for brain metastasis. But what I tell him all the time is that when he was designing studies for brain mets, they were very simple and straightforward, right? You just randomize between 30 and 10 over 2 weeks and over 3 weeks, 40 over 3 weeks, 40 over 4 weeks. And then whichever is the winning arm, then you do a second study and continuously randomize patients. So that was the era that he designed clinical trials in. But in our era, we have a lot of other competing technologies as well. So for example, this is the METIS trial. This is a randomized trial of radiosurgery with or without tumor treating fields for non-small cell lung cancer brain mets. So now you're competing with a technology that's not even in the medical oncology space or even the radiation oncology space, but a kind of a fourth space. That trial has finished its accrual, and so next year in 2024, we'll actually have the results from that study. The second is on the right-hand side, something that we've talked about in previous conferences is now there are targeted therapies that have better intracranial penetration. And so the question is, how do you time and sequence those therapies with radiosurgery? And so this is a phase 1 trial that we had run combining osimertinib with stereotactic radiosurgery for patients who had EGFR mutated non-small cell lung cancer brain metastasis. We also have to think about corticosteroids for treatment. So traditionally, all patients who received radiosurgery, they got Decadron the morning of their radiosurgery treatment. Essentially, as the frame is being placed, we're giving Decadron, and then they would get a corticosteroid taper afterwards. But about 50% of patients with brain mets in the United States now receive immune checkpoint inhibitor therapy as part of their systemic therapy. And we have data from MSK and from the Gustave Roussy that showed that if you're giving corticosteroids more than your basal levels, so more than 10 milligrams of prednisone equivalent, you have poor outcomes if patients are receiving anti-PD-1 or PD-L1 therapy. And then this is actually a series that I had published back in Cleveland, that if we looked at our patients who were receiving immune checkpoint inhibitor and radiosurgery, and they had corticosteroids, they had not only poor local control, but they actually had poor overall survival. That's an overall survival curve there. And so it's very concerning those patients to really not give corticosteroids if they're not necessary. We're doing this clinical trial actually that will open on Monday when I return to substitute the corticosteroids. using a different type of agent. So this is a RAGE inhibitor, which is, there's a very nice Nature paper out for those of you who will read it. It's, this is actually the new radiation resistance pathway that explains basically outcomes after whole brain radiation therapy or radiosurgery in brain mets. Very nice science from Spain showing that this parameter is the single unique feature that is associated with determining radiation resistance in brain metastasis. There happens to be a drug that works against that pathway, and so essentially not only does that drug work against radiation resistance, but also protects against neuroinflammation, and potentially in preclinical models can help with neurocognitive function. So 3 different aspects. So this is a trial that we are doing in which we're giving the RAGE inhibitor prior to radiosurgery, then giving radiosurgery, withholding all steroids, and then looking at the response to treatment as well. So potentially this could be a one agent to protect neurocognitive function, to act as a protecting against neuroinflammation and radiation necrosis risk, but also against radiation resistance. Finally, when we're thinking about treatment or the after effects of radiation therapy, obviously radiation necrosis is what comes to mind. This is the chief dose-limiting toxicity of radiosurgery, and this is frequently seen in our population and really a headache for our neuro-oncologists. 1/3 of brain mets that are treated with radiosurgery increase in size at some point during that follow-up imaging, and more than 1/2 of patients are told at some point that one of their treated lesions has increased in size. So it's very, very common that we see these fluctuations afterwards. And this may worsen neurologic deficits of the patient, increasing the frequency and cost of imaging, and potentially necessitate treatment with steroids or other antiogenic agents. Essentially, the biggest factor, the risk for radiation necrosis, is tumor size. As you can see here, this is a large analysis that we had put together, about 6,000 lesions treated with radiosurgery. And essentially, as you increase tumor size, you increase the risk of radiation necrosis. So it's very straightforward. What's not straightforward is actually understanding or diagnosing radiation necrosis. So we can use structural MRI with short-term follow-up, a T1, T2 mismatch, dynamic contrast imaging, diffusion rate imaging, MR spectroscopy, or PET or INSPECT agents. And this is an algorithm that was developed at Cleveland Clinic before about how to diagnose radiation necrosis. So patient has radiosurgery, they have an enlarging lesion, then you do a short-term follow-up, it worsens, then you do advanced imaging, typically with a perfusion MRI scan or a FDG PET scan, and then you come up with a diagnosis. So walking through this is a patient who came to us for a second opinion, metastatic non-small cell lung cancer, had post-op SRS after resection for a brain met, had a recurrence, had another resection, had again post-op SRS, and then had symptomatic disease progression. You can see that lesion in the right parietal lobe here with increasing vasogenic edema, and it is hot on perfusion. So patient had radiosurgery, it enlarged, we did a short-term follow-up, it worsened, we did an MR perfusion, it was elevated, and therefore this is tumor progression, right? Patient undergoes surgery and it's radiation necrosis. There is no tumor progression. So despite us having these nice algorithms, sometimes they don't always work. It's an example here of a very small lesion, right? Treated with single fraction radiosurgery. You can see the FLAIR images afterwards, potentially tumor progression or radiation necrosis. We did the 3-panel of imaging, so MR perfusion is elevated, MR spectroscopy is elevated, but FDG PET is decreased. So what do you do if the imaging is not even concordant with itself? This patient actually underwent surgery and it's radiation necrosis, despite having 2 images that would be consistent with tumor progression. So what we've done is 2 sets of clinical trials. The first is using amino acid PET scans, followed by surgery to actually diagnose them, and a second is amino acid PET scans followed by clinical follow-up. First in 23 patients, the second one in 150 patients. And this is the data from the phase 2 trial that I presented at ASCO this year. Basically, all of these patients had amino acid PET scans and then had surgery. And we had full histopathology evaluated by 2 pathologists, and all of the radiology images were evaluated by 3 radiologists. Essentially, we came up with parameters, an SUV max of more than 4.8 or greater than parotid gland, and that gets you a good sensitivity and specificity, about 80%. And just to show you an example of these images here, 2 paired images for patients treated with radiosurgery for brain mets, both from breast cancer. And you can see one that's consistent with tumor progression, SUV max is 10, and a second which is radiation necrosis with an SUV max of only 2.4. So we are going to the FDA with this data, hopefully to get an approval. Finally, just as I'm finishing with neurocognitive function, I think it's really important to evaluate in our patients. This is something that's lost in patients who are treated in the clinic. So all of our patients are enrolled into our neurocog registry. And then finally, given how complicated the process is with radiosurgery, we're integrating AI into each of the aspects of both patient selection, management, and their treatment follow-up. So, thank you.
So that was an excellent and a quite comprehensive talk, Dr. Rupesh. In the interest of time, we'll be taking questions after both the sessions of brain metastasis. So now I invite Professor V.P. Singh, Senior Consultant Neurosurgeon at Medanta Hospital, Delhi, for management of brain metastasis in India. Thank you.
Right. Good afternoon. I would like to start by thanking ISRS and Dave for this opportunity. I've been asked to talk about management of brain metastasis in India. You know, when we compared our radiosurgery series, the number of brain metastases treated were only 3 to 4%, whereas any American series would have at least 50 to 60% thing. So it has come to India quite late, and part of it is, I think, awareness amongst both awareness and hesitation amongst both the neurosurgeons and the oncologists. So what changed about 10 years ago at Apollo, we had a very senior consultant, a very bright consultant who developed brain metastasis. And she was advised whole brain radiation. And she said, I'm not going to get my brain fried. Whatever life I have, I'm going to work in the end and do my work properly. And that's when we did her. Another consultant had the same problem. And we treated both of them 2 or 3 times with radiosurgery. And that's when, I think, at least in Apollo, the things changed and we came ahead. Now, this is a vast topic. There are many sort of aspects to it. And I think the best way is to try to show some cases and see how we do in different cases. And see what is the evidence for doing what we do. As somebody mentioned yesterday, you can find literature or articles supporting whatever you want to present. So that's not difficult. So what I've tried to use are only randomized trials or meta-analysis to try to give the things. So people are living longer with malignancy, the systemic therapies, targeted therapies. A large number of patients are surviving for a longer time. And this brain metastasis continues to pose a management challenge because they are very important for determining the morbidity and mortality in these patients. And what is most important is you have to preserve the quality of life of these patients. The commonest origin is lung, breast, renal, and melanomas. 25 to 30% are single, and 10 to 30% of patients present initially with brain metastasis as the first symptom. And approximately 15 to 20% of patients dying of cancer have brain metastasis. So the management depends on various things: the tumor factors, the number, location, size, histological type of metastasis, whether it's radiosensitive or radioresistant, the functional status of the patient, the control of the primary disease, and whether there are other systemic metastases. So for purposes of classification, we are talking about oligometastatic disease and polymetastatic disease. Amongst the oligometastatic, we can discuss the single lesions and the 2 to 4 lesions. And polymetastatic could be any number, but generally people talk about up to 10 and more than 10. So there are various radio-resistant tumors, but when you're giving a single fraction or a 3-fraction radiosurgery, the high dose overcomes the radio resistance barriers. So here really it doesn't matter very much whether the tumor histology is radio resistant or radio sensitive. The prognosis, we all know, the KPS score is important, age less than 65, absent or controlled primary site, and absent systemic disease, and that's the basis of the RPA classification. The outcome assessments, we talk about local brain control, distant brain control, control of the primary site, and extracranial metastasis control. So we talk about progression-free survival, overall survival, neurological outcomes, and most importantly, the quality of life indicators. With the targeted therapies nowadays, which having prolonged the life, it is seen that the genome sequencing may be different in the brain metastasis compared to other sites, and even with the primary. So it's important that whenever you do it, you have tissue from different sites. One should do the molecular studies in all of them. So what are the treatment options available? There are a number of things: whole brain radiation surgery, radiosurgery, the combination of surgery and whole brain radiation, or the combination of surgery and SRS, and the reverse also, as mentioned, the pre-op SRS followed by surgery, following radiosurgery with whole brain, or just doing sandwich radiosurgery subsequently. So the scenario one, if it's a single brain metastasis causing significant mass effect, patient is symptomatic, the first treatment is clear-cut. Surgery is the best option. You have to take the tumor out and you have to reduce the pressure so that the patient becomes better. The question is, if a complete excision has been done, should we give adjunctive radiation, and if so, which one to give? So is surgery alone good enough? We have good evidence to support that surgical excision alone is not a good option. The addition of whole brain radiation does help to improve the outcomes. So this is a study, a randomized trial comparing surgery with surgery and stereotactic radiosurgery. So observation post-operatively is not a good option, because if you look at the top graph, the local recurrence is much higher if you've not given SRS here. The overall outcome, survival, and the time to recurrence are similar, but local recurrence is much improved if you give an adjunctive radiation therapy. The scenario two is if you have a single metastasis in a good patient where the primary disease is controlled and a good performance score. So here, what do we do? Do we give whole brain radiation? Do we do microsurgery, or do we do SRS? Is whole brain radiation good enough? Here we've compared a meta-analysis of 6 studies comparing whole brain radiation versus surgery plus whole brain radiation, and the results are clear that surgical excision followed by whole brain radiation would give you a much better outcome than whole brain radiation alone. What about novel whole brain radiation protocols? They don't really affect the management at all. They don't change the outcome. So if you have to do the primary treatment, what should you do? Is surgery or radiosurgery should be the first choice in a small lesion in an intact patient with a good KPS. So the benefits of surgery are you get a definite histopathological diagnosis, you reduce the tumor burden significantly so that your adjunctive therapies can act better, but while you're doing the surgery, there is chances of dissemination due to handling. There could be distance spread. There could be meningeal seeding. So to counter these, people often try to take out these small metastases as a complete unit rather than doing it piecemeal. So you don't try to do an intratumoral decompression. You go around the tumor, the metastasis, and take it out. The advantages of radiosurgery are that it's non-invasive, so the immediate morbidity is low. And if it's a deep-seated lesion with significant surgical risks, and then obviously this is a much better option. But you're leaving tumor inside, and that could potentially be the source of later distant spread. So which of these should be the first choice? Now this is a study from 2020, a meta-analysis of 20 studies. Now, there are very few randomized trials in this. There are only about 2 randomized controlled trials. The others are only retrospective cohort trials, so the evidence is not absolute or very strong. This is 1,809 patients divided between radiosurgery and surgery. And we find that the local control, the distant control, and the overall survival is quite similar between the two. So we do not have a clear answer. Another study in 2021, a meta-analysis, again shows that the local control and the overall survival are similar. So we really don't have a clear-cut answer which should be the preferred option. There are some pointers which can help us. If we are not sure of the diagnosis, then surgery should definitely be the preferred thing. As mentioned before, if it's a large tumor with mass effect, patient is symptomatic, again surgery would be preferred. Cystic tumors, there is some doubt when they are going to respond to radiosurgery. So if it's a tumor with a small cyst, radiosurgery can still be done. But if it's a tumor with a large cyst, surgery should be preferable. Again, the location of the lesion. If it's on the surface in a non-eloquent area, then if there's a low surgical risk, then probably surgery should be preferable. And a relative thing may be whether the tumor is radio-resistant or not, although radiosurgery is usually good to take care of such lesions. On the other hand, if it's a deep-seated tumor in the thalamus, as you see on the first scan, obviously surgery is not a good option. One would go for radiosurgery. Or if the tumor is in an endocrine area, or if the patient is medically unfit. So once you've done the primary treatment, what should be the next modality? Should you give whole brain radiation upfront? Or should you just not follow it up, wait and watch? If new lesions develop, then you should do SRS. And should microsurgery be followed by SRS or whole brain radiosurgery? So this is the meta-analysis of 8, again, cohort studies comparing surgery plus SRS versus surgery with whole brain radiation to find out which would be a better modality of treatment. And here, comparing the two types of radiation, the radiosurgery had a lower risk of leukoencephalopathy but a higher risk of radiation necrosis, and the whole brain radiation was better to preventing distant recurrence and leptomeningeal disease. So another study in 2017 trying the same thing to see whether SRS or whole brain radiation should be the initial modality of treatment after the surgery. And again, the overall survival was similar. The cognitive deterioration was obviously worse with the whole brain radiation. The next question comes that whatever the initial therapy that you've given, whether you've done radiosurgery as a primary modality for these small lesions, or you have done surgery, should you give whole brain radiation or not? And there's a very definite evidence that the distant brain metastasis as well as the local recurrence was much less if you give whole brain radiation. Another study, of the effectiveness of adjunctive whole brain radiosurgery, a large number of cases, again came to the same conclusion that distant brain metastasis and the local recurrence were much reduced if you give whole brain radiation. So the evidence is quite clear. Addition of whole brain radiation after the primary modality, whatever it is, surgery or stereotactic radiosurgery, is beneficial in preventing distant recurrences in the brain as well as local recurrences. But again, the quality of life issues come in. So although we know it is useful, the incidence of leukoencephalopathy is quite high after whole brain radiation. And neurocognitive decline is very well established that this happens. So what about strategies like pharmacological use of memantine or hippocampal avoidance whole brain radiation? They do reduce the neurocognitive decline, but it is still not as what we would want, for safety purposes. So the other option is to do a sandwich therapy. So you do a primary modality, surgery or radiosurgery, do not give whole brain radiation, follow the patient up closely, and once they are sure to develop more lesions later on. And that is the stage when you should repeat the radiosurgery, as happens in the US. People go up, have 3, 4, 5 radiosurgery sessions as and when the new tumors come up. So the other thing we have to say is when we are doing repeated SRS,
for these new lesions as sandwich. What happens to the neurocognitive effects of those? So is SRS totally safe from neurocognitive decline? Not really. There is also some degree of cognitive worsening, but it is far, far less compared to the neurocognitive decline which occurs with whole brain radiation. And this is important because previously, because of lower life expectancy, people were not surviving long enough for the neurocognitive effects to be manifest. And now with improving results, we are finding that more and more people, the disease is controlled, but their quality of life is severely affected with neurocognitive defects. So this is what is the current recommendation, that sandwich SRS can be done. It should be repeated multiple times, and you have to counsel the patient. You have to counsel them that these tumors will keep coming, and you have to be ready for it. So psychologically, they should not get upset if another lesion appears. We expect that these lesions will appear, but we will repeatedly treat them as and when they are required. And this is the Hutton-Locker's criteria for the incidence of distant metastasis after SRS. Depends on the number of brain metastases initially, the extracranial metastasis, and the tumor type. So another criticism which people often ask is, because you're doing repeated SRS, are we doing the same accumulated doses as the whole brain radiation therapy? And as Rupesh also pointed out, you can go up to many sessions before the overall dose to the whole brain goes beyond the acceptable standards. So sandwich therapy in India is particularly difficult because of the cost factor and the availability factor. So although it's extensively used in the West, where they have repeat radiosurgery maybe every 4, 6 months, 8 months, as the new lesions show up, the costing becomes a major issue in India, and there is no easy solution to it. There is an AIMS model where they have started that, if you have radiosurgery once, then the second radiosurgery or third radiosurgery, as the new lesions come up, they don't charge them for it. So that is a very good option they have, but they can afford to do it being a government setup. And in the private sector, that's not such a practical option. Coming to the third scenario, the oligometastatic disease, where there are 2 to 4 metastases. If there is any lesion which is big and causing symptoms, surgical excision of that lesion should be done. And the treatment of the other lesions can be done when by SRS, provided the total volume is suitable. As we mentioned earlier, we avoid the whole brain radiation therapy because of the potential side effects, and a close follow-up is required, and as and when new lesions appear, they need to be managed. Scenario 4 is a polymetastatic disease, more than 4 metastases, and the management of these is determined by the number of metastases, the size of the metastasis, and most importantly, the total volume of the metastasis, the combined volume. If the total volume of all the metastases is under 10 cc, then SRS can be given to all the metastases irrespective of what numbers there are. But if the volume is high, then SRS may not be a good option, and whole brain radiation may be needed with hippocampus sparing. So this is a patient with 8 metastases, which we have treated with fractionated SRS, 5 fractions, 35 gray, to all the metastases. Another paper on the outcomes of 4 to 10 brain metastases, a prospective study, and they found that with SRS, you have a 1-year overall survival of 35%. Does the number of metastases matter? I mean, how do we come to the figure of 10? 10 is just an arbitrary number people have taken. So this is a study by Yamamoto. I think Rupesh also mentioned that. In this study, they've gone up to, they've compared the outcomes with the different number of metastases. And they found that the number of metastases, the more the metastases, the lesser the survival. But if you look at the non-brain death cases, where that is almost similar in all of them. So the death is occurring from the primary or the other metastatic sites, not from the brain. And that is important because it is the brain metastasis which really affect your quality of life and how you stay, how you perform afterwards. So at least in the even though they may die earlier, they are not having the symptoms and morbidity of an arm or leg weakness or being in coma. The scenario 6 is if there's a widespread and progressive systemic disease with the expected survival of 3 to 6 months. In such a situation, with, if there are a large number of mets, then I think palliative whole brain radiotherapy is probably the only thing. And there you should use hippocampus sparing techniques to try to reduce the neurocognitive effects as far as possible. Lastly, I come to a special situation, brainstem mets, where there's practically very little option. Surgery is not an option. And here, SRS is a good option because you can really spin the dose of radiation, which is spinning over to the rest of the normal brain. It's non-invasive, it has less morbidity, but we have to use lower doses. We can't go to 20 or 22 gray. And in this series by Lee, there were 28 patients who had a mean survival of 9 months, underwent radiosurgery, had edema only in one patient with a good tumor control rate. And this is one of our patients we treated with CyberKnife, and the pre and the post treatment. This is after about 6 months, you find a reduction in the size of the lesion. Now, this is another patient with a surface mets with a lot of edema. Normally, we would have preferred surgery, but the patient was medically unfit and did not want to take the risk at all. And therefore, we had to do radiosurgery. And even with that extensive edema, you can find that the lesion has reduced in size and the edema has improved. So these are the criteria. This is the algorithms from ASTRO 2022, a limited brain metastasis or an extensive brain metastasis. So I think each individual case you have to optimize, see the number of metastases, see the condition of the patient, see the extent of the disease elsewhere, and based on that, we have to take what is best for the patient, trying to preserve the quality of life of the patient. So thank you for your patience and a happy Onam to all.
Thank you, Dr. VP Singh. That was a very elaborate presentation. Excellent talk. The house is open for questions now, but we'll have limited number of questions as we are running short of time. No, I think we'll go one by one. After Billy Maga, sir, Amit can ask the next question.
The primary is well under control, and you have done the whole brain RT and for the metastasis, and metastasis in the brain only. What do you want to do now?
I think that's more of a, I mean, the radiation person would be more appropriate to answer that. But yes, I think a focused radiation may be possible. You know, it is possible to do a repeat, to do a SRS for that lesion, trying to, with the, that would be have the minimal spin over to the other areas. So SRS would still be possible after a whole brain.
So you're talking about the primary control, and there is limited metastasis in the brain,
After whole brain radiation.
Yeah, so that is a primary controlled true oligometastatic setting, and I think focal. Multiple metastasis.
So, if I understood you correctly, you're talking about a primary controlled. Whole brain radiation has already been given before,
and now you have multiple metastases.
Multiple brain mets. Yes. Right.
So then typically we salvage them with radiosurgery. If
Sorry?
it's typically, well, I mean, we salvage the patient with radiosurgery to the brain. If it's been less than 6 months, then we would reduce the dose, typically by 2 gray. And it has been more than 6 months, then we will give full dose radiosurgery afterwards.
Have you ever considered second time on whole brain RT?
Yeah, we've done a whole brain a second time. I will tell you, it's it's difficult for a patient to tolerate whole brain radiation therapy a second time. Essentially, we would give 20 gray in 10 fractions, sometimes 25 gray in 10 fractions if it's been a long time. The only settings that I've really done it in is patients with small cell lung cancer, because they have just widespread intracranial disease, has had whole brain or PCI the first time. And we would typically offer radiosurgery, but sometimes these patients have a number. Like I have a patient who had 70 lesions afterwards and never had recurrence in the body, so we gave whole brain again. But it's very rare to give.
So I also do radiosurgery, but if it is more than a year, year and a half, then we have two protocols. Either we do 13-12, which is kind of a, in the middle, and sometimes 25 in 10. And if possible, we avoid the hippocampus, because at least you have the hippocampal sparing.
We will be very brief in questioning and answering, because next, Amit, please.
Yeah, I have a question with Dr. Kotecha. What's your experience with brainstem metastasis?
Yeah, so I mean, we have similar. Essentially, what we do is single fraction if they are small lesions, so less than 1 centimeter. And if they're more than 1 centimeter, then we would do fractionated. I'm actually, for the NRG trial, I have to write the international guidelines. And what I wrote is essentially, if it's less than 1 cc, 18 gray, 1 cc up to 4 cc's, then you can give 16 gray. And then more than that, then you would give 14 gray. So.
And outcome-wise, survival?
Yeah, the survival actually for brainstem mets versus patients who do not have brainstem mets are actually the same. And so previously they were excluded from trials or excluded from analyses, but there have been multiple comparative series that show that they're the exact same, so they should not be excluded.
And small cell cancer?
For small cell, you can technically reduce by 2 gray if you want. We usually give the same dose. In the United States, actually, we're starting to give radiosurgery for small cell. There's what's called the FIRE SCLC analysis that shows that their outcome is the same, whether they get radiosurgery or whole brain radiation. So that was areas that we used to give whole brain radiation, and now I've trained to give them radiosurgery.
How do you explain that slide where you showed that the ASL was there, the choline peak was there, and the PET is negative? I mean, how do you explain that physiologically?
Oh, yes. I mean, this is just the discordance with the imaging that you have. I mean, nothing is going to be 100% sensitive or specific.
Because we have been heavily relying on ASL and
I know.
choline peaks.
Actually,
if you can repeat the slide, there is very high lipid peak, so we should consider that it's maybe necrosis, actually.
To say the same. And it was not ASL, mind you. It was perfusion with DSC. It was CBV. And we have seen CBV is not so great. ASL is superior. I just take 10 seconds to ask Rupesh. First, on a lighter note, you don't have sleepless nights, which machine to choose? You have got Proton, CyberKnife.
It'll be I think it's like the second to last lecture before the conference ends tomorrow.
All
but
right.
I got asked to compare the advantages and limitations for every single modality. So we'll go one by one for each of them.
Sure. Very quick question is about, again, pre-op SRS. So many of the lung cancer patients, they are on immune checkpoint inhibitors, and then you present with large met, need surgery, you do pre-op SRS, and then you also have sometimes dexamethasone. So how do you interplay the whole? Do you stop immune checkpoint blockade, and how soon do you restart after surgery?
So the data that we have essentially shows the best benefit if you're going to do radiosurgery and then receive immune checkpoint inhibitor within 4 weeks. We actually did a separate analysis in our patients. We had 151 patients treated with 1,000 brain mets with and without immune checkpoint inhibitor. And actually even 2 weeks was a little bit better than 4 weeks. And so we give them radiosurgery, we give them essentially 5 days of Decadron, and then they would stop, and then we would get them to receive immune checkpoint inhibitor therapy. There are 2 other established practices in the United States. One is to actually give the patient Keppra instead of dexamethasone during the time of radiosurgery, so that you can hold the patient over in case they have a seizure event.
Yeah.
So number one is to give them just Keppra, and a second is to actually give them a single dose of Avastin right before you do the radiosurgery, and then withhold any Decadron. We don't do that in the outpatient setting, and you cannot, at least in the United States, get it approved because the approval is for radiation necrosis. But if the patient is an inpatient, then you could potentially give them a dose of Avastin and then do the radiosurgery. I actually wanted to do this as a clinical question, but we couldn't get the funding to do it. But I think
actually we use Avastin as well.
That's
and
what
if there is if you discover a small residual, you have given pre-op SRS, do the surgery, and you find a small residual.
Yeah. So if there's any, for example, the patient doesn't have a gross total resection. And actually, if you looked at the series for pre-op SRS, 100% of our patients had a gross total resection. It also is why our control rate is so high. that's not in the established literature. And if you have subtotal resections, their control rate drops very quickly. So what I would do is we do a post-op MRI, and if they have residual, or I would see, at 4 weeks, we would give them a boost dose. So if we gave 18 the first time for pre-op SRS, we'd give 12 gray as the boost, so you give 30 gray over 4 weeks.
I would ask you.
Sorry, Dr. Rupesh, there was a hypothetical trial which is going on with tumor treating fields and your SRS. You think that because the tumor treating fields, it is always throughout the day, throughout the month, throughout the years, would it act as a prophylactic measure of decreasing, prophylactic measure of the metastasis coming out?
That's the purpose of that trial, is to reduce the distant intracranial failure rate after upfront SRS alone. So that was the purpose of that study. So we'll see if it does that.
Dr. Rupesh, since you're doing a lot of SRS, just want to ask a comment, where do you fit in whole brain hippocampal avoidance, whole brain RT with memantine in your picture? Because we don't have a head-to-head comparison with SRS.
Yeah, so typically if there are less than 15 brain mets, then we're going to do radiosurgery up front. If they're young patients, have axis targeted mutations, sometimes we'll increase that number. So if it's more than 15 lesions and they do not have lepto, then they will get hippocampal avoidance whole brain plus memantine in the upfront setting. In the recurrent setting for patients who have a very high brain mets velocity after upfront SRS, then those are patients who we will also give hippocampal avoidance plus memantine.
I thank all the speakers. It has been a wonderful session. Thank you, everybody.
Our next plenary lecture is on current role of conventional FRT in the management of intracranial extracerebral tumors. And moderators for this session are Dr. Amit Jain, Consultant Radiation Oncologist, Valentis Cancer Hospital, Meerut, and Dr. Anand Balasubramaniam, Head of Neurosurgery Department, Amrita Hospitals, Faridabad. I request our moderators to introduce the speaker.
Professor Elisa Encheva is a professor in Radiation Oncology Department and University Hospital St. Marina, Medical University, Varna at Bulgaria. Now for 2 days about stereotactic radiosurgery. Now it's time to see whether there is any role left behind for conventional fractionated radiation therapy in the management of brain tumors excluding gliomas, definitely. Professor Encheva.
Okay, thank you. Okay, hello everybody. I would like first to thank the organizers for inviting me. It's a pleasure to be in India. It's my first time. As you see, my topic is about conventional radiotherapy in management of intracranial extracerebral tumors. We know that these intracranial extracerebral tumors are a heterogeneous group of tumors, and they have different degrees of aggressiveness. They could originate from brain membranes like arachnoid, dura, like from bone, endocrine, nervous, and vascular structures. And the most common histologies here are the meningioma, pituitary adenoma, vestibular schwannoma, craniopharyngioma, paraganglioma, and also they could be they're mostly benign. Could be also malignant lesions like chordoma, chondrosarcoma, like brain metastases, and also hemangioperitoma and all others. Of course, they could be located at skull base or on convexity, and usually surgery is the first treatment, the primary treatment in vast majority of the patient. Patient could be managed successfully just with surgery when the tumor is less aggressive and with favorable location. And radiotherapy is reserved for residual tumor process total resection in patient with large tumors and high risk of complications from surgery. Radiotherapy is given also in recurrent scenarios, post-gross total resection when tumor has very aggressive behavior and not good histology features. And it's, radiotherapy could be, fractionated radiotherapy could be effective first-line treatment for selected tumor. Radiotherapy could be given conventionally fractionated in multiple fraction, could be given SRS like 1 to 5 fraction, also in hyperfractionated SRT 5 to 10 fraction. And the risk of toxicity is associated with the total dose we give, the dose per fraction, location, volume of the tumor, and the volume of irradiated healthy tissue in the high dose region. We all know what is the conventional radiotherapy. For benign tumors, we give 45-54 gray, and for malignant till 60. Sometimes we could give boost in meningioma if it's malignant and a gray, about according to new protocol. So in conventionally fractionated radiotherapy, we could use photons or protons. Recently, we already used the modern technique, IMRT-VMAT, in fractionated stereotactic radiotherapy. The protons could also be delivered with IMPT. So we all know the difference in toxicity tolerance dose based on the fractionation schedule. So if we could not keep the tolerance dose low enough, it's better to use the conventional hyperfractionated or conventional fractionated radiotherapy. Now, first I'm going to talk about meningioma. You all know that this is the most common primary CNS tumor. It's a heterogeneous group of tumors, and the outcomes, they differ, vary with the histology, the molecular genetic findings, the location of the tumor size, the volume, the presenting clinical characteristic, and the treatment. Of course, we know that the outcome varies with the grade of the tumor. We know there's statistical different recurrence-free survival based on new WHO classification. We also could rely on molecular markers for grading and our aggressiveness of the tumor. Of course, the best predictor for our results is the Simpson grading, and unfortunately for managing meningioma we don't have randomized trials. We also only rely on retrospective and single institution series. And recently 2 phase 2 trials for external beam radiotherapy were performed, and unfortunately the treatment is associated with high morbidity. I mainly focus on grade 1 meningioma, where the management could be observation, gross total resection, or subtotal resection. If it's needed, could be added radiotherapy. In grade 3 meningioma, it's more clear that we definitely need external beam radiotherapy post-surgery, and it increased survival. The active debate is about adding radiotherapy to gross total resection in atypical meningioma. Because when it's subtotal resection, radiotherapy, fractionated radiotherapy could improve progression-free survival. So as I already said, radiotherapy is widely used for meningioma. It could be in primary treatment, adjuvant salvage therapy when in recurrence or progression after resection, and we could use different regimens. So standard fractionation regimen, like conventional fractionation, we could use 50.4 gray for grade 1 till 60 gray for grade 3 meningioma. Usually in grade 1 meningioma, the gross total resection is considered definitive treatment. But unfortunately, we observe a lot of local recurrence. This is mainly based on the improved imaging, and post-subtotal resection, the recurrence rate is much higher. So in this case, radiotherapy is only validated non-surgical intervention when we have a recurrence post-resection. So it's commonly and in the past mostly delivered with conventional fractionated radiotherapy. We have substantial evidence to show the efficacy of fractionated radiotherapy grade 1 meningioma, with achieving 5-10 years local control rate from 89 to 100%, with low late toxicity 0-12%. And fractionated radiotherapy improve control after subtotal resection in grade 1 meningioma from 60% to 100% when we add radiotherapy to subtotal resection. And these results, they are concordance with the result low risk arm of RTOG 0539. So what data we have? If we have look at systemic review and meta-analysis that compare SRS versus stereotactic radiotherapy, we can see that unfortunately the results in the literature are contradictory. So one of them show that the control is better with fractionated radiotherapy, another says it's better with SRS. In this systemic review and meta-analysis based on 1,700 patients, it's shown that radiographic tumor control is better achieved by fractionated radiotherapy, and unfortunately, it's shown that SRS had a twofold higher likelihood of clinical worsening during follow-up and 4 times higher risk of immediate post-irradiation symptomatic edema with respect when it's compared to SRT. But the PFS value at 4 and 10 years are similar, around 90%. Another moment is that clinical worsening is a little bit less but not statistically significant in fractionated radiotherapy. Where is fully given fractionated radiotherapy? This is in case of meningioma of optic nerve and perioptic nerve meningioma. It could also be given in severe cavernous meningioma. And with fractionated radiotherapy, we achieve a good control. And of course, we need to have the good imaging to diagnose without biopsy this tumor, the optic nerve sheath meningioma. Gallium-DOTATOC PET imaging could help us distinguish the meningioma from gliomas. For optic nerve sheath meningioma, we all know that observation could lead to visual deterioration. Surgery will cause vision loss unilaterally, and a single fraction radiosurgery usually used when the patient already lost his vision or there is a poor vision. And fractionated radiotherapy has shown to be superior when compared in a study to observation, even compared to surgery and surgery plus radiotherapy. So only radiotherapy proved to be with no significant decline in visual activity from diagnosis to last follow-up. And the doses that was given in this study in 64 patients was 40-55 gray. The complication rate in surgery arm was double than radiotherapy arm, 66% compared to 33%. And in the complication was radiation retinopathy, vascular occlusion, persistent neuritis, and temporal lobe atrophy. There could be used all modalities of radiotherapy in treating optic nerve sheath meningioma, but not one fraction when we like to preserve the vision. In most of the cases, we preserve the vision in 80% of the patients. So we need to keep in mind the dose for optic nerve to be less than 54 gray in 30 fractions. So the complication rate, of course, increases with the higher dose we deliver, and radiation retinopathy is more common observed in tumors which are anterior. And high dose of more than 50 gray predisposed to retinal injury. The radiation optic neuropathy in these cases develop between 3 and 8 months, 3 months and 8 years post radiotherapy. These are the studies we have. We have these studies, selective studies, fractionated radiotherapy. They show that we have very good local control, 100% 5-year local control when we give fractionated radiotherapy in the range of 50.454 gray with very less toxicity, ranging around 7% long-term optic toxicity, optic nerve toxicity. Nowadays, there are few series reporting fractionated SRS in 5 to 5 fraction with very good results, also achieving local control from 96 to 100%. So in this manner of delivering SRS, we can get comparable results with fractionated radiotherapy. The other meningioma where fractionated radiotherapy has a place is cavernous sinus meningioma. Unfortunately, we don't have any level 1, level 2 data, no evidence, no randomized trials. We just have some level 3 match series, and they show similar results, except the shrinkage, radiological tumor shrinkage is higher when we give SRS, is 53% compared to 29% when we give fractionated radiotherapy. And the ISRS guidelines, which were issued 2018, based on this data, they concluded that based upon current available evidence, SRS and SRT confer favorable benefit to risk profile for most patients with cavernous sinus meningioma eligible for radiotherapy. So these are the studies that show very good results, around 95% tumor control with given fractionated radiotherapy and good cranial nerve preservation. So the guideline consensus statement of European Association Neurosurgeon skill-based section recommend fractionated radiotherapy only if the distance to the optic nerve is less than 3 millimeters and the ipsilateral visual function is good. So we see here in the, I don't know, we could give fractionated radiotherapy. We don't have any symptoms, sorry, I cannot point. No symptomatic meningioma, meningioma, and tumor bigger than 2.5 centimeter. So about our target volume delineation, we have some recommendation. I think all you know that durotate does not need to be included in the GTV. GTV to CTV for grade meningioma could be 0 to 1 centimeter, primarily along dural surface, and the hyperostic bone should be included in the GTV, and PTV to CTV margin could be 3 millimeters, and those range, as I told you, is till 54 degrees. What evidence we have for adjuvant radiotherapy in grade 1 meningioma? We have two phase 2 trials. One is R2G0539, the other EORTC. In the first trial, recurrent grade 1 meningioma is in the intermediate risk group, and the dose they give in this trial is 55 grade to GTV plus 1 centimeter. And they prove that in this case, given radiotherapy as post in recurrence, achieve excellent PFS, 3-year PFS, around 94%, and the subgroups have the same results. So these results support the use of adjuvant radiotherapy for gross totally resected atypical meningioma, newly diagnosed and recurrent Yuhu grade 1 meningioma. For about the high-risk group meningioma, very good PFS was achieved, 3-year PFS with 78% overall survival. Another trial that was made for advanced radiotherapy, it didn't include any grade 1 meningioma, but proved the same, the very good PFS, more than 70%, which was the primary endpoint when giving radiotherapy. So the current phase, three-phase trial, but they don't include, again, they're just for atypical meningioma, and they compare gross tumor resection plus observation versus gross total resection and radiotherapy. So based on the literature, the evidence we have, IANO guidelines recommend to give radiofractionated radiotherapy for grade 1 meningioma only in recurrent setting when we don't have gross total resection or we have a recurrence. So the next, because of the matter of time, I will move fast. We know that pituitary adenoma are 60% of all brain tumors. They are the second most frequent intracranial tumors. They could be secretory, non-secretory adenoma, and we need to have a very good imaging to detect our microadenoma, because sometimes we can have false negative rate at 45-62%. The management of pituitary adenoma could be observation, surgery, medical management, or radiotherapy. In matter of SRS or fractionated radiotherapy, indication for non-functioning, non-secreting adenoma is adenoma that is suitable for surgical treatment, or recurrent or progressive or residual disease of total resected adenoma, and for secretic adenoma we have the same indication, plus we'd like to of course, hormonal excess after a maximum operation and conservative treatment, or it means in case of hormone refractory disease. Of course, our goal in functional adenoma is mainly to normalize the hormone secretion and to control the tumor growth. In non-functioning adenoma, we'd like primary goal to control the tumor. In stereotactic radiotherapy, fractionated radiotherapy, it's an option in macroadenomas when we have larger tumors more than 3 centimeters, and unfortunately the treatment effect occurs in post many years compared to stereotactic radiosurgery, and fractionated radiotherapy could be delivered in case of large tumors in close proximity to optic nerve chiasm, and even in cases when the optic chiasm and optic tract is not visible and is encased by the tumor. And in small well-circumcised tumor, of course, we could give SRS, and depending on this, if the pituitary adenoma is fractionated or no, we can give a higher dose in secreting pituitary adenoma, 50.4 to 55 gray in 1.8 daily fraction, and for non-secreting adenoma, we can give even 45 with very good control. And of course, our tolerance zone for optic tract is much higher when we compare with SRS. And this is the safe way to irradiate really big lesions, like unfortunately we see in our practice. And this patient, usually they come blind to us, and unfortunately we cannot, vision could not be recovered, but at least to control the growth of the tumor. So usually the GTV is equal to CTV when we control these tumors, and for PTV we add 5 millimeters. And it depends if it's stereotactic frame treatment or standard thermoplastic mask. If it's a stereotactic, we can reduce, if it's fractionated stereotactic radiotherapy, we can reduce margin 0 to 2 millimeters. These are the results from fractionated stereotactic radiotherapy, recent results given for pituitary adenoma. And the local control is between 87 and 100%, and with hypopituitarism occurring much less than the past than in the past, so it's around 10 to 40%. In the past was 20 to 60% with conventional fractionated radiotherapy. Sorry, I'm going fast because I have more to say. So this is the problem, the hypopituitarism. When we treat, this is the most common long-term toxicity when we treat pituitary adenoma, and with modern fractionated stereotactic radiotherapy, the series showed this reduction of hypopituitarism. The optic neuropathy is very low rate, less than 1% in fractionated in the new series, and all the series a little bit over 1%. So secondary brain tumors still observed 10 or 20 years post radiotherapy, and they are also not so high incidence comparing the old series, around 2%, 2.5%. So when we look at the literature, we could see that both fractionated and stereotactic radiosurgery, when we compare both treatment of could control tumor growth with a very the same results, and only the difference is that median time to complete remission is much faster, 26 months compared to 63 months. When we give SRS, we could achieve a faster remission of the secretory of the tumor. This is a sonographic. It's old study, but very good study, and we see the difference between cumulative remission rate and overall hormone complete remission rate was 26.2 at 2 years and 76% at 4 years. Another study tried to ask the question, is it better SRS than conventional radiotherapy? And they found that they have similar tumor control rate, similar endocrinological remission. Unfortunately, it's a lower rate than tumor control. and acceptable new hypothyroidism rate 10 to 50%. So it's proof that it's effective treatment. This is how we see fractionated radiotherapy could achieve in non-secretory pituitary adenoma 95% tumor control. And in patient with acromegaly, the hormonal remission is about 35% at 5 years. For Cushing disease, is 75 at 5 years, and for prolactinomas, 25 to 36%. Another systemic review and meta-analysis that included 134 patients also shown that SRS and fractionated radiotherapy achieve a comparable local control and the endocrine cure rate. And this is interesting study comparing radiosurgery with fractionated radiotherapy and transsphenoidal surgery, and it shown that modern fractionated radiotherapy is associated with more favorable local control and equal survival compared with transsphenoidal surgery. So SRS and FRT shown to be better, and there are also similar results with given stereotactic method of local control given SRS and fractionated radiotherapy. When we look at the modern data, giving radiotherapy with modern LINAC, we see that 5-year PFS is 95% for secretory tumors and 95% for non-secretory, and worse PFS was associated with larger PTV. And hormonal control at 5 years was reported to be 50%, and it was associated with higher dose to the tumor and the number of surgeries. The guidelines recommend that radiosurgery using single fraction 12 gray or more radiation therapy with fractionated radiotherapy 255 gray is recommended for greater tumor control rate of 90% or higher at 5 years after treatment. So this is for functioning pituitary adenoma. So as we saw based on the literature, SRS and fractionated radiotherapy are both effective treatment for pituitary adenoma. For large lesion involving the optic apparatus, conventionally fractionated radiotherapy is recommended. And unfortunately, development new pituitary deficit is reduced, but is still present. So we should consider the quality of life of our patients and the future complication. And of course, we need clinical trials to compare the different fractionation regimens. The next, I'll move to vestibular schwannoma. It's 8% of all primary tumor, brain tumor. It was said a lot of vestibular schwannoma. We know that radiotherapy could be delivered like SRS, fractionated radiotherapy, or hypofractionated radiotherapy. And we have different approaches. And all these approaches, wait-and-see microsurgery, are equally effective depending on the size and location of the tumor. So one of the major benefits of giving fractionated radiotherapy or SRS in comparison to microsurgeries is the decreased risk of cranial nerve damage. And of course, the hearing preservation is our primary goal. And also, we'd like to maintain the quality of life of our patients. Fractionated radiotherapy initially was used as adjuvant to subtotal resection, and the reports from 1987 showed decreased recurrence rates from 46 to 6% when adding radiotherapy to surgery, subtotally resected tumor. And of course, in the past, it's now already we don't see this high rate incidence of trigeminal and facial nerve palsies. It was higher with SRS. That's why fractionated SRT was introduced. And unfortunately, most of the studies we have are retrospective reviews. We don't have any randomized data comparing the different modalities. And we see very good hearing preservation rate from 50% to 86, even 100% with contemporary fractionated radiotherapy. And the largest series from Germany published 2015 based on 300 patients almost. They even observed a very low risk of cranial nerve toxicity, only 1%. For a median follow-up of 5.6 years. So, sorry, I just will move fast to the other. long-term outcome show similar results, and this was stated, the guidelines, neurosurgical surgeon guidelines stated that there is no difference in radiographic control and clinical outcomes using single multiple fraction. No recommendation can be given. We observe improvement dizziness and tinnitus in the patient with conventional radiotherapy. Unfortunately, tumor expansion is also observed, and as big the tumor is, bigger the expansion is. For example, tumor 3 centimeter, 50% expansion was observed, and it was associated with increased risk of hydrocephalus requiring shunt, loss of cervical hearing, worsening of facial trigeminal nerve. And these findings support the use of early SRT rather than wait-and-see policy from the standpoint of hearing preservation. The young recommendations, unfortunately, I don't see SRT even in large tumors, just in neurofibromatosis, but I think it should be included. Is mission, but another algorithm given from Germany, where they try to prove the role of protons in pituitary adenoma. They show that fractionated radiotherapy or proton therapy could be given in stage Q3 or 4 when surgery is impossible or rejected. This is for target volume delineation. We donate margin GTV is equal to CTV, and PTV is 1 to 2 millimeters. We need to talk craniopharyngioma if I may fast. Radiotherapy, the gold standard for treatment of craniopharyngioma is surgical therapy plus radiotherapy with 5-year survival rate of 98%. And giving radiotherapy to surgical therapy, it improves 10 years. It's 90% compared to 81% with gross total resection and 42% with subtotal resection. Radiotherapy could be given fractionated. Usually fractionated radiotherapy we give when we have contact with optic nerve, difficulty to identify optic pathway, and large tumors. And we usually give gray 50.2 to 55 gray. The local control is very high. At 20 years local control with fractionated radiotherapy is 88%, and overall survival at 20 years 67%. It's safe to deliver fractionated radiotherapy with low rate of optic neuropathy. Only one case was reported in 60 patients. And what is interesting that in pediatric craniopharyngioma, there was no difference in 1 and 5 years progression-free survival between gross total resection and subtotal resection plus radiotherapy. But there was a significant difference between subtotal resection compared to subtotal resection plus external beam radiotherapy. And just to say very interesting thing is that compared to stereotactic radiotherapy, radiosurgery, we don't observe complete tumor control, tumor disappearance, but we don't have a difference in tumor control. And there was a study showing that we could give radiotherapy indefinitely matter, and that age was associated with worse overall survival, and highest proportion was given surgery plus radiotherapy in pediatric population. So probably the radiotherapy is not very often given in adult patient, and it's shown that it's better to also was shown that limited surgery with radiotherapy, fractionated radiotherapy, could achieve very good tumor control. And when comparing radiotherapy, limited surgery plus photon radiotherapy and proton radiotherapy, there was no difference in results. Only the difference was in the cognitive function. Statistically significant was the IQ change and adaptive behavior. Proton did not improve survival in pediatric compared to photons. And another very interesting trial is that when we compare partial resection plus radiotherapy versus gross total resection, we see similar intellectual function and quality of life. There's no difference, even if we had radiotherapy. So we should take care of the imaging during the radiotherapy course, because we observe a big change in the cyst. So usually in children we recommend the weekly MRI to see if they're too. Yeah, sorry, I could not finish. Yes. Okay, thank you. I hope. I don't know if you have time. I just leave.
Thank you, Dr. Incheva. Thank you so much.
Thank you.
So we can have a few quick questions. I think people.
This optic nerve glioma with no vision. Do you think this role of radiotherapy? I think surgery can give a total. You can remove the disease in that situation. Optic nerve glioma with no vision.
No vision.
Yeah. So do you still want to give radiotherapy as you mentioned, or I think surgically we can eradicate?
Yeah,
the
if it's,
disease?
of course, if it's possible to eradicate surgically, yes, but radiotherapy is given for tumor control and for other symptoms like headache or because of depression.
We can remove the whole disease then.
If it's possible, of course, but some patients, they come to us with many recurrence, many operation, and they already don't want to get any more surgery. This is a problem. That's why sometimes we need.
For benign lesion of the skull base, do you prefer stereotactic fractionated radiotherapy or wide field conventional fractionated radiotherapy?
3 to 5 fractions of SRS, I would prefer.
No, SRT, stereotactic radiotherapy or wide field conventional?
No, I prefer the
Stereotactic.
Stereotactic,
Okay,
yeah, but
okay.
fractionated stereotactic
Yes,
instead
yes,
of
yes,
conventional, yes. And depends on the patient will, of course. Some patients are afraid when we explain the side effects that could follow, they don't want to get this short course of treatment. They prefer to get the less toxic based on their understanding.
I had a general question to ask regarding fractionation. So it is SRS if it is 5 fractions, and some people go up to 10. Otherwise, you are directly dumping to 30 fractions. So why is there no number in between? Is it dictated by convention, or can you modify it to a lesser number between 10 to 30 depending on the dose constraints or organs at risk? Then you can reduce the time to treatment and maybe have a better biological effect than standard 30 fraction.
Yeah, that's a good idea, but unfortunately we don't have the data. Now from 1 fraction SRS we move to 3 to 5. Of course in some locations, some tumors, they also a regimen 10 times 3, but still we don't have the data for toxicity. We need to have a long-term, we have the best long-term data for this fractionated regimen and 1 fraction of SRS. So that's why, of course, could be done, but need to be done in a trial. Yeah. And of course, we don't have any
idea for somebody to think and
trial. Yes.
Yeah, we have
40 grays and
15
15 fraction,
yeah.
yes. But it's different scenario. There is a different kind of, this is benign tumor, different radiobiology behind.
Especially in benign tumors, we should think of cutting down the fraction.
But
see, the thing is, when we do conventional fractionation, it is only in a very large tumor, or it is impinging on the optic chiasm or the brainstem, or near the spinal cord, or in a critical structure. So if you do that, historically the radiation, as soon as you go more than 1.8 to 2 gray, there is a risk of long-term side effects. So therefore, the hypo 2.53 doesn't work. If it is really away and it is relatively small, less than 3.5 centimeter, even 4 centimeter, but you respect the chiasm and you respect the tolerances, then you might as well finish in 1 week, 3 to 5 fractions. But if it is larger, then you don't want in between. So therefore, historically, there have been 2 paradigms in benign tumors because they live forever. Yeah. You don't want any side effects in future.
Yes. Okay. Thank you.
Thank you.
Thank you.
Yeah, we can proceed to the next session. Thank you so much.
The next lecture is on proton therapy and heavy ion therapy, its current status and future perspectives of clinical applications. The moderators for this session are Dr. Mikhail Chernov, Department of Neurosurgery at Tokyo Women's Medical University, Adachi, and Professor C.S. Madhu, HOD and Consultant at Department of Radiation Oncology, Lord's Hospital, Kochi. So kindly introduce the speaker for this session.
So our next talk on proton therapy and heavy ion therapy, current status and future perspectives of clinical applications, will be given by Professor Rakesh Jalali, who is director of this course and world-famous specialist in radiotherapy, specifically in pediatric patients, who is now working with proton therapy. So definitely he will give us up-to-date information about such treatment.
Thank you.
Please start your lecture.
Thanks very much for the kind introduction. It's been an absolute pleasure to see the different deliberations and presentations in the last two days. I'd like to begin with a case which have been actually discussed several times during the course of 2 days, but it's just a case example of a relatively young person many years ago who presented what looks like a symptomatology of a corticotroph secreting tumor. It was a Cushing's, underwent a surgery, there was some residual disease, underwent a gamma knife radiosurgery, 30 GY at 50% isodose, had a good DFI. Several years later, again had unfortunately a progression, started with 2 sets of medical management of cabergoline and kitazosanol, and then eventually went to Mass General to receive a proton radiosurgery. This is just an example of how the patient's natural history goes in these relatively difficult tumors to manage. He had uncontrolled diabetes mellitus, went to Germany to underwent bilateral adelectomy, started again on medical management, symptom improved a bit, but then again presented with uncontrolled, very high cortisol levels, and was essentially developed a Nelson's. And then there was a large recurrent lesion. Another surgery was performed, was an aggressive pituitary adenoma, ACTH secreting, and was sent to us for further management. So when he came, he was like a typical uncontrolled, difficult, recurrent, refractory, aggressive Cushing's that you would see in the clinic. He was very obese, he was in a wheelchair, had significant myopathy, uncontrolled diabetes, uncontrolled hypertension. Was very difficult actually to even think of us to consider proton therapy or any further therapy, with several motivations and discussions with our endocrinology colleagues. We eventually thought of what to do, and then what we did is you can see the tumor there. And our philosophy has been, and this was discussed by some of the speakers yesterday, that when I was in Tata Memorial, we used to run a pituitary clinic with our endocrinology colleagues in KM Hospital along with Professor Atul Goyal's team. And we always felt that it's always better to treat the entire cella, not only when you don't see the tumor, even if you see the tumor. And there was discussion yesterday that if you see the tumor, you do SRS and then you don't treat. But if you don't see, you treat the entire cell. I think Professor McKinchan also mentioned that. But our philosophy was always to treat. It was almost like a radiation hypophysectomy. And then we had the stereotactic conformal radiotherapy that time. It's a relatively small number of patients. But even I was surprised with the relatively high remission rate of 75%, and we saw since yesterday it's always been bordering anywhere between 30 to 40 to 50 to 60% max. You could say that there was a high instance of new deficits. It was true, but all of us know among all the pituitary tumors, perhaps Cushing's is the most difficult, and if you can achieve the remission, then why not do it? So we did the same. We had the proton therapy. We have the we are lucky to have the state-of-the-art image-guided intensity modulated proton therapy. It has the pencil beam technology. We don't give CTV, we just optimize using robust optimization, but every single case that we have treated uses Monte Carlo optimization with a very small spot size. We gave conventional fractionation, this dose distribution, what we call multi-field optimization IMPT plan. And in the first half, we had some difficulty to set the patient up, but eventually we did it. I have to say this has been, in my career, one of the most gratifying results. Within few months, literally, there was a dramatic, significant improvement, and we have seen it that in radiosurgery as well. There was a weight loss, improvement in Cushing-Guide's feature, his levels normalized. It took us few months to normalize. He's been in remission now more than about 2.5 years. preserved cognition, memory. He is a CEO of a major Asia Pacific, actually pharmaceutical company, has started traveling again throughout the world, and this is what we can do sometimes. So this is not just to show that what is the impact of proton, but it's also to show the natural history of the disease, and radiosurgery may not be one-stop shop in many of these tumors. So you have to continue following these up cases with subsequent treatments. And some of the philosophies essentially from radiosurgery and radiotherapy is that in radiosurgery, we know that sometimes you have to treat. In radiation oncology, generally our philosophy is to treat just once and therefore not wait for the tumors to recur. And it doesn't happen always, but that is just the general philosophy. We know for many years now, more than 60 years, that proton beam therapy has this fantastic physical and definite biological advantage of conventional radiation. And every single radiosurgery that we have discussed so far uses photon, whatever technology you use. And the proton has the distinct advantage that you can just actually stop it, and we know that depending upon a finite length and energy, it deposits all its ionizing radiation at one particular point and deposits what's called Bragg peak. And then that's also because of the positive charge, it has a direct ionization as compared to free radical through the indirect ionization which you use in photon. And you have seen that table just briefly tells you about the year it has been started. One of the challenges, of course, is that we sometimes do not know what is called end of range uncertainty, where the RB would end, and also how much would be the RB. Traditionally 1.1 to 1.3, but we have seen variations in it, and especially if you go to heavy ions, then the toxicity and the relatively uncertainty increases. Now, we also are aware that actually proton therapy were one of the pioneers of radiosurgery, and we have all learned in our student time how our pioneers from Gelberg to Fabricant and many others, relatively inaccessible AVMs could treat, and this is one of the earliest series, depending upon as large series as 70 cubic centimeters, and they realized they were among the first ones to give us the dose constant, which subsequently were modified in the classic Flickinger's model, but these were very, very early data, and they also tried to see what is the dose threshold and eventually found out that 25 gray equivalent. Mind you, these were relatively older technologies, they were scattered technologies, but we also learned from the follow-up of the Gelberg studies of more than 1,000 odd patients, 1,200 odd patients, that what is the impact of the size, what is the impact of the dose, what is the impact of evaluation, what is the impact of the location, and these, although have not been routinely used because of the difficulty of you having so many proton machines and also the technical challenges and the cost and so on and so forth. But I have to say, and all of us agree, that they kind of laid the platform for subsequent radiosurgery people to learn from it and then adapt and adopt some of these early data into their routine practice. We also know that although protons have been there for many years, the real renaissance really is taking now. You know, it's only about 10 to 12 years. And one of the problems was the initial protons infrastructure was quite cumbersome. We had a very wide beam, we didn't have a very narrow beam, so we had to use a lot of apertures, we had to use a lot of collimators, we had to use, on a customized basis, we could use 3 or 4 beams, but each beam had to really narrow down and conform to the shape of the tumor. Because of the extra hardware, it needed more time, it needed more cost. It also needed several systems. There was practically no image guidance. Everything was on scatter technology, both the passive scattering and the double scatter, and also had a relatively high neutron contamination, which you don't know. So some of the benefits of the proton, because of the ability to restrict the doses from the exit dose point of view, a little bit tempered with the excessive neutron dose. And then, of course, we knew that there was time-consuming hardware and cost and many other issues. As I said, the pencil beam technology has been a major evolution. I wouldn't use the word revolution because the first paper actually came in 1998. It amazes me the concept of IMPT was in 97, 98, even before IMRT came. And then, of course, IMRT became very popular. Tony Lomax was the first one to give the concept of pencil beam technology. So instead of being very large beam, now we use very tiny, the spots as low as 3 millimeters, and we take the entire target, you slice into different tissues, depending on the energy. The energy also increased now 70 MeV to 230 MeV. So like we say, we make a little bit slice of each target, and then we treat literally spot by spot. and you treat by layer and by line. So this gives you a very nice distribution coming from the distal edge, which is treated by the heaviest energy, and on an inverse planning algorithm and platform, then you can go proximally in about a target, divide into like 1,000 bread slices, and then literally paint on a spot by spot, line by line, layer by layer, and you can practically sculpt the doses. So in other words, it gives a very nice dose distribution. So SRS, the greatest advantage, of course, is this fantastic conformity, and then you have literally no dose, but you are limited by the size. So proton, there is no size limitation. In fact, the smaller target, there is hardly any difference. In fact, proton might be worse because of the lateral penumbra. But as soon as the target becomes slightly larger, you get beautiful distribution as you would get in SRS. So imagine in SRS world, you could treat everything with SRS with as conformality, and that is what the proton can potentially do it. The larger the tumor, the larger is the target, better is the magnitude of the benefit. The American Society of Radiation Oncology, the ASTRO, gives this group policies, and these are the number of policies where it can be standard of care, and it does list malignant and benign CNS tumors, and there are group 2 indications, but CNS tumors already are in the group 1. So in India, we are fortunate to have the first proton therapy center. Of course, it takes a lot of time. The initial thought process was as way back as in 2012. Goes to a lot of process. There was no, this was the first proton facility in the country, so it had to go all the iterations and all the pains that you would associate with getting the regulatory agency, but eventually in December 2018, we got the beautiful print that we've always wanted, that the Atomic Energy Government of India approved the first proton installation, and then we started the treatment on 1st January of 2019. This is the facility. We have the IBA Proteus Plus. We have 2 gantries and 1 fixed room. And the energy levels I already told you. And there's a beam degrader initially, which degrades the energy that you use. This is the Proteus cyclotron accelerator. And this is the energy degrader and the beam transport system. And as I just mentioned, we have 3 rooms. We were also lucky that it was quickly realized, based on the experience of global centers, that it's not enough to just have a standalone proton center. It's a dedicated cancer center, and you have the operation theater, you have the medical oncology, you have the surgeons, you have the genomics, you have the tumor boards, and we know that radiosurgery or radiotherapy or proton is just one part of the entire treatment, especially in the cancer. Now, we treat routinely about 45 to 50 patients on the couch. On the 2 gantries, as you can see the graph, when we started, of course, we had only 8 hours of machine. We could treat only about 5 to 10 patients. Then we got 16 hours, then we got 2 rooms, and then we can hit up to 50 to 55 patients. There's a fair number of patients in the CNS, but 24% of the patients are in the pediatric age group. These are the first two papers that we published, and this has been cited many places because these were among the first papers which had come from the modern IMPT image guidance, both from the physics, characterization, and performance point of view, but also we were among the first ones published in BGR that we demonstrated that the fear of ambient neutron contamination was very, very low in the modern contemporary proton series. We also realize, however, as is the case in radiosurgery, that there does need to be a very stringent peer review process. So we start our day in our hospital with what is called daily ISO-center meetings, typically in the morning, and the room is also called actually ISO-center room, and where we discuss all the every single case, every single plan. It has to go through the checklist, how many cases of the quality assurance, how many have to adaptive, and this has been an incredibly learning experience for all of us. Dr. Srinivas, who is actually in my audience, we are all site-specific. He treats a lot of children and adults, adolescents as well. He collected the first Indian proton beam therapy series, was based on a protocol called RAPPER protocol. This was based on children and young adults. And as you can see that it was a very prospective evaluation, very encouraging. We also realized that some of these children, there was hardly any SOPs for the pediatric anesthesia. And then we got a dedicated pediatric anesthesiologist. There were several things that we had to do for the pediatric space. And we eventually published them as well, such that there is some database on SOPs, how to administer the pediatric anesthesia on the proton therapy. We discussed a little bit about the chordoma. I mean, there is absolutely no doubt, and we discussed with many people. You speak to Professor Al-Mafti himself. He is convinced that you cannot just treat a small chordoma, cannot be treated only a small disease in a one area. If you look at the long-term history, they are, as we know, they are benign but locally aggressive. They have difficult locations. We absolutely know that there's a dose-response relationship, PFS with surgery alone suboptimal, and every single consensus guidelines have shown the importance of particle beam therapy, both proton and carbon ion, and also they have this non-contiguous spread. Standard of care, this is modern IMPT series from PSI Zurich, as high as 72.5 gray RB, which was discussed in the morning. And there are several factors, though, which do play a role. The OR compression, the gross tumor volume, depending on the compression on the brainstem and the chiasm, does make a difference, and you have to keep it in mind. That's the point I was trying to make. This was another case example of a young lady. Clival chordoma was actually treated with surgery with gamma knife. Very soon, after a few years, was initially observed. There was a large recurrence. And when she came to me, sometimes the feeling is, your first center in India, you get so many patients referred for proton therapy, but there's just large tumor sitting out there as if the proton is going to take care of it. So as I was mentioning, between 15 to 25% of the patients undergo actually a second resection. And we have managed to put in place a fantastic skull-based team from the neurosurgical department and the head and neck department with endoscopist, with a series of, especially with the metal and many other things in place. And this is our protocol with a reasonably large number of patients treated now. Many of them have several surgeries. These are our dose tiers. Dr. Srinivas was mentioning the EQG2 has actually to be about 76 GY. The dose to tier and the lower CTV has to be anywhere between 56 to 64, depending upon the compression, and these are our dose tolerance limits. So far, of course, I can't even claim anything because the follow-up is ridiculously low, but so far only one recurrence so far we had, and that recurrence was exactly where we tried to, where the patient refused second surgery, and we compromised on the dose towards the brainstem, and there's exactly where near the spinal cord and brainstem, and there's again the recurrence took place. So we are keeping a close watch on a prospective trial for all these patients. We also had two pieces of good evidence that we realized that the shrinkage is very slow, as we know for all benign tumors, and therefore we devised T1 perfusion protocol, which has been very, very good. And that has been helping us even if there is no anatomical shrinkage, but the perfusion values from the T1 perfusion, not the classic T2 perfusion, and we are collecting the data meticulously. Two pieces of other papers we have, of course, have the challenges of metal implants because the positive charge proton doesn't like the metal, but we try to do it. It's not so difficult now using the SIMR and other algorithms, and we have the MVCT on tomotherapy as well, which helps us to look at that. Our physics team devised a novel, completely first time in the world, a 3D construction model, and it was primarily on base of skull chordomas. And this was published. It's quite a feat to publish in physics and medicine and biology, PMB, and that was quite interesting as well from our center. You just heard about craniopharyngioma. I just want to show you two data sets. To my mind, this is the best data so far for fractionated conformal stereotactic radiotherapy from St. Jude's Duke, and 100 odd patients, 96% 10-year survival. And if you look at radiosurgery or look at that data, that's PFS is not very good because you keep on treating them with surgery and radiosurgery. This is upfront, fractionated, whole volume, wherever it has to be treated, and that's quite interesting. But they were also very good intellectual honesty because you could see the permanent neurological deficit was as high as 8.2%. And that was, and vasculopathies as well. So there is clearly room for improvement, both from surgical series, but as well as from radiation series. Our own series from Tata Memorial Hospital, which I spent most of my career with a median follow-up of 5.2 years, not 10 years so far. The survival was pretty good as well, about 96% using fractionated stereotactic conformal radiotherapy. So the first patient, I think somebody mentioned, the first proton therapy patient in India was for craniopharyngioma. As was also mentioned by the previous speaker, we have to be extremely careful about the change in the dynamics of the cyst Also, the beam arrangement makes a difference. You don't want to go through the shunt. You have to look at where the cystic areas is or to the cavities, and that is very, very important. And we have seen the dynamics of cyst. And interestingly, what I have also realized that we were always worried about the cystic change in radiation. Somehow it seems, although we have not analyzed the data, the numbers is relatively very small, we have seen that some of the cysts also shrink. And it's been a little bit better experience with proton, as was my experience with stereotactic conformal radiotherapy using photons. Just to show you also that we adopted the craniospinal radiation in our practice very soon. I think 4th or 5th patient was the CSI patient. We have treated close to about 80 to 90 patients. And there are 3 sets of publications looking at both the clinical outcomes, the dosimetric outcomes, and our own unique using some Python scripting in our hospital, in our center, to use robustly optimized plans for craniospinal radiation, which, as you know, is one of the most challenging areas of treatment. But we also know that this actually is a very good candidate for proton therapy because significant reduction of the low dose volume wash and many other factors. Intracranial germ cell tumors, again, a very good indication. This was a germ cell tumor. We published our initial series, and you do know only the whole ventricular radiation, but then you always wonder what will happen to the hippocampi, to the temporal lobe, because cognition was very important. This is just an example of this young lady who we treated with a germ tumor. I think this was among our first patients. In 2020, and you can see she has done extremely well academically. She actually stood 3rd in the entire district, scoring 593 marks out of 600. We wonder how she missed those 7 marks. And only about few weeks ago, 2 weeks ago, I had the pleasure of seeing her again in the clinic, and she has grown taller than me and definitely smarter than me in terms of her IQ. We discussed about the meningiomas, the grade 1 meningiomas. We still tend to do 3 to 5 fractions if they are relatively small, but as soon as the meningiomas are relatively large, and Dr. Chernow was asking that, and then we would use them 50 to 54 gray fractionated. The trouble is that if you do wide field radiation with a conventional, you end up with a lot of toxicity. But proton gives you that luxury that you can be really very tight, and yet you have the luxury of the fractionation, which can be very safe, both to the particularly to the optic chiasm and the brainstem, and sometimes to the other cranial nerves as well. But as far as the grade 2 and grade 3 are concerned, they are the ones we are struggling with. And then you also see, as I was mentioning yesterday, or just this morning, you get this very difficult NF2-related meningiomas all over the place. The meningiomatosis, impossible to cover in the single fraction or fractionated SRS, and you always don't want to do them IMRT because you end up with a lot of radiation to the normal brain, and these are some of the cases that we have dealt with, both NF and non-NF2 as well. And then you can see there are 2 dose escalation studies being done, along with actually immune checkpoint inhibitors using avelumab. I'm not sure whether these trials are still ongoing. I was trying to look at the literature 2 days ago. Some of the trials have started and not done accrual so well, but some of these things can be exploited with the advantage of the particle beam therapy. As I was mentioning, just a case example of a very complex, difficult, recurrent, many times operated upon atypical meningiomas, and this is the type of dose distributions that you get in a fractionated treatment. You can do it with multi-session radiosurgery, but almost the same plan can be achieved with proton therapy, and yet you do the fractionation to get the advantage of the fractionation as you would get in conventional manner, which of course you cannot get in the IMRT era. We have had 2 protocols on vestibular schwannoma. My colleagues, Dr. Srinivas and Dr. Shankar, are here. We do very small, like you do everyone else. There is very little difference to choose between gamma knife, cyber knife, or proton therapy if it is less than 1.5 centimeter or so. But as soon as it hits more than 2, 2.5, 3 centimeters, we see that there is some advantage in terms of sparing, and this is one of the cases that we have treated on 25 in 5. You can see this beginning of the black hole, the central necrosis occurring, and as soon as the tumor is more than 3.5 centimeter, and sometimes recurrent setting or even the primary setting where the patient is absolutely doesn't want surgery and has good preserved hearing and serviceable, we have adopted many of these vestibular schwannomas to about 48 to 50 gray using conventional fractionation, and yet using the proton IMPT such that they have the advantage of the both. And then a little bit about the gliomas, because we haven't discussed so much gliomas these 2 days, but because we have tried gliomas and it hasn't really failed. And one of the criticisms of all these, especially when you talk about neurosurgery and radiosurgery, it's all right because we can understand each other's emotions. But all of us know that when we talk about all these high-tech, fairly expensive technologies, and you talk to your healthcare planners, you talk to medical oncology community, you talk to general oncology, you talk in ASCO or ASMO, we are always criticized that you don't have level 1 evidence, and always the level evidence is level 2, level 3, level 4, or anecdotal. So it's very hard to generate level 1 evidence for high precision surgery and high precision radiation. And this was again, which was tested 20 years ago, and unfortunately was a negative result because actually the patients who got the radiosurgery boost had actually slightly worse prognosis. So when I returned to Tata Memorial in the year 2001, we had only 2 slots to use stereotaxy, and that was because we're a busy hospital. So we decided to a randomized prospective trial in children and young adults, looking at the most important primary endpoint of neuropsychological, cognitive, neuroendocrine, neurological dysfunction with a secondary endpoint of survival. Mind you, the senior people in the audience would bear with me. Even that time we had a fear in late 90s that there could be actually more recurrences because we are so tight. And nowadays, of course, we know that's not a problem, but that time also, therefore, the survival was the secondary endpoint. We needed 200 odd patients to have the appropriate statistical power to detect a meaningful difference to the most important endpoint of the cognition and endocrine deficit. So actually speaking, stereotaxy has given to the world perhaps the only level 1 evidence of high precision radiation, and that comes from stereotactic radiotherapy, even if it is fractionated. So this is the paper that we published a few years ago, stereotactic conformal radiotherapy versus conventional radiotherapy. There was a significant difference both in terms of neurocognitive outcome, superiority, but also distinct difference in neuroendocrine deficits in favor of high precision stereotactic radiotherapy. And we also looked at the dose response constraints to the pituitary hypothalamic axis, and does provide to some extent a high level of evidence for high precision radiotherapy. In other words, whatever you see on the computer in terms of dosimetric superiority, we could demonstrate can be actually translated in the patient in the clinic, maintaining their quality of life and long-term survivorship. These are the 2, to my knowledge, probably a good data sets for cognition. This comes from St. Jude Data Group. Again, they have been marvelous in collecting the data so meticulously, 54 GY. It's a large data set for a very good number of patients, 80 odd patients with 9.8 years follow-up, and the hippocampi dose constraint is both from the right side and left side is about V40. And our data set was published roughly about the same time in neuro-oncology. It was a smaller subset of only 48 patients, and we had data set of only 5 years. But this, it seems that this is the only study which has actually a prospective series, both at the baseline. We didn't have so many series, do not have a baseline before surgery or before radiation, but we did have a prospective data neurocognitive outcome baseline, and we kept on looking after treating them with stereotactic SRT, and then we showed that the dose constraint to the hippocampus in a fractured manner is about 30 gray or so. And finally, I want to finish with glioblastoma, and this has been the most difficult disease, and whatever you do, even this what I'm showing you, I am not sure whether it make any difference. GBM really means GBM, but there is some interesting data sets, and I was discussing with somebody yesterday, but we always thought that we used to see this lymphopenia, and we always associate with temozolomide, and we know that lymphopenia is very important from oncology perspective, whether it is esophagus, whether it is pelvis, whether it is even hematological malignancies. And Ski Grossman from Johns Hopkins used to talk to me, 10 years ago in SNOW meetings, and he used to always tell me that it is the radiation. I used to say, come on, it is temozolomide, you are a medical oncologist. But it turns out that actually it is because of the radiation. So the radiation, when it flows and you have a large volume, the lymphocytes get exposed, and that causes lymphopenia. And there is this we know this randomized trial which was published, there is no difference in the survival, but there is a difference in terms of significantly better lymphopenia. And interestingly, the first author in this actually is a physicist, Radhe Mohan, who is the chief of physics in MD Anderson. And the second is Paul Brown, and he showed that definitely there is improvement in the fatigue and some of the quality of life parameters. So in our center, this is our first Indian series. We collected the data as in gliomas. In a similar cohort, we couldn't do a randomized trial, but we tried to match the patients. First of all, it was clear that the V20 and V25 was associated both in the proton beam therapy, and we have a helical tomotherapy, that there was, it correlated with the severity of lymphopenia. But what was interestingly, the proton therapy, because it can reduce the volume of normal dose of normal brain, it actually had lesser lymphopenia. But ultimately it is the survival. So we did look at the survival as well. And both, as I said, any grade lymphopenia, especially the grade 3 lymphopenia, which is actually most important, was significantly lesser. And then we did show that there was some improvement in PFS in the proton therapy series. So this is very interesting thought, and this is being studied in at least 2 or 3 studies. The BN001 is actually escalating the doses to 75 GY, but they are looking at CD4 and lymphopenia as well, and looking at progression and pseudo-progression. There was also a photon arm which did not show any difference, but we are waiting for the data to mature from the proton therapy. For the carbon ion, of course, they are looking at Cleopatra, which is the primary GBM, and they want to escalate the doses of giving the standard after the standard arm to about 18 gray and 6 fractions as a dose escalation studies. And this can be possible only in particle beam therapy. For the recurrent gliomas, they have a different study comparing with fractionated stereotactic radiotherapy. In a recurrent setting, we discussed there is a role in gliomas, and it's called a Cinderella trial. It's done from Germany, and we are waiting for the data sets to emerge from that as well. As we discussed briefly, there is also, and I am particularly very excited about the role of stereotaxy and radiation and particle beam therapy with synergistic action with immunotherapy, because we know that some of the tumors, especially in the brain, but other sites as well, that can act as the tumor cell kill from the relatively high doses of particle beam therapy, especially if you give in a hypofractionated manner, in an FRs, hypofractionated stereotactic SRS or SRT, so as to speak. And then you, of course, have the advantage of sparing the T cell reservoirs, whether it is the Wardier's ring, whether it is the microbiome, whether it is the lymphocytes, whether it is in any part of the body, and including in the brain. So a combination of that can trigger a mount at immune response, and then you of course have the innate immunity there as well, as such that you can do a combinatorial approach, and this is very exciting to me, and the whole concept is going to change in the next 5 to 10 years. Finally, there is always a difference in the cost. We know there are several economic models. While the initial cost is very high, but in left-sided breast cancer, in many pediatric cancers, in many CNS tumors, actually eventually that there is cost effectiveness, because the ability of that child or of the patient when he grows, he has the function, he has the intellectual function, he has the endocrine function, the growth is normal, IQ is preserved, less dependency on growth hormone and adverse events. So actually they are contributing meaningfully to the society, so it is cost effective from a societal point of view. Dr. Srinivas and I, we have debated so many times, then how do we make the world to realize that proton therapy and LMIC is also justified, as is radiosurgery. Same debate used to happen 10, 15 years ago. Why you need gamma knives in India? Why do you need cyber knives in our countries when you don't have regular Linacs? And how do you pitch together to design a collaborative study? And but we were not sure this will get accepted, but did get accepted as a commentary piece in JCO's Global Oncology, and we have argued from an ethical point of view and effectively actually as a cost-effective model as well, that the proton therapy can be eventually effective. And last couple of slides are how to, because one of the topics was how to move forward in future. We are extremely cognizant about the cost, as one we should be. So we are trying to reduce the footprint in the particle beam therapy. There is a new model of Mevion where the proton will be mounted, the cyclotron will be mounted on the gantry, which is called a gantry mounted cyclotron. So it will be a very small, like you saw the Zapex on a metro station. Who knows, you might have a proton therapy on a metro station or somewhere as well. The spot scanning proton arc therapy is very exciting and is integrating the MRI on proton therapy. We also realized that we have to put the aperture in, reduce the penumbra on the pencil beam, and we are working on it. So if you put the aperture on the penumbra, that would be the ultimate in proton radiosurgery. There could be a renaissance of proton radiosurgery because you have the pencil beam, you have the Monte Carlo, you have the image guidance, and then you have the ability of the imaging, and then you chip, you take off the dactyl penumbra by the what we used to do in passive scattering, and that is very, very interesting. And finally, of course, the flash. Now, if the flash comes, the whole world is going to change. The radiosurgery, whether you do functional, because the radiation is going to be given in milliseconds with no side effects. If it does happen, we will completely, I think we'll lose our jobs. I don't know what we will do. And with that, I want to acknowledge the whole Apollo family, my colleagues in Tata Memorial, the cancer management teams, enormous gratitude to radiation and medical physics, the nursing team, care coordinators, clinical research secretariat, international, national colleagues, Apollo leadership, management, and a wonderful audience like you, my chairpersons, and the organizers of this meeting.
Thank you very much, Professor Jalali, for wonderful talk. We are extremely limited in time, but we can get 2 or 3 questions or comments. Okay, I have a very simple question. Don't you know why Cinderella and Cleopatra trials took so long time? I think they were initiated around 6 or 7 years ago and still not completed.
I think they were very ambitious when they put up the carbon, and they tried to do it, but then they realized also perhaps it's not so simple, and they were also hoping the other centers would participate as well. But as we know, there is literally very few centers getting carbon, and the whole enthusiasm, even we feel we are even struggling with proton uncertainty. I'll be extremely careful to use the carbon, and you may have more experience than me in Japan in carbon, so I think that is one of the reasons why, and in general, the dose escalation philosophy has not really worked in GBM. So all these have been little dampeners in accrual.
Thank you very much for, of course, thank you very much for highlighting the importance of proton in improving the therapeutic ratio and also in re-radiation, etc. But I just wanted to ask you, do you have any specific protocols for say histopathological subtypes like HER2 positive brain metastasis, adenoid cystic carcinoma, brain metastasis, etc., where they are a bit different when compared to their counterparts?
So there is no different protocol per se with proton, but Rupesh and I were discussing about it, that different biologies may sometimes tweak your philosophy of radiosurgery. Like, for example, the HER2 positive, when they are post-operative, I was just mentioning, they are relatively high to develop geographical, intracranial failures away from the local site, whether you should be a little bit more generous, especially in the cavity, and so on and so forth, and also perhaps in TNBC. But if it's a small tumor with long DFI, we don't care, we just treat with radiosurgery. Maybe the compliance and the threshold of repeating imaging could be lower because you can pick up the disease very early. So therefore, that is the second thing. The only positive thing, however, with the context that you asked, is this fascinating data of Memorial Sloan Kettering, where we showed that the proton CSI in leptomeningeal metastasis is significantly better in terms of survival and local control as compared to local therapy conventional. There's a phase 2 randomized trial which was presented in ASCO last year in plenary and is published in JCO. Even we have treated about 10 to 12 patients, I think, Srinivas, 10 to 12 patients of proton CSI. And I have to tell you, we used to struggle so much with the photon CSI, and proton CSI is significantly better to manage. But we don't give 13-10, what they did. I give 35 in 15 to give a little bit more fractionation with a lesser dose because they have been heavily pre-treated, so their tolerance becomes a little bit better.
Dr. Jalali, thank you for the excellent talk. The lymphopenia study that you showed, the amount of radiation that is spilling over into the brain is hardly much to cause ablation of a bone marrow, or there's no major vessel there. So how would proton therapy reduce the lymphopenia? I'm just wondering.
These are the circulating lymphocytes through the blood vessels. It's not the bone marrow. So it is the because the blood flows everywhere, right, in the brain. So when you are irradiating for those 2-3 minutes, the circulating lymphocytes get irradiated, and that causes lymphopenia. So in the conventional radiation, especially with IMRT VMAT, where there is a very large volume of low dose, because the whole brain literally gets low dose wash, 10, 15 gray, that is enough to cause lymphopenia. And that was the revelation that we had. The proton therapy limits that low dose to intermediate wash, so the lymphopenia is less, Whether it translates into survival, we don't know. That's being investigated. But it's a brilliant proof of principle study, that we have done, and the Americans are trying to test in a randomized fashion.
And it's actually, sorry.
Okay,
so
so,
it's specifically,
okay.
it's specifically actually the V5 up to the V40. It's actually not the V40 in higher doses. It is specifically the lower doses that are associated with lymphopenia risk. And then separately, lymphopenia is associated with survival.
That's right.
So when you connect the two of them, that's the the thought process, and that's why for GBM patients we have this back and forth, especially for the MGMT methylated patients who are now going to get temozolomide plus lomustine, which is already going to cause lymphopenia. Are those patients we should select for proton therapy? I wrote the guidelines for proton therapy for brain tumors. They'll be coming out in neuro-oncology, and that's one of the subset of patients. If they're going to get double modality, I think that's the only patient you would think about as a high-grade glioma. Otherwise, there's no benefit right now.
So we do as well. We select, not all GBMs, of course not, but some patients, especially if they have molecular favorable grade 4 IDH mutant astros and methylated. Having said that, that trial has significant issues of the combining temozolomide and lomustine, all the published in the Lancet.
It's being repeated.
So we have actually stopped doing that. I did some patients and we stopped it.
We have not done it off trial because we ran into issues as well. So it's being repeated on trial on BN011. For the NRG trial with the proton dose escalation, we still don't have results yet. And actually, we just had the NRG meeting. It's because there have not been enough events yet for them to report out, which is very interesting.
In the proton arm? That's music to my ears.
So we don't know what the final results will show, but they, as of July, they did not have enough events to actually report out that arm. So we don't know if
not having any events in GBM? That's
Okay, I'm very sorry, but we're extremely limited in time. Many thanks again for this great presentation. And since I have this microphone in my hands, I wish to make a very short announcement specifically for neurosurgeons. If you will not come tomorrow here, please take your certificates. They're ready, and they're very beautiful.
We have come to the final plenary lecture of the day on radiobiology of high doses, modeling of SBRT, SRS and SRT. Moderators for the session includes Dr. Mariadas, medical physicist, Medanta Hospital, Lucknow, and Dr. Anak CH, chief medical physicist, Amrita Institute of Medical Science, Kochi. I request a moderator to introduce the speaker.
Good evening all. We are running out of time, but here Dr. Rajesh Kinigar is our speaker for this topic on radiobiology of high doses, modeling of SPRT, SRT and SRS.
Just an announcement. I also request all to do the feedback forms that have been, the online link that has been sent in the groups, so that that is also required as part of the ISRS meeting. Please, sir.
Very good evening, and thank you, Chairperson, the organizers, and ISRS as well. We had a very heavy lecture, I mean heavy by a particle, and you made me MS Dhoni to finish the talk within so much less time. Definitely, I would not take it heavy, and I should be able to cover as early as possible. Okay, so this talk I will try to cover 60 to 70% with the review of literatures, with various documentation and the publications, with the fractionation. We already have heard enough and adequate for the different sites as well. I would just like to put a few seconds on this slide. We had the medical physics contribution to the community, and we are listening to these technologies. Definitely the contribution from medical physics is tremendous and definitely is to be encouraged. So this is available on the website. So with such a beauty of the Kochi and the Kerala, let us go through the topic of the radiology as such. with the background for the review, some review literature with the take-home message, we'll try to see that. I will definitely skip many of the slides because the expert talks has been given, and we need to have a look at, particularly for the students and all those who are now entering into the field, and those who wants to move from the paradigm shift from a conventional, conformal, and then stereotactic and so on. So definitely the substantial dose escalation of the tumor is the core topic of this subject, and taking care of the different technology as well. We had been listening to the LQ model. Whenever the radiobiology comes in the picture, we always hear the LQ model. Does it holds good for the different fractionations, and SRS, SRT, SBRT will definitely have to look at. So there in the literature, if you review, there are arguments, in the sense the scientific arguments with the different publications or debates and particularly, and the core theme is basically the damage to the vasculature, and which is not accounted in the LQ model as such. On the contrary, there are a couple of literatures. As you know, one of the speakers always told that if I have to debate on a side, I can debate it on the other side as well. So definitely the argument with the fractionations also were equivalent compared to the single fraction as well. The question again in one of from the literatures that these tumoricidal mechanisms at high dose per fraction are the same at the lower doses, or are there any new mechanisms happening, particularly specifically at high doses? Again, we need to take a different boat at the safer side. As we know from the backwaters the boat will go, we have to be safer as on. Starting with the literatures and getting the answers to these literatures, definitely we need a strong evidence from by the follow-up or whatever the expertise, etc. And we need to go back maybe a half decade, 2 decades, or 1.5 decades that way. So the one of the literature, the high dose fractionation, etc., which is mentioned on the screen, what do? The large data sets with the tumor control probability, and it has been reported from the stereotactic radiotherapy as such. They referred basic 3 models. I will not go much into detail. This paper is available as I mentioned in the slide. So it is not specifically distinct tumoricidal mechanism. LQ model, which is linear one, the universal survival curves which are usually referred, and the paid linear quadratic formalisms. They are extensively discussed in this literature, and particularly with the formalism and everything. I request everyone to go through that. So these models, what do basically assume? The homogeneous tumor sensitivity, though they are amenable to extension, including the heterogeneous radiosensitivity as well. And they also mention about the single fraction, multifraction, the BD, and other aspects as well. So in this, they concluded with the tumor control data as such, which is very much important to look into the criteria. Now, another paper, again, I did not put a more focus on photon or proton as such. Once the radiobiology comes, we have heard, but we need to wait for some time for the proton to come up with the follow-up and other thing. So this technology review of SRS delivery, including the linear, cyberknife, and different technology we heard from the specific speakers. They discuss about the radiobiology of SRS, particularly with the OER. Again, going back to the students, we read this, the oxygen enhancement ratios and the dose response relationship. These are coming from the radiobiology. They're very important. What are the cells, the hypoxic, their attention in the different phase cycles of the cell cycle is very important with that. Coming to the radiobiology again, which spares the late reacting healthy tissues, and also a more effective cell killing takes place. We already heard from the eminent speaker as such. So as the OER is higher, definitely there will be regimes and which way have the benefits as well. However, the rationale for this is the radiobiological effect of a single fraction or a multiple fraction, and that it may be due to the cell kill or the loss of the cell division, which capabilities and other regardless for the mitotic phase as such. We should not forget about the dosimetrical feature. Wordly meaning is not basically the dosimetry I have to perform on the machine. The dosimetry indices, I mean to say that. So these has to be, usually is referred in the paper as a specificity and a selectivity. What do they mean? Is precision and conformal dose planning is very important. Role of individual human being is the professional, individual skilled professional is very important. Selectivity refers to the biological difference to the response of the different tissues. Again, it is very much important. So being a physicist, we need to enter into the clinical physicist and maybe a radiobiological physicist as such, having more interaction with the radiation oncologist and maybe a radiologist and the different people in the streamline along with. Sometimes we do see in Tata Hospital that the surgeons as well, they come, and Dr. Shankar will agree with that. So it is a good discussion, always having a good interaction with that. This paper will tell about again the vascular damage. I will not go much into the detail for the CNS systems. I probably not put this slide because the next slide will, because the students have learned about the 5 Rs. But the review of literature starts from when there was a 4 Rs and the different capabilities, repopulation and all. So there was also one of the good paper which is in the literature. So the tumor radiobiology of these SRS, SRT and SBRT are there more than 5 R. We also read about 5 Rs. So what are those 5 Rs is mentioned about this. So we know these 5 Rs, and apart from that, are there any efficacy of the high doses, particularly the advances is image guidance. The LQ model may not be accurately modeled or accurately fitting to the regime what you are practicing. Also the anti-tumor effects. I think 1 or 2 lectures we heard from the speakers that the effects were very important for the higher radiation facilities. And the many tumors may not be a hypoxia. Again, it is going back to the hypoxic regime of the patients. So the question comes again back, is the LQ model adequate to describe the cell killing at high doses and all? So this particular paper concluded the range of the dose to be delivered from 1.8 to 20 gray. It will depend on different regimes and different critical conditions, clinical conditions as such. And as already the speakers has mentioned that with proton, Dr. Jalali has mentioned that the CSI, they were very cautious to go with a little bit lesser dose per fraction as to take a call on the effects. So the biological challenges with these 5 Rs with SRS, SBRT, definitely we already heard the endothelial cell damage, vascular damage, and the enhanced anti-tumor immunity after the tumor irradiations. So basically the tumor control probability, NTCP, these are models now already fit into the planning systems. Alone as a physicist, probably we will not be able to take it ahead unless and until we know the radiobiology, it's the cell kinetics and the parameter to be fit into the planning system for your proliferation and the impact to give the equivalent dose distributions what we are practicing. We need to sit with the concerned clinician and to understand and do some plans as well as to have compared. This paper already has been displayed, and I will not go back basically. So radiosurgery, the fractionation quandary, a single fraction or hypofractionation, and the conclusion was that it is not there is no significant difference as such. Same paper has been referred. When you say BED, LQ model, does the BED holds good truly for SRS, SRT, or SBRTs may not be true 100% as well. So this paper very well refers to about the BEDs and the other parameters as such. This table, I probably remember that one of the speakers has shown it, depending on the single fraction versus the fractionated regimes. And the left side of the table, you can see the different parameters of assessment has been referred to. So this basically has, and I did not go, a lot of clinical trials has been reported from the literature, and if you want to refer those clinical trials, you can go back to those publications as well. This conclusion with the hypofractionation and the more or with the single fraction, significant impact was not noted as such. The question comes to, again, this tumor or endothelial cells are the main radiobiological target or the antigen-induced damage and the immune response. So that's why probably now the next era would be the immunotherapy. It is slowly evolving with a cautious, and probably another 10 years on the line, we may have adequate literature, adequate experience of the people in the mind. Again, there is a good paper that what should be the optimal fractionation as such, and you could see that there are the fractionation we already heard, 3 to 5 or 3 to 6 would be an optimal fractionation depending on the case management side. for the particular the youngster and the students and those who are entering into the field, this is one of the very good paper again. To have, we are used to calculate the BED and the formulism entering into the total dose or dose per fraction. Please review this paper, and it is very important paper for mentioning. Again, what is assessment? Like if you are controlling, assessing the local control rates, etc., and we have seen through the eminent speakers particularly, the dose fractionation into the number of fractions, particularly the BED of 10 grade equivalent, which, and what is our expectation as a physicist is always 100%. Is it clinically acceptable? What is the patient expecting? That morning we heard a very good lecture. It's very important that what patient outcomes and what are they assessing is very important. We need to look at. And this paper also had concluded around 6 to 8 fractions better. Probably the new evolution has come up, and definitely it is very important aspect of that. With the editorial on the SBRTs, particularly the extracranial regions, there are a couple of papers, and we also have read, probably the people have given 18 grain single fraction, and one has to be very cautious depending on the response, etc. Of course, the physicist has to interact with the clinician and the follow-ups, and I would request the physicist to proactively interact with the clinician, whether that patient had a follow-up, what was the follow-up, and etc. That's difficult, but probably that's good practice to start with. It's an important thing. Many of the publications that has been referred there, basically the novel approaches and other things. I will just rush those slides. Now, definitely the question is, what is the sky? Is the limit? How low can you go? And this paper is very good. I literally referred it and reviewed. Took some of the points, like sometimes I may not read the aspects of where there is no physics, but definitely. So what are the clinical considerations for the hypofractioners? And they have listed everything. I just took out probably the toxicities, acute and late, the tumor control, the overall treatment time, and the EQD2, we always heard about this, the non-isoeffective EQD doses, and the rest of the things, immune-mediated cell kill, etc. It's a very good paper as such in this one. Having said about the radiobiology, the different fractionations, single fractionations, interactions, is it only radiobiology as a team? Now this journey will be towards as a team member. What is about the system, QA and the precision? I mean, the system is entire as the patient enters into the hospital and then comes for a follow-up with a smile. So definitely we need to look at into the immobilization, positioning systems, and we heard if there is a precise system, perfect immobilization, probably the clinicians will not give a margin at all. Then responsibility comes on a physicist to be very precise, confident about the beam delivery and the systems itself. Imaging modalities, the dual energy CTs have come up, and the MR and the functional MR and so on. Registration algorithm, try to understand that. This registration algorithm also has a factor with the display of the monitor which you are using it. The monitor which we see, they are high-grade monitors, high-grade clinical monitors in the radiology department, but may not be the same in the radiotherapy department. And probably that also may have an impact of the lot of parameters. Then comes the linear assisted or the technology delivery, the double F, triple F, again, the 6 triple F, 10 triple F. So we had a couple of studies in that, what would be the best optimal the energy assessment. Calculation algorithm, we knew the Monte Carlo or equivalent. Are there any better? If there is a flash therapy, again, will there be a different technology of algorithms? Is my QA device capable to grab that much 45 gray per second dose rate to that much capacity? We need to look into it. I already spoke about the display monitors. The CT, CBCT, KV, MV, HU caliber. This question is generally asked. Can I calculate and use my CBCT for planning? Of course, yes. Look into it, calibrate your own HU density curve and use it. Try for some 5-6 cases and then compare it and use it. QA devices, particularly you need to look at the spatial resolution related to the theme, SRS, SRT, SBRTs. You know, you will be treating a 1 cc volume. Even the lateral radius, you will not be able to measure at all. So there the spatial resolution is very important, and there are a lot of evolution in the QA devices system. Motion management, of course, every technology will evolve. That will be a prototype or beta. Then they will evolve in the image, the motion management, and then the remaining aspects. Very important, probably not been addressed, the big data management is going to be a big trouble for everyone now. And we just have a very simple answer is a cloud. Think of it, its cloud is a cloud. Definitely we need to have, where is my data? Is it secure? Yes, of course it's secure. We need to change the mindsets that my data has to be. So the physical systems, hardwares are going to disappear from the department now very soon, and we need to think of this big data. The question again will go to the clinicians, how long do we preserve the clinical data? 5 years, 10 years? I got only one paper probably that says 10 years. So that is very important again. We also had, and think about the planning system. We are very fascinated to do a wonderful plan, 95%, or whatever the prescription. Is my planning system capable? So fairly, I will not name any planning system, but understand the system up to what minimum field size your machine can deliver the radiation. Is that field size is being configured into a planning system? If not, ultimately you say my patient-specific QA passes. So you are treating patient. That will reflected in the follow-ups. By chance it comes with a recurrence that Dr. Jalali has mentioned. They left an underdose, and particularly there they got a patient come back. Was it due to our QA? Was it due to some other? So this is the thing, probably we need to look into it. So the configuration of the planning system, beam modeling, its accuracy, and the output factors for a smallest field size will be 40% underestimated. Think of that variation when you deliver a single fraction dose. It's very important to look into it. Total scatter factor with if you are using a cones, stereotactic cones. And Suresh is sitting here. We did a plastic scintillator study with this. Though we did not use these cones for a clinical treatment, but as a physician, we should be ready always. We don't know when the patient will come. That much requirement, and am I ready with my physics data as such? Again, I was a part of IEA AAPM TRS-483 group, and we concluded for 3 years. This was a collaborative multi-institutional study, and they collected the data that what planning system, what are the factors, and finally the validation. They sent us the TLDs, OSLDs, and the films, and we could publish this work as such. We also had, coming from the cranial to extracranial, that lung SBRTs, and 7.5 into 8, we did it. Probably the dose per fractionation or the energy. So that was also important, and we did that study. This was already shown, I think, I don't know, but the practice patterns and perspective, particularly in the low middle income countries, it's very important, the spine SBRT, and this paper from the center. We also wrote to one of the article which says about the effectiveness of the robust optimization, and this paper particularly tells about the 6 and 10 MV FF beams. So we discussed again, and we reviewed the literature, what is the optimal energy. And this paper, we wrote to the editor with this one, and we showed it that the 6 FFF may be an appropriate choice for a lung SBRT of 7.5 into 8, with all the parameters kept into mind, comparable to the 10 MV, 10 FFF as well. Because we are fascinated towards the high dose rate. My objective is the patient should spend lesser and lesser time on the couch, so that everything is taken care of about the motion management as such. To conclude, definitely we should understand the radiobiological issues, and they are still imperfect. Mastering the radiobiology definitely needs in-depth knowledge. We need to move to a different regime, different topic as such, and it has to be sustained with a quality care. It also needs a critical review. Don't leave the reading at all. Wherever you are, you have the mobile in your hand. Just you Google and read any literature. You will come many literatures with those branches as well. We also need to understand the technology which is driven. As we were seeing, every technology shows a very good response as such, whether it is cyber knife, gamma knife, Zapex, or proton or photon. Understand the technology in depth, limitations, master those technologies and transfer it to the concerned team. This is very important. Pros and cons has to be studied. Definitely, if you are alone, encourage yourself to interact with the team and your colleagues in the different centers and all. Discuss with them. That is very important. Follow-up definitely is a key. This follow-up is, again, I will leave it to the clinicians, but not only the clinicians. We need also to follow up with them. What happened to the patient, which I planned maybe 2 years ago or whatever it that be. And the learning is definitely important. With my great thanks to the society, the organizing team, which probably might have not slept nights, and the experts in the meeting, I attended very seriously. I took a lot of notes from those lectures, which I still learning, and the delegates. Without you, which is definitely the meeting is incomplete, and everyone which probably I have missed. Thank you again, and be safe. Thank you so much.
Thank you, Dr. Rajesh Kinikar, on the topic on radiobiology of high doses, modeling of SPRT, SRT, and SRS. Is open for discussion.
That's what you made me probably Dhoni to finish the match.
Last hour.
Where already the saturation is achieved. Yes.
Oh. So definitely there is a variation in the time, beam on time on the tumor. So what we have seen clinically is a greater impact of unflat beams over flat beams. I'm not really sure, applying the current LQ model or the USC model, we are able to show any radiobiologic superiority versus the clinical effect which we are getting. I would like to listen to your comments on this.
Yes, I again went back to the literature and all. They correlate with the double F and versus triple F with the interplay effect of the MLC deliveries. That is what the positional accuracy is very important. And yesterday, the first lecture, Dr. Kataria madam has mentioned, you are deserving the accuracy or expecting the accuracy less than a millimeter, 0.3 millimeters or 0.2 MUs, the difference, which we can't measure at all. So that accuracy has to be maintained. So interplay effect, the positional accuracy of the MLCs is very important. But I probably slightly disagree with that. The 6FFF will give definitely a benefit if your tumor also has a motion into effect. Probably the cranial, you say that immobilization is perfect. 6FFF, depending on what dose rate you're using and what energy is using, 6FFF will probably be beneficial. I could not get much literature with the 6FFF beam as such, very comparably. Yes.
Silly question actually. Silly in the sense that when we say the brain is motionless, you have to understand there's a pulsation in the brain which goes on. I mean, as a neurosurgeon, when you open the brain, you can see the pulsation up and down. And it's an atrophic brain, there's enough space for the brain to jump around. So when we use that word that we are motionless in gamma knife and things like that, I asked that question to myself.
Yeah, but Dr. Shankar itself told that probably that there is a motion and with the jaw movement, and like Dr. Shankar can.
It's the jaw movement is different, but in the brain, the brain is always pulsating actually in the skull. Yes. It's not static.
Yes.
It's not static. It is pulsating. So, and 1 or 2 millimeter pulsation definitely is there. Variation is there in the target. So, I don't know. Brainstem might be a fixed structure.
Brainstem is typically less than a millimeter. So typically the pulsation.
But the cortex in atrophic brain would be jumping 2 millimeters, I believe, definitely.
But even things like the optic chiasm that you think are going to be relatively, not movable, they still move, and it's about 0.5,
and the structure is
0.75.
close to the ventricle. They would be moving a little bit. So that question always comes to my mind.
Yeah.
And with the respiration it moves, and with the pulsation it moves, and okay, heavy particle, is it?
But if you miss the SOBP, the exit dose, probably that if it comes into the SOBP, then it will be a challenge. But Dr. Jalali always used to dream a zero dose to a lesion, and when he treated a patient with a proton, he called me from there. Kinikar, I achieved that 0 dose. That was probably.
And I tell you now, as a surgeon, I'm telling you, when the carbon dioxide level goes up, the brain bulges. When the carbon dioxide level goes down, the brain shrinks.
Yes.
So I don't know.
Maybe the next ISRS meeting we can.
I think the one last part is that although we think about the radiobiology, we just think in the radiation sense. In patients receiving specific therapies like immune checkpoint inhibitor therapies, I think then our radiobiology has to be reevaluated.
Yes.
You know, there's data from preclinical studies that show that maybe hypofractionation is better at not only local response, but potentially inducing a better abscopal response as well. So that's one of the things that we're going to be looking at in our clinical trial, and that's one of the reasons why we're doing it. It's moderate. So yeah, for in the GBM study, so we have a NRG-BN10, which is we're giving atezolizumab, an anti-PD-1, plus tocilizumab, an anti-IL-6. And so the radiosurgery regimen that we're using is 8 gray times 3, because that's kind of that sweet spot where it's you get some immunostimulatory effect. If you give too high of a dose, you actually cause immunosuppression. If you have too low of a dose, you actually also cause immunosuppression, but for different reasons. So therefore, that's kind of the sweet spot dose is 8 gray times 3.
There is one more question. When you're giving a heterogeneous prescription radiosurgery, how do you calculate the biology?
No, that's what I.
The marginal dose or
No, that's what I. One of the slides shows the BED calculation. The BED does not hold good truly. Yes, that's what the paper says that. The first. Yes, that's what it's up to. You need to move from your classical decisions, 95% no, it's 50% prescription, understanding that it's a physics, that means every hot is inside, and that inside will be in a microscopic disease, probably, yes. So the BED calculation, that formula 1 plus alpha by DN doesn't hold good truly for this fractionation or SRS society. That paper clearly says that. Thank you so much. Thank you again.
Session is closed. Thank you.
By Dr. Anup, and then we will move on. Just a short.
As we draw the curtains today, extend our appreciation and heartfelt gratitude to all the faculties, speakers, and delegates for the active participation. Today we had a very extravaganza in terms of knowledge and teachings, and thanks a lot from all of us. And I invite you all to join the party tonight at Bolgati. The gala dinner starts by around 7 o'clock.
No, but we'll have we'll be having travel being arranged by around 6:45. So you'll have all the faculties to Marriott. There's a bus ready down. So now there's a bus down. We'll take you to Marriott, and from Marriott by around 7 o'clock to the venue. Okay. And for all the delegates, there is a bus already ready, which will leave by around 6:45 to the venue.
Yeah, thank you.